We are live and you can start. Please unmute and start.
Good morning, everyone. So we have our second innings today. Yesterday we had wonderful sessions, so very nice education to everyone. And today we have a mixed bag, the potpourri with a galaxy of stars, both international and national. And to start this session, I invite our two moderators, Professor Sarita Bajaj. I think she needs no introduction. She's a well-known figure in India. She's professor of endocrinology at the MNL Hospital in Prayagraj. But on a personal note, let me tell you that she's a magnanimous lady and her greatness lies in her humility and generosity to all her junior colleagues and her students. I must also mention one line that she is the first and the only woman to become president of the RSSDI in India. And she has many other accolades, which I think has been introduced yesterday. The second moderator for today is Dr. Rucha Mehta. Rucha Mehta, I just heard she went on a half marathon yesterday, so she practices what she preaches to her students. She has her own Edmore clinic where she is doing original work in obesity and also ketogenic diets. And she is also a consultant at Apollo Hospital, Ahmedabad. So without wasting much time, ma'am, can I invite Dr. Sarita and Dr. Rucha to take over the session?
Hi, Rucha. Good morning.
Good morning, everybody. Yeah, certainly.
Good morning, and a real early good morning. I think for Vivian, I think the time is nice. It's maybe it's around lunchtime, I think.
Yes, around lunchtime.
Yeah, but for Dr. Hinde, I think it's 6 o'clock in the morning. So a very, very special thank you for joining us, and good morning to Lily. And thank you again. This is an honor to be here. And thank you, Benny, for those very, very kind words. So like Benny said, this is a mixed bag and we have a lot of interesting sessions. I'm sure we've all had girls coming to us with their parents frantic around, especially when at a time they're getting married, that they want to lose weight fast. So this is what Vivian will be talking about, an obese young woman who's getting married in 6 months and she wants a quick fix. So we have Dr. Vivian Lim from Singapore. She's graduated from the National University of Singapore Medical School. She's MRCP UK Masters in Internal Medicine in Singapore and accredited as a specialist in endocrinology, as well as a fellow of the Academy of Medicine Singapore. And of course, she's currently president of the Asian Federation of Endocrine Societies. She sits in the executive committee of the International Society of Endocrinology, president of the Endocrine Metabolic Society of Singapore from 2016 to 18, and she remains in the executive committee of the Osteoporosis Society of Singapore after having held the post of honorary secretary. And we have the upcoming ICE AFIS AOAC in 2022, which will be held in Singapore, and she's the chairperson. She holds the position previously of peer coordinator of Doctors Without Borders in Singapore. Apart from this introduction, and like you can see, she has many accolades to her credit. She's a very, very dear friend. I think this has been the benefit of at least webinars. We've not been able to connect personally, but I think we've developed a good rapport over the web. So Vivian, it's really, really nice to hear you and to see you. You can add life to any meeting. I'm really looking forward to this talk. Over to you, Vivian.
Thank you very, very much. And it's always wonderful to see Dr. Sarita Bajaj, and I have yet to meet you in person. I'll be very, very happy once the borders open to come over personally in India and say a good hello to you guys. And I definitely had to accept, the invitation to this talk and to thank Dr. Sarita Bajra and her entire team and organizing committee for asking me to give this talk. I have to say that this is one of the most interesting and unique topics, titles I have ever been given for a talk, and I was scratching my head for a while there. So without further ado, and I'm tasked to speak about an obese young woman getting married in 6 months and wants a quick fix. Well, these are my disclosures. The world is very small. We know how small it is now when one little virus can hit every single part of the world and cause us to be sharing webinars like this. But, even though it's small, it's also very large and with many different cultures and continents, yet the same thing remains. It's interesting that vast majority of the cultures, when you get married, and let's not be gender biased here, whether males or females, everyone wants to look slim, lean, mean, and pretty. And, and they have all sorts of means to do that. Now, my first thought is great. If my patient walks into my clinic saying such a thing, this is great because this is a compliant patient, just like any gestational diabetes patient, they will just listen to you. Then after that, on second thoughts, the question to ask is this going to affect her negatively for the future? So what am I going to talk about today? Some facts about obesity, what is considered a quick fix? Is it detrimental? And tips on management to ensure that the patient has this best outcome after this quick fix. So some facts on obesity, we don't have to belabor the point. We know the metabolic consequences of this excess weight, and we also know the physical consequences of this excess weight. And the latest, of course, no talk now can be without COVID, would be that it increases the risk of getting COVID, as well as mortality with COVID. Now, just a quick recap for the people out there in the audience. These are our weight classifications, weight divided by height squared, that is BMI, the body mass index. On the left, that is the weight categories, BMI categories for overweight and obesity for WHO. But Asians, we know that we are at a lower BMI, we have higher metabolic risk. So this is more or less for Asians in terms of the metabolic, for the BMIs. Extent of the problem worldwide, basically it's just increasing, doesn't matter which part of the world. This is some data that I dug out, but notice that we are using, this is Indian data, but they're using a BMI of 25 and above, not 23. And between that's always this urban-rural divide that you're going to see, but the total is about a fifth of the population is overweight and a bit obese. Again, this is with a BMI of 25. And if we looked at children, it's the same thing. A fifth of them are overweight and obese. Now, Asians definitely have a significant cardiovascular risk at lower BMIs. I'm from Singapore, and here we have a data from Singapore with our three races, Chinese, Indians, and Malays. And if you look at for females, basically at a BMI of 22 and above, we already see an odds ratio which is higher in terms of cardiovascular risk. Let's look at the males. At the BMI of 20 and above, we already have statistically significant increased odds ratio for cardiovascular risk. Yet we are not putting it at that level. We are saying 23 and above is overweight. But mindful that different across the zones, different races might actually be starting lower. Now let's quickly go into our Miss Quick Fix. So QF here. So she's 23 years old. I was just given that topic, right? So I had to set the age. I had to go Google to see what is the mean age of marriage in India. So I'm not sure whether this is true because it came from Google. I understand it's 22 years old for females in India. In Singapore, it's about 29 years old, pretty old when we got married. So it's 23 years old, gushing and happy, wants to be pretty and slim on the best day of her life. I arbitrarily set her height at 1.55. I'm being very lenient, given that, again, from the web, the mean height I understand from India is 1.52 meters for females. The weight I've put at 70 kilograms, that put her at the BMI of 29.1, and that is already class 1 obesity in where we are from. So let's talk about what is considered a quick fix and is it detrimental. Let's look at the different quick fixes then. So because the topic was 6 months, so I went trawling the net to see whether I could find something about 6 months. No. So let's talk about management of obesity and the gamut of different options that are available for this person, whether or not they're quick fix. But let's say within 6 months, let's see about this bariatric surgery that we see here. They are talking about Roux-en-Y gastric bypass. Aim of the study was to examine the effects of surgically induced weight loss on cardiopulmonary function 6 months after the procedure. What was the weight loss that I wanted to get at 6 months after the procedure? It was 29.8 kilograms after Roux-en-Y gastric bypass in 6 months, and this was associated with a significant reduction of comorbidities, especially diabetes and sedentary lifestyle. Moving on, what about medical diets? What do we get here? Now, in Singapore, we have phentermine, liraglutide, and orlistat. The less said about orlistat, the better. No patients of mine love me at all if I put them on orlistat, and very, very modest weight loss at most. What about phentermine? I don't have data there to give me more than 6 months to a year and lots of side effects. But whereas liraglutide, that's a different thing. FDA just approved hot off the press yesterday at this amount for 10 to 17 years of age, if I'm not wrong, for children. So this would be a very promising drug that's coming out that is already here to be used. There's this 1 year randomized controlled trial. Let's see for that 1 year, what do we get? 3,000 over patients, BMI of at least 30 or at least 27 with untreated dyslipidemia of hypertension. Mean loss was 8.4 kilograms as against 2.8 kilograms in the placebo group. The number of patients who had at least 10% weight loss was 1/3 of them. Very good response. Responders, about 15% of them had at least 15% weight loss. And we all have patients under us who are on liraglutide who are super responders, where we get actually 20 to even 30% weight loss. Next one that we talk about. So we talk about surgery. In terms of 6 months, we talk about medication, 1 year, about 9 kilograms. And we talk about now we're going to talk about diets now. What about very low caloric diets? This has been there for a very long time already. We talk about crash diets, right? But medically, we do use this quite often to get a person prepared for surgery. For example, get that abdominal fat down, NAFLDs and stuff. Again, I got this data because 6 months, there's 6 months written in the topic. So 30 type 2 diabetic patients, VLCD for 8 weeks, about 700 calories using Optifast together with non-starchy vegetables. Sorry, minute wasn't there. Weight loss was about 14 kilograms in that 8 weeks. And that remains stable over 6 months. So about 40% who were responders, they had fasting glucose, which were less than 7 millimoles per liter. And they after return to isocaloric diet and after 6 months. So we do have people in 8 weeks then dropping 14 kilograms. So 8 weeks, so 14 divided by 8, that could be as many as about 2 kilograms per week. What about the VLCD effect on responders? Take a look here. This is baseline. This is after VLCD. This is after 6 months. We have stability here. Everything, the asterisks basically is statistically significant. Look at the BMI, waist-hip ratio, fat mass, insulin, basically all metabolic markers, most of them have decreased, have improved after VLCD diet. Rapid weight loss. What about self-treatment? Because let's be honest here. Most people are not going to come into my clinic and tell me, you have 6 months, doctor, you have to make me slim. A lot of them are going to self-treat themselves. So what do we have data out there with regards to self-treatment? So I brought this out. I was trawling the web. The things that I learned, the Biggest Loser Asia Season 2, Raj was the winner. Look at him. So in 3 months, he lost a total of 67 kilograms. No one can deny looking at him that he's lean and mean and a fighting machine. Oh, by the way, he's Singaporean. He won. This was the top female there. Also Singaporean, Indian by origin, Malay by origin. Look at how much she won in that 3 months, 35 kilograms. No one can deny. Look at her lean and mean board that this is not healthy. So is it doable? Yes, it's doable. What were they doing? Combination of hypo or low caloric diet, probably around the level of that of the VLCD diets, plus exercise. You definitely need a physical trainer to get in muscles like that and a bod like hers. So we talked about this. In terms of acute wise, does there seem to be problems? We had acute, we have lots of kilograms lost, bariatric surgery, very low caloric diet, not so much for the medications, but that's to be expected. Number 3, self-treatment looking like that. Okay, acute wise, would I say that there's detriment? Doesn't seem to be if they're done correctly with proper medical supervision. Long term, now that's the question. We all know who are in weight management that losing is not the problem, or rather to us, that was the easy part. It is the maintenance, which is going to be an uphill battle all the way. So let's look then at 10-year study for the various options of treatment. Let's look at 10-year studies. We have the most in terms of long-term data, of course, for a surgical procedure, because it was a surgical procedure. So this was a systematic review with meta-analysis performed on all eligible reports containing 10 or more years of follow-up data on weight loss after bariatric surgery. Let's see the mean of the percentage excess weight loss. Whatever it is, look at it that it was not to 0. The lowest was 20 odd. So they did have sustainability of this, at least for the ones which are more conventional. We talk about the Roux-en-Y, we'll talk about the sleeve gastrectomies. So, and the sleeve gastrectomies here. So you see that there is sustainability of quite a good percentage of that weight which was lost. And this is the SOS data from Sweden with regards to the how showing 15 years after follow-up of the gastric bypass. The best is the gastric bypass out of all of them, showing this trajectory that we are expecting to see for a lot of the surgical procedures. What about liraglutide, 3 milligrams? This was 3 years data. We have 3 years data, and we saw 1 year, again, that little trajectory, which was the same, paralleling that of surgery, where it was the greatest in the first phase. And then you see this gradual weight regain. This is still dataless. After that, I am looking forward to more and more data coming out. What about long-term weight regain in VLCDs? Now, this is then the one where we had nothing to help, just by very low caloric diets. And what is worrisome about this was we don't have that many long-term data which are beyond 1 year. And even in 1 year, let's see about this is take you through this. The regain is a percentage of the initial weight gain. So 64% means you are still less. You have still been, that there is still some weight loss at 1 year, but already you see one in which is 122%. There's only one study went up to 5 years, and none of and it's like none of them were. Everybody regained their weight or rebound and got even higher. So it's 121% of the original weight, which was the original weight was a mean of 106 kilograms. So this is fate of VLCD diet, very low caloric diet. What about the fate of real life people? This is the US winner for the Biggest Losers. Well, they might not want to name them Biggest Losers after all, because, well, big loser, because 2 years later, 3 months later, after the program, he won. 2 years later, that's what he looks like, holding that little pint of beer. What about fish? Because we are talking about, this is a female conference here. Let's talk about that top winner, a Singapore top winner in season 2 of the Asia Top Losers. And look at the hot board there. But this was the biography. I wanted to know what happened to her after. And this was a biography. She said she lost 35 kilograms, but gained it all back and more. And her page is to document her yo-yo diets, her road to recovery from depression to wellness. This is what is afflicting a lot of our patients now. So obesity is not a moral of the discipline problem. There are lots and lots, I wouldn't have time to go in with regards to all the hormonal regulation that wants to keep the patient at that weight. Basically, this is just a survival mechanism to keep that weight so that you can survive when times are when there's starvation times. Unfortunately, we don't have starvation times now, and that's what's causing the problem. So, and what's worse for this patient, the biggest losers, so they showed them, they took 14 of this, we had data for up to 6 years after, that there was persistent metabolic adaptation 6 years after the Biggest Loser competition. So if you take a look at this then, basically what it is that after the age, the age, they were all about 35 years of age. At baseline, the weight was about 148. At follow-up, the 6 years, the mean was that there was still some decrease, but unfortunately, the metabolic adaptation was about minus 500 calories. They were so much more efficient in using the fuel now. And 5 out of 14 became the same weight or within 1% of their original weight. So this is the fate of the Biggest Losers. So long-term, in terms of acute, seems okay. But long-term wise, what's happening here? We see potential for disaster now in the future when we are talking about those going off very low caloric diets. We're going for the Biggest Losers doing that type of great weight loss without the behavior change in between that would make sure that they don't regain it all back. So back to our lady then. So the majority is likely going to be choosing the dietary quick fix. And in fact, the majority, as I mentioned, might be doing it on their own. The question now is, as I was mentioning, is this going to affect her negatively for the future? And unfortunately, the answer is going to be yes. If they do it mostly on their own, without proper supervision, without proper knowledge, this is what's happening. They will be paralleling what the Biggest Losers are going to suffer from. Because most of them, with the incentive of being pretty for 6 months later for their for marriage, they're not going to care. They're going to lose weight. They definitely will lose weight. They're just going on to go on a crash diet. And that's what's going to happen, just like what the Biggest Losers do. And in general, even without the incentive to want to crash and lose that quick fix weight, we would see patients who are, let's say, around 13 years of age. They start off at 50, which is about mid-range. They're not obese. They're totally normal weight. But as the course progresses, you see their weight going higher, with the bloops being because they married and they got the children. And then it got worse and worse as you progress towards middle age. And now, what's worse is that if we have now this quick fix, is it going to be negatively affected in terms of everything now? She started off, she was already obese in the beginning as a child, 60 kilograms, and now she's 70 kilograms. Is it going to start off worse and end her up at the worst place than what you would see on an average patient? So our responsibility then is to ensure health, and that they are armed with the proper knowledge, the person that walks into my clinic. So in the clinic, when I see her, what I want to do is I want to delineate the problem. Class 1 obesity, using the upper limit of normal of at least 27.5. I want to uncover her comorbidities, because chances are she will and she might have comorbidities, if not now, in the future. And I want to discuss options of therapy, lifestyle, against medical, against even surgery if she is qualifies. So first, I want to uncover her comorbidities. So very quickly, these would be the things that I would do for her: full blood counts, renal panels, liver tests, ultrasound liver, fasting glucose, HbA1c, insulin, may or may not do an OGTT, lipids, uric acid, and again, may or may not try to do a thyroid function test or Cushing screening, depends on whether I think that there's a secondary cause to the obesity. Vast majority of the time, 99.999%, no, they don't have a secondary cause. It's just imbalance of output and input. So when we got her results, her ultrasound liver, not surprising, lots of my patients come and this is what I discover. There's fatty liver. And if you see her insulin, she's hyperinsulinemic. And there was looking at her, she had acanthosis nigricans, very, very slight, but hiding behind at her neck, at the nape of her neck behind her. Her lipids there, her triglycerides was on the higher side already. This is a metabolic phenomenon where we see where the triglycerides are high and the HDL is low. LDLs are generally not linked in the same way to obesity, so I can get a beautiful LDL without any issues. Uric acid, again, slightly higher, metabolic phenomenon that I'm seeing already, and I didn't do the thyroid function test or any Cushing screening. So her comorbidities, she has class 1 obesity complicated by fatty liver, dyslipidemia, hyperinsulinemia, high risk of diabetes in the future, especially since she's a race, South Asian in origin. Number 2, what about her family history? Now I want to discuss the options of therapy. So these are the 3 options that can come about for her, but bariatric surgery is out, she's still slim for that. So it's either lifestyle or medications. Let's talk about lifestyle. What we'll do practically, I will calculate the calories which are required per day. You can't just tell her eat less calories, go exercise. Nothing is going to work. She is absolute body weight of 70 kilograms. It's class 1 obesity for her because her height is 1.55, but 70 kilograms is absolutely not high at all. So we want to aim for a 50 calorie deficiency. I'll go on the net, just Google in, and we get a calculator like this, and you can plug in her age, female, her height, her weight, and you can even choose what the activity is. So I calculated already based on sedentary lifestyle. Guess how much she requires? Only about 1,600 calories a day. That is really nothing, despite the fact that she's 23 years old. You want mild weight loss, 0.25 kilograms per week is 1,400 calories. You want 0.5 kilograms per week, 1,171 calories. You can't do 671. That is not healthy, not without medical supervision, and not for a quick fix, which is marriage. Calculated wise, in terms of if we did exercise 1 to 3 times per week, 15 to 30 minutes of exercise, moderate intensity exercise, 1,900. 4 to 5 times a week, 2,000. 2,200 calories if you did daily activity or intense exercise. And sometimes exercise is worrisome to just use it because you underestimate the amount you eat. You also overestimate your exercise. You end up with a patient not losing weight at all because they are under and overestimating at 2 different parts. So if you want 500 calories per day, that would mean about 3,500 calories per week. And that will be about half kilogram per week. So if you are doing it at sedentary, so for her, you definitely would need to put in exercise in order to muck up the output, so that if she takes, let's say, 1,200 or 1,000 calories, you have that discrepancy of the calories, and that's where you get your weight loss. Let's do a comparison of what diets should we go for then. So a comparison of weight loss among named diet programs in overweight and obese adults, a meta-analysis done in JAMA. So you had 48 studies there, and the largest weight loss was associated with low carb or low fat diets. And whether it's low carb or low fat, in 6 months, we're talking about 8 kilograms against 7 kilograms, 12 months, 7.25, 7.27. Really, there's no difference here. And the weight loss was differences between individual diets, about 1.7 kilograms at most. So individual diets like South Beach diets, Atkins diets, whatever they are, at most, in between, minimal differences amongst them. So the recommendation based on that was then what is we have always learned, which is recommend a diet that the patient will adhere to in order to lose weight. So ladies and gentlemen, input equals to output, and your input is food, just food, and output is exercise and non-exercise calorie loss. If your input is less than output, there is weight loss. This is indelible fact. So 3,500 calories a day, half a kilogram. So lifestyle facts that I impart to my patients: understand the possible consequences of a quick fix. Understand that it's not one diet, but a caloric difference between input and output. If they don't understand that, we're going to have a problem. They go diet after diet after diet and not understand the underlying principle. You have to choose a diet that will not push the patient into an eating disorder, and that a reasonable person will know is harsh. If that person loves the potato chips, if you say no potato chips for the rest of their life, they will be pretty obsessed about that potato chip. Allowing to eat that one potato chip would be better actually in the long run. And choose to empower them to be able to live in society and yet can still lose weight and thereafter to maintain that weight. My holy grail is this lady. I tried to find an elderly Indian lady. Lots of scenarios. I'm sure you know of all those elderly ladies out there who are slim, lean, and mean. You ask them whether they had diet in their entire life. They say no. Learn from them. If there is something which is not a diet, they will keep it for their entire life, and they have won. And I see also Chinese females like that. Sometimes you need to help a brain a little by giving them, for example, liraglutide, which will help to suppress all those counter-regulatory hormones that will push you into putting on weight more. So whichever diet the patient chooses, the heart of it, caloric deficit, learning to eat in society and customize to the patient so that you have weight maintenance. You want that weight maintenance now, not just a quick fix. And Holy Grail is a behavior change to make all this part of their own, being like the elderly female who has never been on a diet. Then she wins. So back to her, she chose a lifestyle, personal trainer, dietitian, 1,000 calories per day. Was she successful? You bet she is. Chances are she is, because she needs that incentive, which is very great. This is Fish, our biggest loser for season. This was what her kilogram loss was for that 10 weeks. Okay, and it's the first week is always the greatest because there's not just water, but they are crashing sometimes, and they're so enthusiastic. So you get that big weight loss. So for her, she did 1,000 calories, increasing exercise and resistance training. So around 3 kilograms per month, decreasing as the months progress. That's what we see. Generally, that's what we get. Actually, this was 1 kilogram. So she lost 15 kilograms, made her 55 kilograms. BMI just slipped in under the radar upper limit of normal. All markers of metabolic syndrome resolved. We did our job, 6 months, okay? She went to happily got married. Married was for forever. Vows are exchanged about forever. But what about weight loss? Is it forever? That's the problem. And this is the main challenge that we'll be facing in the future for her. And remember the slide where there's so many things they're trying to get her back to have weight regain. And we need to then tackle this. So follow up for a patient after weight loss. It is like any chronic disease. Graves' disease, for example, sometimes patient gets lost to follow up. So you always warn them, if you find weight creeping up more than 3 kilograms, please get back in. And we have to then rediscover and rediscuss again, like any chronic disease, issues, comorbidities, the various options that we have now in order to maintain that weight or to lose weight, especially if they're lost to follow up. And now they've regained like 20 kilograms, 150% of what they have lost. So in conclusion, we talked about various options of management of the obesity, their speed, that quick fix thing, their effectiveness, their maintenance phase. Not a lot of data, is not as much as bariatric surgery in terms of sustainability, especially not for those which are only a diet alone. And we talked about a practical approach to this patient in terms of this weight loss and what I do in my clinic at the same time. And no one size fits all, and we are ever searching for that holy grail. Remember the elderly female who's never been on a diet, to impart to my patient to be like them, so that if you're not on diet, you have won. That is, you will maintain your weight basically more or less for the rest of your life. Thank you very much. I'll take any questions. If I can't take any questions, you can email me those questions. Thank you.
Thank you. That was absolutely brilliant, Vivian. I mean, and innovative. I mean, you've had to start from scratch, and the way you've done it, I really, really enjoyed each and every minute of it. Wonderful.
Thank you very much.
Yes, I think because this is a long session, Rucha, would you agree, Lily? If we had the questions, and then Vivian, I think she needs to get somewhere after this.
Yes.
I think we are running very late, so we need to actually move on to the next session. We are about 15 minutes behind, so I think we need to move on.
Okay, so thank you, Vivian.
Thank you very much.
That was absolutely terrific.
Thank you very much. Thank you, guys. Goodbye.
Bye-bye.
Have a good session. Bye.
Ditto from
Thank
me,
you.
Dr. Vivian. Ditto from me. Excellent, brilliant, superb. Wow. This is Dr. Manisha. So I'll try to implement whatever you told, ma'am. Thank you.
Thank you very much. Bye-bye.
Bye.
Right. So the next talk is the drug. I don't know this. We are talking about the wonder drugs, the gliflozins. Of course, the gliptins have been around with us for quite some time. But the question that is going to be addressed by Dr. Hinde Iraqi from Morocco is gliptins and gliflozins in pre-diabetes. She is a professor at the Ibn Sina Hospital, University of Rabat, Morocco, professor in endocrinology and metabolic disorders, expert trainer of the Diabetes Conversation Map, editor-in-chief of the Moroccan Medical Journal, member of the Ministry of Health Working Group, and she has several prestigious publications to her credit. And again, I cannot thank you enough for staying, for coming in so early in the morning. Good morning again, and could you please start off with your presentation?
Thank you very much, Dr. Saida Barraj, for your kind introduction. It's a real pleasure for me to be with you in this annual summit, and thank you for all the really good topics that were yesterday, and I hope today is going to be the same. So today we have the global epidemic of type 2 that remains really one of the greatest health challenges in our time. And we have widespread initiatives that now exist to prevent diabetes wherever possible. So let's see if this new medication have proven efficacy and in prediabetes, and what are the challenges. So first, what is prediabetes? You know that to diagnose diabetes, the criteria have evolved over the year because we have lower plasma glucose threshold and even advocation use of A1C for diagnosis, while continuing to calibrate the threshold against risk from retinopathy. So when we speak about prediabetes, it's a condition when an individual with high plasma glucose level, it is higher than normal, but it is not yet enough to be diagnosed of having diabetes. So by definition, we have the impaired fasting condition. Do you hear me?
We can hear you and we can see your slides. Please continue.
Thank you. By definition, we have the impaired fasting glucose. That is a condition where you have a glucose range between 100 milligram per deciliter to 125 after a fast of at least 8 hours. And the impaired glucose condition is defined as having 2-hour plasma glucose value from an OGGT of 140 milligram per deciliter to 2. And we know that the American Diabetes Association Standards of Care thinks that it's also reasonable to consider an A1C range between 5.7 to 6.5%. So these people would have pre-diabetes. And pre-diabetes can be viewed as the consequences of different pathophysiologic changes. It is before type 2 diabetes. And in most individuals, insulin resistance is the first of a sequence of abnormalities leading to the development of type 2. So here you can see that in pre-diabetes, the insulin resistance is compensated by hyperinsulin secretion, hyperinsulinemia, which allow glucose metabolism to remain normal. And in pre-diabetes, you have the post-meal glucose that rise before the fasting glucose plasma. The prevalence of this prediabetes is very important. Here you can see in Morocco, for example, we have 10% of prediabetes people and 10% almost of diabetes people. So in the 2019 IDF Atlas edition, we know that 7.5% of the adult population are estimated to have a high, an impaired glucose tolerance. And I would like to emphasize that the vast majority live in low and middle income country, and this is going to worsen by the next years. The countries with the highest number of people in the age group 20 to 79 years old are China, as you can see, United States of America and Indonesia. And it is projected that India, that is the fourth country, will exceed Indonesia in 2045, and it will be the third in terms of number of people with impaired glucose tolerance. So you should, and all the people I think in the world should pay attention to this situation. And you know that diabetes remains the leading cause of blindness, kidney failure, and also amputation. So the current this figure shows the prevalence of retinopathy by 0.5 intervals for each measure of glycemia. And you can see that this rise of risk of retinopathy begin before the diagnosis of diabetic. So it begins from 6%. And we have also cardiovascular disease that is the leading cause of death and even illness and hospitalization. And data suggests that here, the A1C less than 6% could also lead to cardiovascular disease. So please don't forget first to screen for pre-diabetes and advise people and even follow up these people, because this is an evaluate progress. You can, I don't know in India if you use any screening for diabetes risk test. We could use it especially for people who have family with type 2 diabetes. So for diabetes prevention, we have many clinical trials around the globe, and we have trials with, as you know, with the lifestyle intervention. This approach have used a low-fat hypocaloric diet and moderate exercise, like 150 minutes per week. And here the diabetes prevention program study shows that this could lead to 58 reduction in diabetes. But we have also other trials using glucose-lowering medication, old glucose-lowering medication. And this drug therapy, with the exception of Navigator, demonstrate that diabetes incidence can be reduced by 20 to 89% with a wide range of ethnic groups. So when we use metformin or rosiglitazone or even glargine, we have a plus with diabetic prevention. And we also have many trials with the anti-obesity medication that have the same results. So data of incidence of prevalence of microvascular disease in people with pre-diabetes shows also benefit from early preventions. So if we treat pre-diabetes, we try to do our best with pre-diabetes. Here it's with lifestyle, and it was a study with women only. Then we can have 25 reduction of the composite microvascular disease, that was retinopathy, nephropathy, and or neuropathy. And in the Swedish obesity study, the composite microvascular endpoint was 82% lower in those with who had undergone bariatric surgery. And finally, lastly, the retinopathy was reduced by 47% in the Daking lifestyle study. That is also very important. So we have also macrovascular disease in prediabetes, and many trials were done, and all of them proved that we could lower the macrovascular diseases and even the death. So we can say that despite this success among all the strategies, we have only the intensive lifestyle modification that has been universally advocated. And even initiation in metformin with the patients with prediabetes is recommended now for people who have more than 65 years old with BMI more than 25. And we should say that FDA does not recognize prediabetes as a disease and do not approve even metformin. So the question is, with these new therapies, is there any place for incretin therapy first in pre-diabetes. I'm going to speak about incretin therapy. And before, we should say that people with type 2 have an impairment in the incretin system, as you know, that is characterized by a reduced responsiveness to glucose-dependent inotropic polypeptide, and of course, lower GLP-1 concentration. When we have patients with pre-diabetes situation, they already have insulin resistance, as you see in my first slides, and we have defects in the pancreatic beta cell too, and even the alpha cell dysfunction. So DPP-4 inhibitors target this physiological and pathological defect. So this schema could show that the incretin system, you have the GLP-1 and the GIP that stimulates insulin release, and they could lower blood glucose by and DPP-4 could degrade GLP-1 and GIP to inactive metabolites. So when we use a DPP-4 inhibitor, then we block this and we can have more lowering blood glucose. We have many studies with the incretin therapy. The first one I read was with vildagliptin. It was a very small study with only 22 subjects that has an impaired fasting glucose. And this subjects has run for a 6-week study with vildagliptin and then placebo for 2 weeks. And the result was that the fasting glucose did not change after 6 weeks of vildagliptin, but in the second study that were also, I'm sorry. Yeah, in the second study with the sitagliptin with also 22 subjects, this study shows that we have a better concentration of GLP-1, but did not affect the fast or the postprandial glucose. The postprandial endogenic glucose production and glucose disappearance remains unchanged. But this last study with DPP-4 inhibitor sitagliptin improved both glucose tolerance and lipid metabolism in individuals with type 2 diabetics. So, I'm sorry. So we know that even we have many preclinical studies that demonstrate that we have enhanced energy expenditure with sitagliptin and even increased brown adipose tissue. Then this study was very interesting because it could prove that sitagliptin improved glucose tolerance even in pre-diabetic men. But the limitation was that it was a very small sample size and it was a European men only. So because we are in a summit for the women, we would like to have more women included in all the studies. And we can say that the measurements were done, after an overnight fast. And we know that since DPP-4 inhibitors are most effective after a meal, it would be interesting, I think, to do this kind of study with the measurement in postprandial and not in the overnight fast, with an overnight fast. The most interesting studies were these prelim studies, the combination of linagliptin, metformin, and lifestyle modification in patients. It was a double-blind randomized clinical trial, and it would include 52 participants in each group. So it was very interesting at the end. We had patients with impaired glucose tolerance, and the two groups were compared was linagliptin 5 milligrams plus metformin and lifestyle changes compared to metformin with lifestyle changes. And they have many objectives like glucose tolerance and also pancreatic beta cell function. The results were very important, as you say, and the combination of linagliptin, metformin, and lifestyle lead to a significantly greater improvement in glucose level and disposition index in OGGT, with also a significant lower incidence of type 2 diabetes in the patient group receiving linagliptin, metformin, comparing to the group that receive only metformin. So here the incidence of type 2 with the Kaplan-Meier analysis for diabetes free between the two groups also saw that the people who had, the patients who had linagliptin with metformin were more free of diabetes. There were also limitations in that small single center trial. And we can say that the result was not very surprising, that because we know from the first studies with the lifestyle and with the other old medication, then when we had one drug, we had a greater reduction in glycemia and even a greater reduction in type 2 outcomes. So the high cost also associated with DPP-4 inhibitors would maybe prohibit many clinicians from recommending this drug over metformin. So this was very interesting studies with gliptins, but I think we need more, and especially more control randomized study with more people with this pre-diabetes situation. With the gliflozin in pre-diabetes, you know that gliflozin are sodium glucose cotransporter 2. That is a protein in human that facilitates glucose reabsorption in the kidney. And here you can see that when we inhibit the SGLT2 by this new class of medication for patients with type 2, and we have also studies with patients without type 2 diabetes, then we could block the glucose reabsorption in the kidney and increasing glucose excretion and lower blood glucose level. We have many studies with the efficacy and safety of these drugs in multiple randomized controlled trials. And in the condition of pre-diabetes, we have this pre-diabetes trial, which was a randomized controlled parallel open label superiority trial that compared the efficacy of 3 short-term glucose lowering intervention, exercise or metformin or dapagliflozin, and it was used in on glycemic variability in overweight or obese men and women with pre-diabetes. The primary endpoint change was the MAGE, the mean amplitude of glycemic excursion, from baseline to the end of the treatment, and it was 13-week study. So they include the pre-diabetic patients with an age of 30 to 70 years old. They were overweight and they had 120 participants. This is the design of the trial. As you can see, there were 4 groups and they had an intervention in the first and then no intervention. And they could compare DAPA, metformin, and exercise, and also the control group that have only lifestyle advices. And we can say that thanks to CGMS, they could use the MAGE because they could measure the glycemic variability, and the conclusion was that all treatments slightly improved A1C and fasting measure, but only dapagliflozin and metformin and exercise shows signs of improvement in postprandial glucose metabolic in this patient with pre-diabetes. So this was a very interesting study, but because it was really the first randomized controlled trial that tested the SGLT2 inhibitors, and it was a real head-to-head comparison with metformin and also with the exercise, and they could measure the glycemic variability in pre-diabetic. But Of course, because we know that the statistical power to show individual differences in treatments responsiveness within each treatment arm was limited. And the last one was a poster presented in the last ADA Congress. And it was very interesting to see that here we had they compare patients with dapagliflozin and with placebo. They were pre-diabetic patients, and they could show that only 4.9% of these people had new onset of diabetes compared with 7.1% for the group with placebo, and the significant reduction, 32% of a reduction in risk with dapagliflozin. So this study was very interesting, but of course we also need, for the gliptins, a further study to determine how this is durable during the time, and to what extent it would be possible with patients without heart failure reduced ejection fraction. As you know, that in the DAPA-HF, it was patient with heart failure, and it would be interesting to have this kind of study with people without heart failure. So to conclude, I would like to say that the high progression rates of type 2 diabetes and even pre-diabetes, and the very difficult micro and macrovascular complication, and even death, would lead us to think of this pre-diabetes situation. Now we have sufficient evidence to suggest that we should encourage patients to be more active and to have lifestyle intervention. And however, I present you many studies with I remember with all the medication, metformin, and the lifestyle too, and also insulin studies. And with this new studies, we have currently no medication approved for pre-diabetes. We should have more studies with more people included in it. And we know that even now doctors are prescribing off-label metformin and on top of other drugs in the pre-diabetes situation. Most of them are acarbose and GLP-1 receptor agonist, and maybe DPP-4 inhibitors, as I see in the literature. Thank you very much.
Thank you, Dr. Hinde. That was very, very interesting. And like you yourself have clearly said, that everything is off-label, and we are still banking on lifestyle, which invariably defaults with lifestyle, whether it is diabetes or pre-diabetes, knowing that even a small percentage, like 5 to 10% weight loss, would give us metabolic benefits, whether it's in the A1C, whether it is in the lipids, even reduction in the blood pressure. But I think even with drug therapy, the compliance would always be a big issue, because then the patient will feel labeled.
Of course.
With pre-diabetes, they feel there's a touch of diabetes and it can go away, and sort of they're in that period in which it is difficult to convince them. But I think your message is very clear. Rucha, do we have time for questions?
We are running quite a bit late, so unless there's one question, we move on to the next speaker. I don't see any in the chat box.
Yeah, but where do you, I would like to ask you, Dr. Hinde, where do you see their place in pre-diabetes, and would you on a personal level prescribe them?
Here in Morocco, it is a little bit difficult to prescribe, not only because of the cost, but because of the adherence then to diet and lifestyle. Because when we prescribe drug to patients, then they can have less effort to do lifestyle and also diet. So in my personal experience, I use metformin in pre-diabetic patients with and I explain them that it is off-label. It could help, I think, but for this new medication, I'm still not convinced because we should have more data.
Thank you. Thank you very much. Over to you, Rucha.
Sure, thank you.
Thank you,
Thank
Dr.
you for
Raj.
two great talks, and thanks, Dr. Bajaj. Now we move on to the next part of the talk, and Dr. Monica Mahajan, is Dr. Mahajan here?
Yeah, she's there.
Ah, there she is. Okay, yes.
Thank you so much.
So thank you for joining us. And you can start sharing your slide. Yeah. She's going to speak to us today about adult vaccination, which we know is definitely the need of the hour, especially given in this COVID era. And we have another talk coming up on that. She is the Director of Internal Medicine at Max Healthcare in New Delhi. If I can just have the next slide also from you. She's the medical director at Max Specialty Hospital in Panchi and Max Oncology Center, Lajpat Nagar, where she's also in charge of the DNB program for medicine. She's a member of the Scientific and Ethics Committee, and she has authored Systemic Fungal Infection, a book published by JP. She's a physician for the US Embassy, France, Switzerland, Australia, and UN. And she's an expert for a speaker for major TV channels and newspapers. So who better than to speak to us about adult vaccination? And since we are late, I'll hand it over to Dr. Mahajan without any delay.
Thank you so much, Rucha, for your kind introduction, and quickly going on to my slides for today. So first, I need to emphasize as to why vaccines are needed for adults, in the sense that we've always associated vaccines with children. So why is the need for vaccines there in adults in the first place? So what we need to understand is that some diseases are specific to adults, including shingles and pneumonia, which are more common in adults rather than children. From time to time, we realize that the vaccine efficacy in adults has worn off and we need booster doses for certain vaccinations. Again, related to our jobs and our lifestyle, there may be certain exposures which are happening in the adults and not in the children. So we need vaccinations related to work as well as in terms of job and lifestyle. And again, if adults travel, they need a yellow fever vaccine. Catch-up vaccinations, a lot of Indians don't even have records as to what vaccinations they've received so far. So they do need to update their vaccinations, which have been missed out in childhood. Again, availability of new vaccines, which were not there when we were children. And we are talking of a concept of herd immunity. So with all this in mind, let's start with just a basic slide on the immune response when a vaccination is given. So the cells which come into play include the T helper cells, which is the CD4 cells, the B cells, which is responsible for the production of antibodies, as well as the memory response, as well as in terms of the killer T cells. So the various advisory bodies which have given us vaccination advice include the CDC, which is the most practiced all over the world, the WHO recommendations, and then our own API came up with an expert panel on vaccination as to who should be vaccinated and with what. This is the API recommendation, which says that for all healthy adults, the minimum vaccination that you need as an adult is DPT, MMR, influenza, pneumococcal, human papilloma virus, and zoster. And I'll be talking in detail a few slides about each of these situations. And the optional vaccines that API talks of is in terms of Hep A and Hep B in case they've not been done, meningococcal in case there is an outbreak or you're more prone to it, for example, a splenectomy patient, varicella, Hib, typhoid, rabies. And two vaccines which are not recommended include Japanese encephalitis and cholera vaccine. So we do not want to include them in the list. Now, I'm not going to really go and bore you with all the textbook about adult immunization, because every book on adult immunization has a chapter as to what to do and what not to do. I'm going to be talking about specific scenarios here on. So between children and adults, the difference is the hepatitis B vaccine in children is used as a 10 microgram, whereas in adults, we use a 20 microgram dose. And the specific populations where you should ensure that they've been vaccinated include occupational exposure. So all your hospital staff, whether it is the dialysis technician, the surgeon, the nurse, or the physician, HIV seropositive individuals, and patients with chronic liver disease, kidney disease, diabetes, of course, and patients requiring multiple blood transfusions. Sexual exposure, believe me, is very, very rampant, and you have to check with patients in terms of their hepatitis B status. The question that often comes is that I've missed on the doses. What do I do? So somebody's taken one dose and not taken the second or third one, and somebody's taken two doses and not taken the last one. So what do you do? So what is recommended is that if somebody's taken just one dose, do the second dose as soon as possible, and do the third dose around 4 weeks from the second dose. If it's just that one dose has been missed, you do the one dose, the last one, as soon as the patient comes to your clinic, and you don't have to wait. So you don't restart the whole vaccination process all over again. You can manage with the leftover 2 doses or 1 dose as far as things are required. If the titers in the high risk people is less than 10 MIU, then you revaccinate. And in certain populations where there are non-responders, for example, in patients on dialysis or CKD, you might want to do a 0, 1, 2, and 6, so 4 doses instead of 3. Or you may want to do a 40 microgram instead of a 20 microgram. So both approaches in CKD and dialysis patients are all right in terms of doing 4 doses instead of 3, or doing double dosing instead of single dosing, and doing a 3-dose vaccination schedule. Going on quickly to the pneumococcal vaccine, we know that 2 are available in the market. One is the Prevnar 13 and the other is in terms of the pneumococcal polysaccharide 23. So the number of strains obviously covered between the 2 is 13 and 23. So less serotypes are covered in the Prevnar 13, but more serotypes are in the pneumococcal polysaccharide vaccine. So then why is it that we prefer Prevnar 13 to the pneumococcal 23? And the reason for that is that in terms of the pneumococcal 23, it gives a less immune response, and the memory response with the pneumococcal 23 is much less compared to the Prevnar 13. So the Prevnar 13 gives a T cell dependent immune response, but it also has a higher efficacy, and it has a potential of reducing the nasopharyngeal carriage. So that is why the Prevnar 13 has to be done first, and then the pneumococcal 23 has to be administered later on. You cannot be doing both the vaccinations at the same time.
No, you please talk to her. I'm not in charge of it.
So in terms of the vaccination schedule, it's very, very simple as far as the pneumococcal vaccination is concerned. For a person who's coming to your clinic with age of more than 65, you give him the Prevnar 13 first, and 6 to 12 months down the line, you give the pneumococcal 23. For a person who's been vaccinated in the past, because remember the Prevnar 13 has been only in the market for the last 9 years. So a lot of our patients would have received pneumococcal 23 in the past and now come to you. So if they are above the age of 65 years now that they come to you and they've received a pneumococcal 23 in the past, you only need to do one vaccination, which is the Prevnar 13. But somebody who's been vaccinated with Pneumovac 23 in the past was less than 65 years of age when he comes to your clinic, you need to do 2, which is the Prevnar 13 and the pneumococcal 23. So a little confusing, but let me just go through this slide again. In terms of a person who's not been vaccinated, more than 65, you do 2 vaccination, pneumococcal Prevnar 13 followed by Pneumovac 23. A person who's been vaccinated with 1 Pneumovac 23 but is less than 65 years of age when he got it, you need to do both again. And somebody who's above 65, when he comes to you, then you need to do again a Pneumovac 13, Prevnar 13 only. So it depends on how many vaccinations the person has received in the past and what is his age when he comes to your clinic for pneumococcal vaccination. Going on to the influenza vaccination, we know that we need to do it every year because the virus mutates very quickly. It's a killed virus vaccine. There is an oral vaccine available, which is the oral nasal spray, but that we generally prefer not to use, especially in the immunosuppressed individuals. So the best timing for influenza vaccine would be October, November every year. And remember that all your diabetic patients, cardiac patients, kidney patients should definitely receive the influenza vaccine in October, November every year. Meningococcal vaccine is a very specific vaccine which not everybody needs to do. So the Hajj travelers, definite recommendation because it is required as a certification for all Hajj travelers that they have a meningococcal vaccination that has been done. Whenever there is an outbreak, meningococcal vaccine, and people who've undergone splenectomy or people who are living in hostels or are military recruits. So that is the specific recommendation for meningococcal vaccination. Rabies vaccine, a lot of foreigners who come to our country are afraid of dog bites from street dogs, and a lot of people who handle animals need rabies vaccine as a pre-exposure. So the pre-exposure rabies vaccine is given as 3 doses, that's 0, 7, and 28. And in terms of the post-exposure, it is 0, 3, 7, 14, and 28. Now with class 3 bites, you need also a human rabies immunoglobulin to be done at 20 IU per kg, infiltrated around the wound, half dose and half as intramuscular. So what happens if somewhere you're sitting in a periphery where the immunoglobulin is not available, you would do is double the dose of the first vaccine and then go on and proceed. If a scenario comes where a person has received already a pre-exposure vaccination for rabies in terms of a 0,728 and now gets a dog bite, so then you don't need to do all 5 doses. You can just manage with a 0 and a 3. Human papilloma virus, again protective for cervical cancer as well as in terms of genital warts. So recommended age is 9 to 26 years. For people who are between the ages of 9 and 14 years, you just need to do 2 doses at 0 and 6 months. But anybody above the age of 15 years, you need a 0, 1 and 6 months for HPV. Tdap is something which is very, very neglected in our country. So what you need to remember is that all adults need a Tdap vaccine every 10 years till the age of 65 years. That's very important and a very neglected area. So Tdap definitely needed as far as the adults are concerned. HIB is specific again for people with splenectomy or in terms of hematological malignancies, diabetes, pregnancy, alcoholism. So these are the recommendations, not certainly a part of the routines which are recommended. Varicella vaccine, very interestingly, all adults who've not had chickenpox should receive the varicella vaccine. It is recommended for all CKD patients and all patients who are on hemodialysis. And the dose recommended is 2 doses, 4 to 6 weeks apart. Varicella being a live vaccine, like all the other live vaccines, for example, yellow fever vaccine, MMR, or varicella, these are all live vaccines. So they are contraindicated in people who are immunosuppressed or HIV patients who have a CD4 count of less than 200. Typhoid vaccination, prefer to do the injectable one every 3 years, especially if you're fond of eating street food or you are in an area where there is low hygiene facilities. This is something you can download and keep on your table, which is the recommended CDC recommendations age-wise for 2020 as far as vaccination in adults is concerned. So I'm going to really move on, Dr. Lily, with your permission, to do a few slides on the COVID vaccine as far as how the status is, and something which I'm very interested in discussing. So there is virtually a race which is going on as far as the COVID vaccine is concerned, and there are 4 categories of vaccines that we are looking at. There are almost 140 plus vaccines in the pipeline in various stages of clinical trials. So we are looking at the inactivated vaccines. Then inactivated means that the virus has been chemically destroyed either with chemicals or radiation. It will not cause the disease per se, but it will generate a antigenic antibody immune response. Then there are, in terms of the recombinant protein vaccines, they are viral vector vaccines, and they are the DNA and the RNA vaccines which are available. So these are the 4 categories of vaccines which are now being studied as far as the SARS-CoV-2 is concerned. These are not new types of vaccines because we've had these vaccines already being used, these technologies being used for other vaccinations. For example, if we talk about the inactivated vaccine, the flu vaccine is an inactivated vaccine, the influenza vaccine is. Similarly, if you look at virus-like particle vaccines, the HPV or the Gardasil is again a virus-like particle. Ebola, incidentally, is a viral vector vaccine which has been generated. So these are the nucleic acid vaccines. This is the first type of COVID vaccines that we are talking of. They can be DNA vaccines or they can be RNA vaccines. The DNA vaccine needs an empty plasmid. It needs a plasmid to attach the DNA, and then that enters into the human body and generates an antibody response. So DNA vaccines are dependent on plasmids, whereas the RNA vaccines don't need a plasmid for entry. So the most important vaccines that you're hearing of on TV channels is in terms of the mRNA vaccines, which is the Pfizer vaccine and the Moderna vaccine. So Pfizer is a nanoparticle mRNA vaccine, and Moderna is again an mRNA vaccine. The beauty of the mRNA vaccines is that they do not interfere with the human genetic code, and they are very, very easy to manufacture. So you are using the messenger RNA to introduce the virus particle into the human body. So not the whole virus, but some part of the virus particle is being introduced into the human body, and that generates an immune response. So both Pfizer and Moderna are mRNA vaccines. So mRNA vaccine, you use the mRNA, it enters into the human body, it generates an antigen presentation response, forms proteins, and this leads to the formation of antibodies and then subsequently the elimination of the virus. So out of the COVID vaccines which are currently being tested and which are available, the mRNA vaccines are the safest option as far as the vaccines are concerned. But the challenge with the mRNA vaccines which are currently available is that they need to be stored and transported at minus 70 degrees Celsius, which is a big challenge at the moment. So this is the first one which was studied, which is the ChAdOx1 or the Oxford vaccine or the AstraZeneca vaccine. And in India, this is the Serum Institute of India, which is taking it up. Why it is called as ChAdOx? It is the chimpanzee adenovirus, which has been used as a viral vector. So use the adenovirus from the chimpanzee, tag it along with the spike proteins of the virus. And since it was being studied in Oxford, so hence it's been called as ChAdOx1. The Russians have again come up with a viral vector vaccine, which is called as Sputnik 5. And again, that is the strong contender for vaccines in India. So in India, we are talking of 3 vaccines currently, which are in the race majorly. That is the AstraZeneca Serum Institute ChAdOx vaccine, the Sputnik 5, which is the Russian vaccine, and then again in terms of the Covaxin, which is the Bharat Biotech vaccine. So Pfizer-BioNTech became history by getting the first vaccine approval by the Britain's Ministry for Medical and Healthcare Products Related Advisory Committee. And this needs to be stored at minus 70 degrees Celsius. So as of today morning, Pfizer has requested the DCGI to allow them to be marketing in India, but the process will be tedious because in India, storing any vaccine at minus 70 degree will be a big challenge. So efficacy wise, very, very efficacious to the tune of 95%. And Britain is starting vaccination with Pfizer-BioNTech vaccine this week. And they're starting with their healthcare workers and people above the age of 80 years staying in old people home. Moderna is major trials going on in US, and it again is seeking an emergency use approval this week and will probably hit the European and the American market this week. Developed in Massachusetts. So this is again a mRNA vaccine. So both Pfizer and Moderna are very safe vaccines because of their mRNA technology being extremely safe in terms of adverse events associated with the vaccine. The challenge with Pfizer and Moderna, again, they need ultra cold storage in terms of minus 70 degrees. ChAdOx1, I've already talked of. This is the one which is most likely that you and I will be getting as part of the COVID vaccination in India, because Serum Institute started manufacturing it in millions of doses way back in June. And this is the one which is most likely to hit the Indian market and the healthcare workers first. The efficacy is to the tune of 70 to 90%. Now, it did land up in a little bit of a controversy with the half dose. So what happened is, while this vaccine was undergoing trials in Oxford, in a certain subset of volunteers for the vaccination program, they ended up getting only half a dose compared to originally the full dose that was meant to be given as the first dose. Now, AstraZeneca labeled it as serendipity or good luck that with the half dose, the vaccine volunteers generated as much of immunity, whereas Oxford said, no, it was deliberately given as a half dose. So with all this controversy going on, the AstraZeneca shares went down and the people's trust factor in the vaccine was lost. Again, somebody in Chennai claiming that he had a major adverse event with this vaccine. So some controversy with this, but all said and done, this is still a very, very safe vaccine. And the most important part is it can be stored in a fridge. So in our Indian hot and humid conditions, this is the easiest vaccine to transport and the easiest vaccine to distribute to the masses. So we are looking forward to this being the cheapest and the easiest available option as far as India is concerned. Sputnik 5, like I mentioned, is again going to be likely in the Indian market, named after the first Soviet space satellite. It again has a very high efficacy rate of 91.4%. And some of the vaccine related research is being done hands-on with Dr. Reddy's lab, and some of the North Indian states are already holding the trials for Sputnik 5. And again, easy to store at 2 to 8 degrees Celsius. And it uses 2 recombinant virus vectors in terms of 2 human adenoviruses, adenovirus 26, and 21 days later, you use a recombinant viral vaccine with adenovirus 5. So it is using 2 viral vectors so that even if you develop immunity to the first viral vector, you still show a good immune response to the second viral vector. Covaxin is our indigenous product. It's developed by ICMR. This is an inactivated vaccine. it will need a booster dose. So what you need to understand with this inactivated vaccine is that one dose will not work, because inactivated vaccines generate a low immune response. So you always need 2 vaccines when you're talking of an inactivated vaccine. ZyCoV-D by Zydus, our Prime Minister did visit. So this is still in phase 3 trials, and this is a genetically engineered plasmid DNA vaccine. So I mentioned in my earlier slides that when you use a DNA vaccine, you need a plasmid particle to carry on the vaccination. So the plasmids for this has been genetically engineered by Zydus. So going on to my last slide, that between the mRNA and the traditional inactivated vaccines, the mRNA vaccine is much easier to produce, faster, because mRNA molecules are much easier and easily accessible, and the components are injected into the arm and serve as instruction for the body to make the microbial proteins and generate an immune response. Whereas with the traditional vaccines, the production is much slower, much more expensive, and the immune response may not be so robust. So I would say that we still need to practice behavior in terms of social distancing and masks. So stay safe, stay healthy, and do remember that you need to update not just your patient's adult immunization, but you also need to update your own vaccinations as far as you as physicians are concerned. A lot of times we neglect our own health. So please look at your vaccination details, check your hepatitis B status, check what other vaccinations you need. Have you been vaccinated for influenza, for pneumococcal if recommended, and please go ahead and update your own adult immunization schedules, and then look at your patient schedule and make this as part of your prescription writing. Thank you so much for your patient hearing.
Great. Thank you so much, Dr. Monica. That was very comprehensive. And I think let's move on to the next talk. We also have COVID coming up later, so we can combine the Q&As. The next speaker today is someone who's very dear to my heart, a good friend of mine, Dr. Meenal Mohit. And I see that she's already here. Meenal will be speaking to us about endocrine challenges in a woman from womb to tomb. So, and I can only think of no one else or a better person who can really deal with this complex topic. So, if we can, Meenal, you can start sharing the slide here, so that way we have some time. She's a consultant endocrinologist at Manipal Hospital in Jaipur. She's the chief medical director of Sashakt Thyroid Endocrine and Diabetes Center, Jaipur as well. And she has truly pioneered something we call the Cloud Endocrine Clinic, which was launched in this COVID-19 scenario. She has numerous oral and poster presentations at national and international conferences, numerous publications in various national and international journals. She's also been the author of several textbooks of medicine. She's the founder, secretary of the Metabolic Club in Jaipur and the founder, trustee of Sashakt Endocrine Trust and the Women's Practitioners Forum in Jaipur. So you can see she's got a lot of feathers in her cap. She's very active, and be ready for a very dynamic talk. So over to you, Meenal. We look forward to your talk.
Hi, good morning, everyone. Thank you, Dr. Lily, for giving me this platform and this opportunity, and congratulations for the second successful Eva Stride. But I need the permission to share my screen, Rucha. They're asking for that somebody else will have to stop sharing before I can share my screen. Rucha, you are mute.
Dr. Monica, you need to stop sharing your screen.
Monica, yes, Monica has to stop.
Dr. Monica, are you still there? Can somebody from the event management? I don't have a phone number for Dr. Monica. Can Dr. Lily, you call her?
I can call her.
Good. You can go ahead now, Meenal. Yeah.
Yeah, thank you so much, Rucha. Thank you, ma'am. And good morning, everyone present here. The intro slide has already been covered. Thank you, Rucha, for that. Now, the topic that I have been allotted, or rather I have chosen, is a very light one, because this was a conference about a womanhood and safe journey. And the topics that my slides would be covering would just be the introduction, because every topic has already been covered in the entire conference. So it is just touching the problems that women faces right from womb to tomb. And Dr. Bajaj is also here listening to this conference, listening to my talk. Thank you, ma'am. And with your kind permission, in your presence, I'm talking about the endocrine problems in women from womb to tomb. So as you know, womanhood and being a girl or being a woman, we all agree the power of womanhood, and it's a miracle that yes, being a woman is a miracle. And the moment the child is born, the blessing, a family is blessed with a girl child. And the first endocrine problem that we as doctors face in a girl child, the most common 21 hydroxylase deficiency, the most common cause of ambiguity, and the ambiguous genitalia. And there begins the journey, non-ending journey of 17-OHP estimation, maintaining a balance, the cholesterol synthesis pathway, and we all know the excess of adrenal androgens with the deficiency of 21 hydroxylase, leading to virilization. And of course, if it is a severe variety, the child also faces salt crisis or salt wasting crisis, and the child might end up in the ICU also. So then we have a series of surgeries that lead to the correction of the ambiguity which nature has given or awarded the child for no reasons actually. So then there is a lot of surgeries undertaken to bring back the things to normal. This is the first endocrine problem that women faces or the girl child faces, that is ambiguity. Then moving from there, as we rear up the child, any other girl child, so the same child that we are talking, moving from that age group, as the girl starts just walking and she starts stepping in your shoes, you start teaching the child, the girl child, not even 8, and we start teaching the girl child the problems of womanhood, about uterus, vagina, ovaries, menstrual cycles, menarche, the breast development, and then one fine day, probably, you find that even not 8, but there is some breast development already happening, and you are worried. And then starts another series of complications where we are dealing with something called precocity or the precocious puberty. When we talk of precocity or the precocious puberty, I'm not saying that boys do not face it, but here we are focusing only on the girl child. So when we are dealing with early thelarchy or premature thelarchy, we have to look into whether it is a just thelarchy or it is central precocious puberty, or are we dealing with some exaggerated thelarchy. Then we move to something called, it can be just premature adrenarche, there can be some pubic hair growth, then there is sudden spurt of growth, it could be central precocious puberty also. If it is a benign condition, we might counsel the parents and send them back with the reassurance that that will not affect the final adulthood, the final height, and it will not affect anything much except that we require some social and mental counseling and reassurance. But we have to assess it completely before sending the patients back home with that assurance. It could be a central precocious puberty, which might affect the final height and which might affect the social and emotional health of the child. Once we have done with that age group, and probably we are dealing with, no, we're not discussing here the social problems of early marriage. We are discussing conditions that a woman faces where endocrine issues are concerned. And after precocious puberty, the next age group, the child is not grown enough. She's short. And once a girl child is short, it could be Turner's also. So we have to assess the hormones. We have to assess the chromosomes also. It could be a stigma of Turner syndrome, where we also have to deal with delayed puberty. With that, next comes a girl who's fully grown now. She is in her college maybe, or just beginning her college, but every month she has to face dysmenorrhea. Then comes the stigma of acne, which all women worries, oh, another pimple, another spot. And then some hirsutism, unwanted hair growth, which could be beard area, which could be mustache area, it could be all over the body. So then this is a spectrum. Then goes the sonography, and the sonography, the Rotterdam criteria, which gives you something called the polycystic ovarian syndrome or the PCOD. Now the challenge of PCOD is faced. We do have the male analogy for the PCOD, but that is not what is commonly discussed and commonly treated and commonly presenting to us. But PCOD, as we all know, is a very common clinical presentation with obesity, and not only obesity, even lean women faces PCOD definitely. The reason being, it's the imbalance of the androgens. It's a state of hyperandrogenism. Then we have the intra-ovarian hyperandrogenism, as well as the extra-ovarian androgen levels are high. And this hormonal imbalance leads to a complication, the spectrum of polycystic ovarian syndrome. Moving from PCOD comes the time when a woman is married and she's ready to become a mother. And we all know that every baby deserves a healthy mother. And pregnancy, the motherhood, the journey of motherhood is itself a very happy journey. But then we have another endocrine organ developing now, that is the placenta. And the placental hormones, they also play their set of roles. And when we talk of reproductive endocrinology, it itself is a special branch, because it itself is a big chapter in the textbooks of endocrinology. And here comes another set of hormonal complications or the endocrine journey of womanhood or motherhood, I would say. And the first thing we talk of is the thyroid profile or the thyroid hormonal changes, which are very specific for pregnancy because of HCG now coming in and the rising of HCG pushing down the TSH. The first confusion at the level of most of the treating gynecologists is, are we dealing with hyperthyroidism? And then the role of free T4 and free T3, the more of free T4 comes in, where we have to check that it is just the TSH which is being suppressed because of the rising HCG. Then if we do not talk of hyperthyroidism, then the most common is hypothyroidism. It can be subclinical hypothyroidism or it can be overt hypothyroidism. Again, here we need to titrate the dose throughout the pregnancy. As the growing baby, the growing fetus also requires thyroid hormone supplements, and the thyroid hormone source is the mother. We all know the brain development, the IQ of the child depends upon the thyroid hormonal profile of the mother. So all through the journey of pregnancy and motherhood, the thyroid profile is monitored regularly, whether it is hypo or hyper, we are suspecting, and accordingly treated. Another commonly discussed complication of endocrine complication of pregnancy is hyperglycemia. Now, it can be type 2 women becoming pregnant, or it can be type 1 women becoming pregnant, or it can be just a gestational hyperglycemia. In either of the ways, in all the three case scenarios, we need to keep a blood glucose under target, and the targets for pregnancy are again a little tight. We try to keep the fasting blood glucose below 90 milligrams per DL, and all the post meals we try to maintain below 120 milligrams per DL. And most importantly, we need to remember that the only drug of choice during pregnancy, whether type 1, type 2 or gestational, is insulin. And we place the women on a basal bolus regime. That is how it works. And we try to keep the blood glucose under target. All know that this woman, in spite of all our best care, is the woman who's at high risk later on for type 2 diabetes, for early strokes, early atherosclerotic diseases. And this woman is our under observation group of patients where we need to monitor regularly, annually maybe, for her rising blood glucose. And after pregnancy, after delivery, 6 weeks, especially in case of gestational diabetes, we do subject all our patients to oral glucose tolerance test. The babies of the mother born to hyperglycemia are also at risk of macrosomia. They are big babies, large babies, who are at risk of many metabolic complications, as well as there are complications which are related to maybe shoulder dislocation can be there during the time of delivery. So large babies are not what we want. They are not the healthy babies. They are not what we want. We want a healthy baby, and large babies is not synonymous with a healthy baby. So endocrine complication of pregnancy includes gestational diabetes, not only gestational diabetes, hyperglycemia actually I would say, and of course a thyroid dysfunction. Once the pregnancy phase is over, we all know that thyroid has been, or most of the autoimmune disorders rather, have a special bias towards women, and women at whatever socioeconomic class are more subjected, more vulnerable to thyroid dysfunctioning. It can be goiter, it can be hypothyroid, it can be hyperthyroid, it can be anything to do with thyroid dysfunctioning, but the incidence and prevalence is higher in women. Then next phase, the next era of hormonal disturbance which women faces, as the social and the mental stress is there, the burden is there at the time of menarche, almost equivalent or even more, the burden is with the perimenopausal phase. And with the perimenopausal phases and the hormonal fluctuations, another set of hormonal fluctuations, we are ready to face, we all know and understand the hot flushes, the weight gain, the metabolic disturbances, the increased, the rebound of dyslipidemia, hypertension, and the atherosclerotic vascular diseases. We all know the most important and the most prevalent complication or the complaint that we are facing in our OPDs is that flatulence, abdominal distension, hot flushes, insomnias, lack of sleep, the mood disturbances or the mood liabilities, and the night sweats. If you face all this, then another complication which is only discussed in terms of women, though men are not spared, but we mostly discuss osteoporosis in terms of women health, because we all know that women, the bone building is very weak, and up to 25 the bones are building, but we, especially Indian women, we are not much into exercise and bone strengthening. So the fall is very steep for us, and we soon end up with weak bones and osteoporosis, and especially perimenopausal or after menopause, this downhill journey is very fast. And by the time we are 75, because of our lack of exercise or posture, most of us will have noticed this kyphotic, this bump here, and this lack of height, the loss of height is also, we have all witnessed because of the vertebral fractures and collapse. So osteoporosis is another complication, the metabolic or the endocrine complication, which we women inevitably face. The solution lies in right time, early. I will not say that time is right for us, it's already late, but whenever we can start, the idea is a healthy diet, a healthy exercise regime, that was the key to healthy bones. So some do's and some don'ts. I think these are the set of endocrine glands, and we have all some bias towards women, and we have certain specific complications when we talk of endocrine challenges in women. And this is just the crux, the details of every topic has been covered very beautifully by Dr. Lily Rodrigues. And I really congratulate her for the beautiful brochure and also the agenda that she has designed for the conference. With that, I think I will just summarize the womanhood and the journey of womanhood at all ages, right from cradle to the grave. We are facing so many challenges, and we are taking all of them in our stride. The Eva Stride, women, you are love incarnated. As said rightly by Jaishankar Prasad, Nari tum keval shraddha ho, Vishwas rajat nalpak tal mein, Piyush srot si baha karo, Jeevan ke sundar samtal mein. Thank you so much, friends. No matter whatever the age, how many false starts, how many opportunities missed, still I know I can make my dreams come true because I am a woman. Thank you so much.
Great. Thank you so much, Meenal. That was wonderful. And I can't imagine how you did this in 20 minutes, but as I mentioned, only Meenal can do this. To introduce the last speaker, can I have Dr. Sarita Bajaj back, please? Is she around? Am I audible?
Yes, you are.
Okay, because my laptop somehow conked off, so I had to switch to my iPad. Can I have the slide for the last speaker? I can introduce them. I don't know if Dr. Bajaj had said she wanted to introduce, but I'm not sure if she's still there.
Yeah,
so
the slide
for
is
our
there.
next talk, we have Dr. Dimutu Muthukuda. And I'm sorry if I'm not saying that absolutely correctly. She's a consultant endocrinologist in Colombo, Sri Lanka at Sri Jayawardhanapura General Hospital. She did her undergraduate medical education from University of Colombo, postgraduate education also from University of Colombo, Sri Lanka. And then she trained in endocrinology at Addenbrooke Hospital, Cambridge, UK. She is the editor of the Sri Lanka Journal of Diabetes, Endocrinology and Metabolism. She's a member of the editorial board of Sri Lanka Journal of Diabetes, Endocrinology and Metabolism, also the secretary at Sri Lanka College of Endocrinologists. She has several feathers, as you can see again. She's the editor of the Clinical Society for Sri Jayavardhanapuram General Hospital since 2019, chair of the Scientific Committee for Slendo, as well as the chair of the Scientific Committee for Hybrid Slendo this year as well. She's on the executive member of the SAFES 2019 to 2021 program, and her research interests span all the way from endocrine disorders in pregnancy, thyroid disorders, neuroendocrine tumors, and hyperglycemia management in ICUs. She will speak to us about a very burning topic, and especially we all really would want to understand this about COVID-19. And is this truly less of a problem in women? Many of us are aware that we see men being more affected, also having more serious complications due to COVID-19. So let's go ahead and hear right from Dr. Demuthu what the situation truly is. Over to you, Dr. Demuthu.
You have to unmute. Unmute. Yeah.
Is that correct? Right.
Yes.
Thank you very much. Ayubowan. I wish to thank the Eva Stride India team for incorporating this topic in the program. This is a highly sensitive topic. Indeed, appropriate to touch on this at a crucial time where, sorry about that. At a crucial time where we people around the globe are eagerly awaiting to catch a glimpse of hope for the emerging vaccines, as Dr. Mehta had just described. The distribution of COVID-19 cases seems to be almost equal globally. There does not seem to be a gender bias in who gets diagnosed as a case, although this varies from country to country. But when it comes to cases progressing to severe disease and death, men are at quite a substantial disadvantage. Hence, it is justified asking whether COVID-19 is really less of a problem for women. This is what the headline said during the previous few months. In Europe, men account for 57% of deaths from COVID-19 and 70% of admissions to the intensive care unit. In the Netherlands, men make up 38%, only 38% of confirmed cases, but out of that, 55% of deaths. In other words, they are twice as likely as women to die after being infected. Of the 55 countries providing sex disaggregated data on COVID-19, 48 currently show disproportionately higher male deaths among confirmed cases. The reasons behind this disparity are not yet clear. There have been a multitude of hypotheses from the time this trend was first noted. Men die earlier than women generally, so it could be that we are seeing COVID-19 just exacerbating the underlying mortality difference. Perhaps the men who are dying have higher rates of other complications, other non-communicable diseases such as obesity, hypertension, diabetes, and lung disease, and also health-related behaviors such as smoking, or they could just be presenting later to healthcare facilities. So all of which are issues of gender, not just biology. To add to the existing knowledge, there was this systematic literature review and meta-analysis, the largest up to date on this subject, which was published in International Journal of Infectious Diseases in November, with the aim of analyzing the influence of gender on COVID-19, mortality, severity, and disease outcomes. The results indicate that male sex seems to be a risk factor for mortality and for a lower recovery rate, and also for disease severity. It does not highlight a striking difference regarding disease susceptibility, with a male to female ratio of only 1 to 0.9. However, the slight difference might not simply be accidental. The higher proneness of men to COVID-19 could be related to differences in innate immunity, sex hormones, and genetics. And also, females seem to show a higher expression of CD4 lymphocytes, guaranteeing a better viral clearance. The results suggest that males have a 61% higher chance to die from the infection, a 61% higher chance to die from the infection than their female counterparts. This difference seems to hold despite the settings. This is an interesting finding, both in the general population and among hospitalized patients. In most severe cases, SARS-CoV-2 can induce an exaggerated production of pro-inflammatory cytokines. So this is referred to as a cytokine storm, or there's a complex word for this, secondary hemophagocytic lymphohistiocytosis, which leads to multi-organ failure and death. This might be less frequently triggered in women, so although they have a more prompt and effective antiviral response. The place of estrogen is also linked to the presence of estrogen receptors on the surface of innate immune cells, such as monocytes, macrophages, and neutrophils. This also could be another mechanism. High levels of expression of the cell entry receptor, ACE2, used by the virus to invade human cells was shown in male Leydig and Sertoli cells in the testes. These are not found in ovaries. And also ACE2 gene is X-linked. The mechanism may be complex. However, this also could be one of the explanations for the higher mortality in men. There may be multiple biological explanations for the higher disease severity in males. Literature on COVID-19 continues to accumulate. We have new information and new papers published each day. In conclusion, it shows that men with COVID-19 have a higher risk of mortality and greater disease severity compared to females. Male sex could be considered as a negative prognostic factor. However, we need further studies to completely understand the biological mechanisms underlying this susceptibility. Having said that, this cannot be taken to mean that women are protected. It is probably a combination of biology and social determinants of health. This remains the case, but it is women who are more likely to bear the brunt of the social and economic consequences of the pandemic. Due recognition from different corners of the globe have been emerging. Mainstream media, social media, and even international journals of very high caliber have been focusing on this matter lately. We, as humans, have to raise our voice on behalf of the less privileged women. Earlier this year, UN Secretary General Antonio Guterres noted that COVID-19 could reverse the limited progress that has been made on gender equality and women's rights. Global policies have not addressed enough the gendered impacts of disease outbreaks. The response to COVID-19 appears no different. This is the basis of my talk. When you are thinking about a pandemic, you have to differentiate between what comes from being infected and what comes from being affected. So this will be the basis of my talk. The COVID-19 pandemic is not just a health issue. It's a profound shock to our societies and economies. The impacts of crisis are never gender neutral. COVID-19 is no exception. United Nations had emphasized the importance of focusing attention on gender dimensions of global health crises. In its recommendations on global response to health crisis, mind you, this was in 2016. It noted the need to incorporate gender analysis, as well as recognize the critical role played by women in crises. Yet, evidence across sectors continue to lack a gender lens. As frontline responders, women are at the heart of care and response efforts, which are in progress worldwide. Globally, women make up 70% of health workforce across the spectrum as doctors. Just a couple of examples, as doctors, scientists, nurses, midwives, paramedics, and community health workers, and account for the majority of service staff in health facilities. The majority of caregivers at home and in the community are also women. Despite these numbers, women are often not mirrored in national or global decision-making on the response to COVID. Another practical difficulty which we all face is that the masks and other protective equipment have been designed and sized for men, leaving all of us at greater risk of exposure. The needs of women frontline workers must be prioritized. The pandemic is just a reminder of the essential contribution that women make at all levels. While everyone is facing unprecedented challenges, women are bearing the brunt of the economic and social fallout of COVID-19. Women typically earn less and hold less secure jobs than men. COVID-19 brings with it massive job losses, shrinkage of economies, and loss of livelihoods. Women are particularly vulnerable to downsizing of jobs and loss of livelihoods. Women make up 39%, roughly 39% of global employment, but account for 54% of the overall job losses, indicating so there's a skewed gender scenario here, so which is true around the globe. In developing economies, 70% of women work in the informal sector with weakened social protection systems. The most impacted industries have more women, for instance, the garment industry. For domestic workers, 80% of whom are women, the situation has been dire. Women migrant workers are also more likely to hold insecure jobs. For many women, if you are fired today, it means that you do not feed your family tonight. Economic insecurity is not just jobs and income loss, which happens today. It has a snowball effect on the lives of women and girls for years to come. These women are the faces behind the headlines. These consequences won't disappear even when the pandemic subsides. As quarantine measures keep people at home with school and daycare closure, the burden of unpaid care and domestic work has exploded. Women are the primary unpaid caregivers to sick family members, including children and old people. Homeschooling is mainly dealt by mothers. It's imperative to recognize women's caregiving responsibilities and include this work in economic metrics. Now is the time to acknowledge this unpaid work and redistribute this burden. Impact on education has long-lasting consequences if we don't address enough. It will reverse hard-won gains in gender equality. In March, UNESCO estimated that the pandemic was preventing 1.52 billion children from attending school. Estimates show that an additional 11 million girls may leave school by the end of the COVID crisis. Evidence from previous crises suggests that many will not return, so mostly girls will not return. Out of education, girls face a heightened risk of so many problems, early marriage, and also sexually transmitted infections. Schools are a safe environment for these vulnerable girls. Losing this protection has huge implications. Women facing domestic violence is a deeply concerning trend. So it's described as a hidden pandemic. COVID-19 is driving a spike in domestic violence. They are victimized by this shadow pandemic. It's being intensified so many factors by money, health and security stresses, movement restrictions, crowded homes, and reduced peer support. According to the WHO, violence against women remains a major threat to global public health. In a number of countries, domestic violence reports and emergency calls have surged upwards by about 25% since lockdown measures were enacted. Building on a call for an immediate global ceasefire, the UN Secretary General in April this year appealed to end all forms of violence everywhere, on the battlefield and at home, and urged governments to address the horrifying global surge in domestic violence. All forms of conflict hold women and girls back from progress. The world leaders seem to address this issue head on. Can we as South Asians be happy about our progress? Okay, let's focus on the crux of the matter. The pandemic is deepening pre-existing gender inequalities, exposing vulnerabilities in social, political, and economic systems. These in turn amplify the impact of the pandemic. We know that women, girls, and marginalized communities have taken all three together, suffer the most in times of crisis. Is COVID-19 really less of a problem in women? The obvious is always either least understood or overlooked. I think I've done at least some justice to this vital question. The consequences will outlast the pandemic. So as mentioned here, recovery efforts must reach women. Clear gendered implications of crises need to be identified. Advocacy at the global, regional, and local levels should push for policies that respect human rights and prioritize the unique needs of women, girls, and marginalized communities. Not only during the COVID-19 pandemic, but long after we return to normalcy. Time and again, women have proven that they can confront any challenge. This provides hope that we can emerge with a stronger, more just, and equal world. We need to do better. We need to navigate these challenging times together. I appeal that both men and women have to voice together for the sake of the victimized women due to the pandemic. I'm indeed grateful to Professor Sarita Bajaj and Dr. Lily Rodriguez and the entire Eva Stride Summit team for joining hands with Sri Lanka on making the journey safe for women around the globe. Thank you.
Thank you. Thank you.
Thank you so much, Dr. Vivian. It was so inspiring. Can I now ask Dr. Usha Bala, the other chairperson from Hyderabad, to say a few words and maybe conclude the session? I don't know. Just
I think in the interest of time, we can take 2 questions maybe. So,
yeah, Dr. Usha Bala, please take
and
the
Dr. Benny
questions.
also is your other chair.
Do we have any questions from participants?
Ma'am, you can ask the first question. The 2 questions you and me.
I don't have any questions, but with great appreciation for the wonderful topic, adult vaccination, which usually is not included in our meetings. It's one of the very interesting and need of the day. Same with the COVID-19, is it really less of a problem in women? She has highlighted so well on that. Don't have any questions.
So can I ask one?
Yeah.
Same
go
to
ahead, Benny. Yeah.
Madam Monica. Madam, you've so well elaborated on the COVID vaccine. For those who have suffered from COVID, do they need to take the vaccine? And when will be the second dose? The last question, ma'am.
What you need to understand is that so far the studies that have come in, anybody who suffered from COVID, the immune response and antibodies are documented till around 5 to 6 months post the COVID episode that you have. There is a theory that the memory cells will last much longer than the antibody response. Even if the antibodies on your blood test become negative, you may still have memory cells which will protect in the future. But we really don't know how long will you be protected after one episode of COVID. So I would say that yes, you would still need to go for the COVID vaccination. I, as a healthcare worker, did suffer from COVID around 5 months back. I'm treating COVID patients in my hospital. My antibody levels are declining now. So I would definitely want to get myself vaccinated because the theory is that the memory cells will still protect me. But I don't know how long they will protect me. The second part is that the COVID vaccine tends to mutate. So whether the current COVID episode will protect you from the mutated forms of the virus, because we are already finding genetic mutations in this virus or not. So certainly as healthcare workers, even if you've had COVID, you should go ahead and get yourself vaccinated because you can't bank upon the immunity at all.
Thank you very much, ma'am.
Yeah. Shall we close this session?
So, yeah.
If there are no questions, can we close the session?
Yes, I think there are no more questions in the chat box. So I would like to thank all the speakers, all the chairpersons, and Dr. Sarita Bajaj especially for spearheading this. And we will close this session and move on to our next session. So I'll hand it over to Dr. Lily Rodriguez to invite our next chairperson.
Thank you, Rucha. Best of luck for your marathon and congratulations for your half marathon.
She has finished today, this morning, I think, one.
Yes.
Yes.
Yeah, we did a 21 kilometers today. So.
Yeah, I mean, she's very difficult to emulate. We would love to do that.
It was fun. It was fun. So thank you. Yes.
Okay.
Thank you. Thank you so much.
Thank you, Rucha. Thank you, Lady Ma'am.
Thank you, Dr. Usha Bala.
Thanks a lot. Thank you very much for all the
Thank you,
speakers.
Minal.
Yeah.
Thank you.
So now we move on to the hot topics. Women and NCDs, window of opportunities for prevention. So is Dr. Usha Sriram there? Is she there?
Dr. Usha, I can't see her.
You can't see her.
Check.
Dr.
What
Sarita,
about
Dr.
Dr.
Sarita?
I'm here. Good morning.
Dr. Dev is there.
Good morning.
Dr. Sarita, can you take over the session?
Sure. So it's a pleasure. So we have here with us Dr. Tripti Dev, who is also chairing the session with me.
Yes.
She's MD Medicine, DNB Cardiology from Madras Apollo, and she's Fellow of the International Cardiology from Rouen, France, and Senior Intervention Cardiologist, Fellow of the American College of Cardiology, and a Senior Consultant Cardiologist. Thank you for joining us, Dr. Tripti Dev, and a very, very special thanks to Dr. Kirti Da, who's with us in our hour of grief. Very sorry to hear about that. And she will be leaving us after she gives her talk. As Lily said, these are hot topics. Women and non-communicable diseases, that is women and NCD. So what is the window of opportunity that we have for prevention? And we have a brilliant faculty lined up, talking right from pre-pregnancy all the way through menopause. And Dr. Kirtida Acharya from Kenya, she's going to be talking to us from pre-pregnancy, moving on to pregnancy. She's MRCP from Ireland, consultant physician endocrinologist, MP Shah Hospital, Nairobi, Kenya, national chair of the Diabetes Kenya. She has won the Tommy Adamson Award and the KOGS Prize for the best student at University of Nairobi. She's trained in diabetes and endocrinology at Antrim University Hospital, Liverpool, and Glasgow Royal Infirmary, UK, from 1995 to 2000. She's been actively involved in writing the first national diabetes strategy and clinical guidelines for Kenya, committee member of the Kenya NCD Alliance, Kenyan representative Pan-African Endocrine Society, published and presented widely at national and international diabetes and endocrine conferences, supervised numerous postgraduate theses, and she's a very passionate diabetes advocate, training all cadres of healthcare workers and setting up diabetes clinics in rural Kenya and regularly organizing patient empowerment workshops. And she has a lot of extracurricular interests: poetry, painting, singing, cooking, and dancing. She's former lecturer, University of Nairobi, and currently the honorary lecturer there, past faculty at Aga Khan University Hospital, Nairobi, as well as the past secretary of the Kenya Association of Physicians. Over to you, Kirtida.
Thank you. I will just start sharing my screen.
Yes.
Are you able to see my slides?
Yes, yes, we can. We can hear you as well.
Okay, thank you. I'll just switch my video. And I lost connection for a minute. Yeah.
No, you're there. You're very much there.
Okay, thank you. Okay, so I'm going to be discussing throwing open windows of opportunity for prevention in pre-pregnancy and pregnancy, and what we can do about NCDs globally. And I'm very happy to follow on after COVID, because COVID has changed the whole face of NCDs globally. So I'll just get started. So maternal mortality remains unacceptably high, especially in low and middle income countries globally. And there is an interplay of so many factors: socio-economic, cultural. Every culture globally is different, whether it's India, Africa. A woman's education makes a difference as well. And it's a double-edged sword. More highly educated women may have different impacts on their NCD outcome. Less educated women, there is an urban-rural interplay as well. And women's health is, right from womb all the way preconception, the girl child, and all the way to elder. As a woman matures, there is a big impact on NCDs. And like I said, COVID is really changing. It's posed a new. It's like colliding pandemics are happening, and we really need to be prepared for what's going to come as we move on. Of the approximately 130 million pregnancies, I also have this in a pie chart, so I won't take too long on this, but I'll show it in a pictorial form. There is a big impact with NCDs, whether it's hyperglycemia, whether it's hypertension, pre-hypertension, both sides, undernutrition as well as obesity, maternal anemia, mental health, which is something that is so underlooked for unless we look for it. And we know that depression in a mother also, there is fetal transcription, and that's something that we never, in so many cultures there's taboo about even looking at depression and how we manage it. So that's something that maybe is a forum for another. It's something we need to actually look at and see how that transcripts in future generations. I will not even be able to discuss each and every NCD because of time, so I've picked on the ones that are more topical. But in certain cultures, there is in certain countries, like in Africa, we have sickle cell disease. We have so many other NCDs that are not looked at. Cancer is also something that is beyond the scope of what I can discuss today, but the NCDs are just growing in number. Cardiovascular disease, stroke, and these are complicated in pregnancies and preconception. And the earlier we start, even before a lady gets pregnant, rather than trying to close the door of the stable after the horse has escaped, it really impacts on maternal health, morbidity, mortality, and the health of the child. So the economic cost of NCD is something else that when I was trying to search, it has really not been very well researched or documented, especially in the low income and middle income countries. But it really has a big impact when we are preparing, for how we apply for our resources. Again, like in Kenya, we just recently formed an NCD alliance, and we really have to fight for resources. The communicable diseases get all the, the resources, whether it's malaria, HIV, TB. I'm not saying it's not important for them to get the resources, but the NCD docket, though there's so many diseases that come in, we get very limited resources to do our programs and our advocacy. Pre-pregnancy and pregnancy interventions really have huge benefits and long-term outcomes because it plays across generations. So it's very important that we lobby for them. And we know that every year there are so many women who die in childbirth, especially in the less privileged countries, and children as well, we lose them. And there is huge preventable maternal morbidity and mortality as well as childbirth. So this is the pie chart I was talking about, where in every million live births, there is anemia due to whatever cause, and undernutrition, obesity, hyperglycemia, hypertension. And this is just the tip of the iceberg because this is where we are able to get data. Many women who live in rural areas, who live in underprivileged communities, do not even get to a health place where health center where this data can be collected. Now there is a big link. This was in one of the Time magazines some years ago, where there is a huge interplay between low birth weight in a child, high birth weight. There are all these hypotheses, Barker's, Peterson's, maternal weight that plays a role in the future child, where obesity, diabetes, cardiovascular disease, stunting, undernutrition in the mother, anemia, malaria. The weight of a child will predict. It's like looking at a glass ball and decide and predicting what will happen. And it's a U-shaped curve. What will happen to the future of a child? So really, you're giving a start to a child, their future life, in what happens to the mother, the nutrition, the emotional well-being, the parameters. Are we even looking, for the glycemia, the hypertension, the cardiovascular well-being? It's extremely important. So maternal health and the future NCDs and the health of the child, it's extremely important we catch the ladies pre-conception, during pregnancy, the health of the mother. So there is a very huge, like this is just in more detail. We know about how insulin resistance keeps going up to 24 weeks, and that. But even before we catch somebody with GDM, there is diabetes in pregnancy. So besides gestational hyperglycemia, there is a nutrition aspects, the anemia aspects, cardiovascular disease. There is other teratogenic factors, simple things like giving folic acid for preeclampsia, something like low dose aspirin. There are so many, there's so much interplay. We all have polycystic ovarian syndrome in our communities that we need to look for the ideal, according to ethnicity, what is the ideal weight that a lady should be. And again, if we empower and educate our patients and talk with them, we have multidisciplinary teams, whether it's the nutritionist, the endocrinologist or diabetologist or the physician, healthcare workers, empowered diabetes educators. We have social workers or community workers going out there and giving these messages. It will really impact on the pregnancy outcomes. And again, mother to child transmission, obesity is something that is often forgotten about. In many cultures, a pregnant woman is fed and overfed, and then this carries on in the next generation. So we really need to also talk to communities. We need to empower, people in the villages, people in the rural areas, because NCDs are really impacting on maternal health. And like I said, it's undernutrition, wrong nutrition, too much carbohydrates in certain communities where, at the moment with with COVID, there was a lot of people who lost their jobs. Food became an issue. Women who are pregnant had issues. So again, there is programming earlier in pregnancy. There's vulnerable communities, and we need to really cut our coats according to the cloths. So hyperglycemia during pregnancy, we know GDM is on the rise globally. Again, the data in so many countries, data on GDM is lacking, advocacy programs are lacking. So we really need to look for this data, and we really need to see what we can collect. The GDM prevalence varies from between 1.5% to even 50%, depending on the community that you're looking at. I know India is one of the highest prevalence of GDM. Here in Africa, where data is often lacking, advocacy programs for GDM are lacking. Even obstetricians and gynecologists, when we talk to them, very often we are called to help deliver babies which are very big because they need to do a cesarean section because the baby is very big. And really, that is really not something that we are happy with as diabetologists. So we really need more advocacy programs to prevent, very bad outcomes in pregnancy because of lack of cohesiveness between obstetricians or gynecologists and diabetologists or physicians. So we know pregnancy outcomes are linked to maternal hypoglycemia. We know that from the HAPO study and other studies. And we know as the sugar rises, so do the complications in the mother as well as the neonate. And there are so many studies besides HAPO that came on as well to show that. So we know the maternal complications are there besides gestational, hypertension, preeclampsia, polyhydramnios, increased need for cesarean section, and the neonatal complications are there as well: premature deliveries, macrosomia, LGA, SGA, admissions to NICU, neonatal hypoglycemia, as well as neonatal respiratory distress. Now, GDM impacts maternal outcomes. Besides the hemorrhage, hypertensive disorders, difficulties in delivery, and we know that hyperglycemia is just the tip of the iceberg. Besides, we don't have to be glucocentric. There is other issues as well. Once a woman has GDM, we know that there are other issues as well. Women with GDM are at risk of future type 2 diabetes. As time goes on, we have to look for type 2 diabetes. They're also at higher risk of metabolic syndrome, cardiovascular disease. In future, diabetes begets diabetes, and we really have to be on the lookout for them. And even as we adjust for other factors, age, ethnicities, and other comorbidities, we know that these are future cardiovascular patients, and the NCDs are all interrelated with each other. So postpartum also, we don't have to lose these women to our follow-up. Lifestyle, metformin, all this plays a big role. And when the women were followed up in studies like the DPPOS 10-year follow-up, taking an active role with our multidisciplinary teams, lifestyle, metformin, it really reduced the progression to diabetes, as well as even in the nurses health study, physical activity, simple physical activity, didn't even have to be metformin, reducing the BMI really impacted in cardiovascular outcomes and future diabetes. However, when we look on the ground, we know again in low and middle income country, a lot of women, like I said earlier, are not tested for diabetes during pregnancy. So we need to start at grassroots level and empower the women themselves, responsible media, advocacy programs, because like I said earlier, lots of complications arise, and the global diabetes burden is going up post-COVID, the NCD burden is going up, and with a lot of unplanned pregnancies as well. So we really need to see what we can do. The challenge is, out of all the pregnancies, detection and treatment, optimum follow-up, the number of healthcare practitioners and obstetricians per patient ratio, nutritionists, how many qualified and good nutrition care, diabetes educators, when insulin is needed, how adequately are we treating, making sure that we get adequate follow and cover up, the pricing of strips, glucometers. This is all a challenge in where some of us practice, and many times the women are lost to postpartum follow-up and lifestyle advice as well. So these are the real challenges on the ground. So the fetal environment, the mother's peri-conception, preconception health, we have to, whether the fetus gets advantage or handicap, it really depends on us as healthcare practitioners. So even when a woman has polycystic ovarian syndrome, whether she's diabetic, whether she's type 1, type 2, we lay the foundations even before a child is conceived, and we give that handicap or we give that advantage. So as healthcare practitioners, we really need to decide whether we're going to start off a child with a handicap, and we have a huge chance of a window of opportunity. Even before pregnancy, preconception, we have that window of opportunity, and we need to open it wider to provide those pre-counseling antenatal services and reduce all the traditional maternal and perinatal morbidity and mortality factors to our mothers and children. And we have to integrate the NCD clinics into even the antenatal services so that we can help salvage mothers and children. There are many ways in which we can work in our units, and there are ways like this is something I borrowed from my colleague in India. So there are stickers that can be put on if a child has been born to a GDM mother, so that for follow-up, the child could also, this could be incorporated in the pediatric clinic. Here in Kenya as well, we work closely with our pediatric colleagues to make sure that children born to mothers with GDM are also followed up. And even I myself, when I'm dealing with mothers of GDM, or I see family, one of the questions we ask every diabetic patient we see is, what was the birth weight of all your children? And we also advise them to make sure that the offspring are also followed up with lifestyle. We have to work towards sustainable development goals. FIGO has taken it upon themselves, for call for greater action, but we don't just all of us have to be advocates for mother and the mother, and not just the girl child, for every child, to reduce complications. So we all have to practice parsimony and look at what our finances are, what our resources are, and what our infrastructures are. But we don't have to wait for 24 to 26, 28 months. I like the deep sea guidelines, the fifth, national guidelines, because doing, fasting sugar in the first trimester, and then also doing GTT, which is non-fasting, the 75-gram, challenge, non-fasting, picking up a woman at the first antenatal visit. It really, there's so many guidelines out there, but it really makes a difference. So this is a very good guideline, which gives you options depending on how resourced your setting is. Starting right from the first trimester, measuring a fasting sugar or a random sugar or an HbA1c. And then if it's negative, performing a 75-gram 2-hour OGTT at 24 to 28 weeks. Make sure nobody slips through the net. And then making sure later on you can follow any guideline you want, WHO, IAD, PSG. People follow different guidelines, Carpenter and Coulston, whichever guideline they want, but we want to make sure we are not overpicking and we're not underpicking. I'm not giving a talk on gestational diabetes or diabetes in pregnancy. I'm just looking at what we can do to make sure we don't miss window of opportunities in NCD. So I won't be able to go in detail what we can do, but we should not have excuses that we are in a limited resource setting and we can't do this test or that test. There are many ways in which you can screen, pick up, and make sure we don't miss our patients, even if they've not come fasting to our clinics. In the postpartum period, we should also not miss out, and we have to support breastfeeding. We know breastfeeding also prevents future diabetes. There are studies that show it, and contraception advice is also important. Advice on pregnancy spacing, because we know one GDM promotes a second GDM, and retest women at 6 to 12 weeks postpartum with GDM, and make sure that the women are being followed up. Vaccination for children is also important, and also following the child who's born to a mother with GDM. Now, diabetes in pregnancy is not always GDM. There could be pre-existing diabetes. There's true GDM and there's pre-existing diabetes. I already talked about both fetal and maternal morbidity and mortality, so I'm not going to go through this. Like I said, my talk is not on GDM. I mentioned the hyperglycemia and pregnancy outcome study as well. So, but we know we've actually seen this on the ground, the neonatal hypoglycemia, which is very real, the shoulder dystocias, the increased cesarean rate, which is expensive for systems where the healthcare is not provided and the patient has to pay for it. And many of these young girls who are getting pregnant, they cannot provide, the medical costs. So we know that hyperglycemia, not just overt diabetes, is associated with adverse pregnancy outcomes. Medical nutrition therapy is many times with gestational diabetes, we don't even need to go to pharmacotherapy. 80%, 90% of patients can be managed with medical nutrition therapy. We need a very good nutritionist. And again, there are ethnic and cultural differences. We can't start a new diet on somebody. So we consider what they're eating. I cannot again go into each of these are talks in their own rights. Physical activity we know is very important, but we again look at make sure the patient is not having other complications. So the physical activity advice has to be collaborated with the gynecologist as well, so we don't do more harm than good, but it's very important. Pharmacotherapy has to be given to the patient if the lifestyle doesn't work within 1 to 2 weeks or there's marked hyperglycemia. So very important to monitor, and or if there's macrosomia, evidence of macrosomia. Insulin therapy is the mainstay of treatment in patients who are not maintained on lifestyle alone. Human insulin is safe, does not cross the placenta. We can use basal bolus, and there are insulins. We can use insulin aspart, lispro, or detamir. We do not use glargine. The oral hypoglycemics, most of us prefer to use metformin. It is safe. Many times with PCOS, it has also been continued once the patient is pregnant. Recently, there was a paper about sitagliptin preventing miscarriages, but again, that is something that is controversial. FDA has not approved it. So it is just a food for thought. There are many studies on metformin, and most of us are careful with metformin if we are not using insulin. So long-term care of GDM, follow up the patient's counseling, lifestyle is very important. Other considerations in overt diabetes, look for retinopathy, very important. And even pre-conception, we treat the retinopathy. Renal function, very important to manage. Statins are to be discontinued, but look out for neuropathy, nephropathy. So pre-conception checklist, pre-conception, try and aim for HbA1c of 7 or lower. Sometimes we even try for 6.5, depending on where we are practicing. assess for and manage any complications even before a lady gets pregnant, switch to insulin if on oral agents. Folic acid is very important. Discontinue any potential embryopathic medications like ACE inhibitors, ARBs, and statin therapy. These are the risk factors for GDM, PCOS, pre-pregnancy, obesity, family history, age, previous abnormal glucose tolerance, poor obstetric outcome, their ethnicities, which we know Asians and Africans have this, and previously big baby. So glycemic management during pregnancy, I'm not going to go into this because of time, but nutrition counseling, and I already talked about insulin and monitoring. Prior to hospital discharge, very important to counsel, empower, and educate your patient. The nurse is very important in this. And, discuss breastfeeding, very, very important. Encourage it, contraception, 6 to 12 week, the glucose tolerance. And then depending on where your patient falls in, diabetes, impaired glucose tolerance, or normal, you still follow them up and give them their advice. Hypertension in pregnancy is very important. It's the commonest medical disorder seen in 1 in 10 gestations, and it's a major cause of pregnancy-related maternal deaths. We must, at every antenatal visit, even preconception, please measure the blood pressure. The definition of hypertension in pregnancy is 140 millimeters over 90 or greater, and it has to be at least 2 readings at least 20 minutes apart. And there is a classification of hypertension in pregnancy. There's chronic hypertension, preeclampsia, eclampsia, where you get proteinuria, or there is preeclampsia superimposed upon hypertension, and there's gestational hypertension. Time will not allow me to go into greater detail, but there are consequences of hypertension. Every NCD comes with a consequence. So there are maternal complications, seizures, hepatic damage, the HELP syndrome, renal dysfunction, increased preterm delivery and abruptio placenta. And then there are fetal complications, the long-term complications as well. There will be next PET in subsequent pregnancies, cardiovascular complications, including cardiomyopathy as well. The treatment, there is a lot of medications we can choose from: methyl dopaclonidine, labetalol, nifedipine, hydralazine. It's very important to work together with the obstetrician, and the physician or diabetologist have to work together. ACE inhibitors and ARBs are contraindicated, and many times we have to work together with the work in teams, and communication is very important because the patients are very anxious, LA anxiety. I've not been able to discuss cancer, which is an NCD, but we have had ladies who are pregnant and they have cancer, surgery, options, chemotherapy. The oncologist and the diabetologist have to work hand in hand. Mental health, I've not been able to discuss the anemias, the thalassemias, and the sickle cell disease, the respiratory, asthma, how do we manage that? So the NCD, is such a wide topic, but NCDs, this is my conclusion slide, madam. So a life course perspective and premodal prevention through all phases of a woman's life will prevent NCDs across generations in the next generation. We have to screen, intervene, and advocacy at all levels is important. I cannot overemphasize, this is not a one woman or one man show. The multidisciplinary team, nutritionist, obstetrician, diabetes nurse educator, the family, the whole family has to be involved. What is the diet? The mother-in-law might be saying, give lots of ghee, give lots of sugar for increased breast milk. But if the woman is GDM, we have to intervene at that point. COVID-19 has brought new challenges, so we have to think out of the box, new strategies. What better place to begin this transformation of NCDs than where life begins or before life begins? In every challenge, I believe, lies a hidden window of opportunity. If more hands are pushing, more windows and more doors will open. So universal screening for GDM, all the NCDs, we need to improve mothers' health, children's health, patient empowerment, rural outreach programs. Like in Africa and India, the women in the rural areas are suffering the most. We need to be their voices, and we need to go and open their windows for them. Screening, good follow-up. And I think we all need to breathe fresh air and open our windows and doors. This is my very last slide. Here's to strong women, happy women, healthy women, and children, and men as well, a whole society. So may we know them, may we raise them, and maybe be them. Thank you very much. I'm very sorry, I will actually have to go.
Thank you. That was absolutely wonderful. And thank you for being able to join us. So we'll not take any questions right now. Yeah.
Dr.
I will be happy
Kirtida,
to, you can send me questions by email, and I will get back to whoever
See
sends me questions.
I just want to say a last word to Dr. Kirtida. You have covered such a wonderful topic, and you have given us food for thought for the entire day. I think if there was time, you would have spoken the entire day today. You have covered so much. Thank you so much.
Thank you.
Thank you for
that
inviting me as always.
Wonderful.
And thank you for your graciousness.
Thank you.
Namaste.
Namaste.
Over to you, Dr. Tripti. You are mute.
No, she's not.
Can't hear her.
No, can't hear her.
I can't hear her.
Yeah.
Ma'am, open the PPT first, then click on share screen.
But
Full screen, please.
Yeah, am I audible?
it's a pleasure to have Dr. Pramila Kalra with us. She's professor and consultant endocrinologist at Ramaiah Medical College and Hospital, Bengaluru. She's an undergrad and postgrad in medicine from Lucknow and DM from SGPGI, Lucknow. And her major interests are in thyroid disorders, PCOS. She has 67 publications in international journals, 23 chapters in books, and she has presentations in national and international conferences. She's a member of several prestigious societies, and she has graduated with honors, been awarded gold medal, won prizes throughout her career, and she has won the best oral paper presentation in the thyroid meeting 2013-19 and the A.B. Gandhi Award for Excellence in Endocrinology. She is currently executive committee member for the Karnataka RSSTI and executive member of the Indian Thyroid Society. And she won the fellowship of the American College Association. She was awarded that in 2017. Over to you. So moving on with the lifespan. So from pre-pregnancy to pregnancy, now we are moving on to childhood and adolescence. Dr. Pramila Kalra.
Thanks. At the outset, thanks Dr. Lily Rodriguez for inviting me for this talk. It's really interesting, and I congratulate her for doing such a nice conference and choosing such nice topics. I thank Sarita Bajaj ma'am for introducing, and I thank the chairpersons. And I'll be now talking about women and NCD, the window of opportunity for prevention in childhood and adolescence. Now, this is a thing because now whenever we talk about the healthcare or the things to be incorporated, we don't much talk about the things which have to be done during childhood and adolescence. So this topic, I'll be just going through what exactly are the things which we can do and what exactly are the data which is available. So in next 15 to 20 minutes, the scope of my talk would be the non-communicable diseases, the burden of the non-communicable diseases. I'll also be talking about the risk factors associated with it. And I'll be also talking about a bit about the preventive approaches for sure. So if we talk about non-communicable diseases, now they are actually non-communicable. They are chronic, but some may present acutely, like they may present with cardiac event acutely. They may present with the MI. So these presentation can be acute. They may present with hyperglycemia. So they can present acutely, but they may be chronically present. The risk factors may be there for long. They are mostly lifestyle diseases or associated with the changes in the lifestyle. And the impact is huge, leads to a lot of deaths. And we know that almost around 70 to 71% of the death globally are attributed to non-communicable diseases. Now, when we talk about actually the non-communicable diseases, there are actually 4 which according to WHO are included. That is chronic respiratory diseases, cancers, cardiovascular disease, and diabetes. But we know that as diabetologists or endocrinologists or as physicians, we don't stop at this. We further go into the depth of it, and this is how we label it then. So this is like not only diabetes, it's also mental health, it's bone health, obviously respiratory diseases, obesity and metabolic syndrome, cancers and thyroid. But I won't be dealing with or talking about all. I'll be mostly talking about the diabetes, metabolic syndrome, and to a bit about bone health. Now, we know that the risk factors for non-communicable diseases during adulthood can be definitely mitigated with appropriate approaches early in life. It can be done from the start, from the time the child is born, or to the time even before the child is born and the child is conceived, to the time during pregnancy and later. infancy, childhood, adolescence for sure, that's what we are discussing. So that provides a good period of opportunity because that's the time when intervention can be done. And we all know that children are very adaptive, or adolescents may not be very adaptive, but children are very adaptive. So if we teach them something, they adapt to it. Now let us see what is the burden of the disease. Now this study all of us are aware about. So they tried to see the healthy life years and the disease associated or the disability associated years. And what they found that the highest globally observed healthy life years at birth for both men and women was actually in Singapore. This was a 75 for females and 72 for males, but lowest was in the Central African Republic. So we know that obviously as the countries become more better with the finances, these type of things improve. And they also found that the disability affected life years remain actually largely unchanged from 1990 to 2016. There was decrease in the communicable maternal and neonatal nutritional diseases, but there was an increase in the non-communicable. So meaning to say that non-communicable diseases are increasing. And the reason is very obvious. If you see the epidemiological burden of obesity, it's going on increasing. It's becoming like an epidemic. And we know that even the children who are aged 5 years or even under that, they are becoming more obese. And we know now unfortunately with the COVID times we are even seeing kids becoming more obese because they are sitting at home, not playing. Outside physical activity is very less. They are eating at home only and they're not going out to play or exercise. And if you see old data, 1975 and before, the obesity was relatively rare. And I would say that like when we were doing our DM around 12 years, 13 years back, that time the obesity was not so rampant. But in the past 10 years, we have suddenly seen an increase. And the children are coming with more and more obesity. Type 2 diabetes is happening much early at 12 years, 14 years. And cardiac disease obviously is happening earlier than what it used to be. So everywhere in the world, the data is the same. It's not only in India, it's not only in developing countries, it's not only in underdeveloped, everywhere, it's everywhere. So everywhere there is a high burden of non-communicable diseases, which is increasing. So it's like an invisible epidemic. We know that COVID is a pandemic, but we know this is also an epidemic. It is an epidemic of non-communicable disease. And this is one of the world's leading causes of death. And many of these are actually preventable. Like we can prevent malnutrition, we can prevent tobacco use, harmful use of alcohol, physical inactivity can be taken care of. So diabetes can be taken care of to a great extent, they can be prevented. Cancer, some of the preventable cancers, yes. Cardiovascular diseases, yes. Chronic lung disease also to a great extent, yes. So we have to follow a life course approach. We have to intervene at the maternal and child health level before delivery, when the child is conceived, and during childhood and adolescence, and that can actually influence the further risk. So if we see the risk is established very early in life, so there may be some epigenetic mechanisms like what the diet the mother takes, what type of food she takes, what type of stress level there is, what are the other drugs she is taking, what is her nutrition status, all that makes a difference, whether she is a diabetic or not. If the child is born preterm or the child is born low birth weight, those children may have more propensity to get obesity and metabolic syndrome later. So prenatal, maternal undernutrition, all these can predispose to further problems of obesity. We all know about this hypothesis of fetal origin of adult disease. So we know that coronary heart disease and type 2, these may originate through these biological phenomena, which we say the plasticity and the compensatory growth. The child or maybe born preterm, low birth weight, and later on, because of nutrition, fast catch-up growth, they may develop obesity, metabolic syndrome. And children and adolescents are actually heavily impacted by these NCDs. The data says that 1.2 million under age 20 died of NCD in 2002. 25% of obese adolescents have signs of diabetes by the age of 15. When I say signs of diabetes, it may include obesity, increased waist circumference, acanthosis nigricans, which tells us about insulin resistance. And we know that mental health disorders, motor vehicle trauma, homicide, suicide, they also cause significant morbidity and mortality. So mental health is also one important factor. And it is more so important in the present times where children are also suffering with mental health issues. So if you see in 2013 also, at least 42 million infants and young children were obese or overweight. And this number is actually estimated to rise to 70 million by 2025 if the current trends continue. And if you see, this is a very alarming data. In 2014, almost half, 48% of all overweight and obese children aged under 5 lived in Asia and 1/4 lived in Africa. Now, this is very surprising because why it's happening? They are getting more nutrition, or what type of nutrition they are getting is important. They may be eating high carb, they may be lacking protein in the diet, they are born underweight, their mothers are malnourished, early marriages, they have too many kids, and the child doesn't get the proper nutrition during childhood, and later on they get more nutrition, or they eat the wrong type of food, exercise is not there, physical activity is lacking. And if you see, the number of overweight children aged under 5 in Africa has nearly doubled since 1990. So it has doubled from 5.4 million to 10.3 million. So onset of risk behavior actually starts during the childhood time. And if you see globally, around 100,000 young people start smoking each day. And 90% of adults who smoke will give a history also in your OPD. And also this is the data that they started as children or youth. Adolescent alcohol consumption is very common. It risks the brain development. There is non-intentional injury which can happen. Violence can happen. Overweight and obesity definitely is increasing in high income countries, but it is also increasing alarmingly in low and middle income countries, and diabetes and other diseases like obesity, metabolic syndrome are increasing. And if you see the data of the Caspian 4 study also, they tried to see the relationship between the dietary inflammatory index. They used some questionnaires to evaluate the diet associated inflammation and anthropometric indices in children and adolescents. And they did this study in around 5,427 school children. And they actually found that there was very, very high dietary inflammation index in these children, meaning to say that their diet was not what they were supposed to be taking. And this was a study which was carried out in New Delhi, and they did it among 510 students of 9 to 12 class, age group of 12 to 18. And they found that there were inappropriate dietary practices, more of fast food consumption, low fruit consumptions, low physical activity, higher level of experimentation with alcohol, because that is the age when children try to experiment. And to a lesser extent, smoking, high prevalence of obesity and hypertension also in the school children. So definitely we know that this is something which is coming up, and we need to proactively take care. So how to prevent? So we know that life course approach to prevent these NCDs and the risk factors definitely will improve the child and adolescent health. So children are malleable. We can turn them anyway. We can teach them proper healthy practices. We can teach them unhealthy practices. So we know that they can be taught wrong things by marketing unhealthy products in a way that it interests them. Many grow up in environments which are not conducive to adoption of healthy lifestyle, like parents may feel participation in sports is going to waste their time. So how to approach, how to prevent? So it's a cross sector, it's a government approach, society approach, individual skill approach, change the behavior of the child. It can be done at the home level, can be done at school level, can be done at the governmental level, or it can be done also at the whole of the society or the country level. Actions of public agencies and private companies is required, definitely. Implement the appropriate programs. That's very important, implementation. So it should collaborate with maternal health, newborn health, child health system, promoting education which benefits both lifestyle choices and health outcomes, community productivity and social stability, and also the living conditions, adequate sanitization, how the sanitation has to be maintained, how healthy hygiene has to be done, what is the use of open spaces where children should have place to play. What are the policies or the government, what policies government should adopt to promote this child health and adolescent health. So we have to work on eliminating risk factors early, like tobacco use, harmful use of alcohol, unhealthy diet, reduce salt intake, eliminate the trans fats in the food chain. The children have to be taught how to read the labels. The parents have to be taught how to read the food labels, reducing sugar. So what does UNICEF say? UNICEF has very good advocacy on that. They say that we need to have laws and regulation that reduce children and adolescents' direct and indirect exposure to tobacco, alcohol, and other illicit drugs. Laws and regulation which reduce these exposure of these children and adolescents to unhealthy food and drinks, like through the media and at point of sale. Assurance of funding for universal screening and simple treatment of NCDs across the life cycle. Policies to support and protect the health, integration of the life skills. Now, very important is school-based screening for NCD risk. This is very important because if this is incorporated thoroughly in our country, it can go a long way. Promotion of healthy food in and around the school premises, physical activity, standards for the built environment and public amenity that foster physical activity, and definitely not to forget individual safety. Unhealthy behaviors, how to do that. Comprehensive family-centered medical home-based care system, which integrate primary care for children and youth with community public health system. These are useful models. And young people themselves to be engaged as active participants. Like we are doing few studies in our village, which is attached to our medical college. And there we are trying to see that the young people are engaged in these activities, because if you engage them, the others connect to them more actively, and they think that they are of their age group, and they actually agree to the thought process which is there in those kids as well. So the impact of these communicable diseases on children and adolescent life definitely suggests that there is a need of joint effort from the parents, clinicians, and educator to ensure that the children and the adolescent have a positive development of self, and they accept this and they have a coping strategy. They should not feel that if the child is obese, the child should not have any negative emotional experiences, and all these things also need to be taught. So we can prevent them by addressing the diet, physical activity, stopping the tobacco and alcohol use, cost-effective measures, and preventive strategies which can help in preventing these NCDs. Tobacco use, if you see, roughly 1% dies from a tobacco-related disease every 6 seconds, which is equivalent to around 6 million people a year. And nearly all the tobacco use begins in youth. This is very unfortunate, and young adulthood. 9 out of 10 smokers start before the age of 18, and 99% start before the age of 26. So ways to prevent, we should have strict laws, taxes that increase the cost, school policies about tobacco use, strong tobacco-free role models should be there. This is very important because children and adolescents see the role models. Family expectations are very important. Family has to tell what they are trying to do, or if somebody is using in the family, the child should not think that that is the right thing to do. Education about the risk and consequences of using tobacco. Media messages, media can do a great job in this, that counter tobacco advertising. Alcohol, again, we know that's the third leading risk factor for poor health globally, and harmful use was responsible for almost 6% of all the deaths worldwide. So WHO global strategy says reduce the harmful use of alcohol, regulate the commercial and public availability, and we have to have policies where the children or the adolescents should not have access to it. They have to increase the minimum legal drinking age. Enacting zero tolerance laws makes it illegal for people under the age of 21 to drive after any drinking. Now, very, very important is healthy diet. Now, food, diet, and nutritional status are important determinants of non-communicable diseases. Unhealthy diet and physical inactivity are among the leading cause of NCDs. And we know that children and adolescents are exposed to food and diet that augment the risk of NCDs. So this is very important. Now, IAP has come out with a very, very nice thing with an acronym JUNCS. Now, this is JUNCS, which means junk foods to be avoided, ultra-processed food to be avoided, nutritionally inappropriate food, that is caffeinated drinks, colored drinks, carbonated drinks, colas, beverages, and sugar-sweetened beverages. These are the things which come under the category of junks. They say that the children should be promoted to take regional and seasonal fruit, not some exotic fruits. And they should also not promote the use of fruit juices. And caffeinated drinks should not be consumed by children and adolescents. And very nicely, they say use the traffic light coding system in schools. This is very important because if we see the kids go to the canteen and pick up the thing which they should not pick. So this should be strictly implemented by the government in all the schools. And it also suggests communication, marketing, and policy and taxation strategies to reduce the consumption of unhealthy food and to increase the consumption of healthy foods by this junk food acronym. Physical activity. Moderate, regular physical activity is the key to reduce NCDs to a great extent. And if you see, nearly 2/3 of the world population is not doing adequate physical activity. So it is one of the lead causes of causing NCDs. So physical activity promotion in children and adolescents can reduce the burden of NCDs to a great extent. If you see, 1/4 of the adults and 4/5 of the adolescents actually did not meet the WHO physical recommendation. And very important, I have highlighted, is with women and girls and older people were less active than men. And this is known because some societies, girls are not allowed to go outside because of many reasons. And they were found to be very much less physically active as compared to men, boys, and younger people. And we know that this is one of the risk factors for NCDs. So we have to see that women or children or girls and adolescent girls are promoted to do more physical activity. And also walking, cycling, any form of physical activity is good. School curriculum should have this healthy eating, physical activity, and body image classes. Increased sessions should be there for physical activity, and development of fundamental movement skills throughout the school week should be there. It's not that we should have one physical activity period once in a week in the school. That should not be the case. It should be every day. Improvements in the nutritional quality of the food which is supplied in schools. So other things which can be done, interventions like environmental and cultural practices. Parents should be taught what is healthy eating, what is a healthy child. Teachers should be taught because they can actually tell the student or the child who is going to school, and they can understand better and carry the same message to their homes. Parents support home activities that encourage children to be more active, eat more nutritious food, spend less time in screen-based activities. Unfortunately, that's not possible at the present moment, but soon, hopefully, we pray that this should be possible. Not to forget, last thing, calcium intake. In our country, this is very, very important because though NCDs don't include osteoporosis as a major thing or the osteomalacia, but what I would say in India, it's very important, especially for girls. A lot of societies still don't give dairy products to girls, thinking it's costly, should be given only to boys, should be the thing which should be targeted in India. Study showed age 9 to 11, the majority of girls did not actually meet the calcium recommendation. And we know that lesser the calcium intake, they will have weaker bones and they will develop osteoporosis later. Adequate intake of calcium and vitamin D, sunlight exposure, that can only happen if they go out for physical activity and get exposed to sunlight. And they should have adequate intake of milk products. Health system challenges are not to be forgotten in our country. Incorporation to the system is very important. Whenever we talk about these health policies to the higher ups, they tell us how is it going to help the present problem. It's not going to help presently. It will help us after maybe 10, 15 years when the new generation becomes adult generation and then they are healthy. That will translate at that point of time into a better outcome of the expected life expectancy and many other things with the better quality of life. Allocating budget is very difficult for these things because some of the policymakers don't find this to be the thing to be targeted. Recruiting staff, and the staff should be motivated enough to work. That's what, as I told in our village model, what we are trying to do is we are trying to recruit the villagers only, the younger village population to work for this because they are the ones who can have a better impact because they are the ones who are in contact with that population and they are of the same age group. So to summarize, if we have to prevent NCDs from the adolescent and the childhood times, we have to influence the government policies. As physicians, our job is to make these policies and to show to the government that it helps. Advocate every child's right to health. Here I have not written a girl child or the male child, but what I mean to say is it's every child's right to health. Strengthen the service delivery. This is very important. Policies are made, but it's not carried down to the root. Empower communities. This is how I think NCDs can be prevented to a great extent in our country, because if we empower our communities, they can do a much better job rather than we trying to do everything. So as physicians or doctors, it's our duty to empower these communities, and then they can carry the message forwards to the next level. So with this, I end.
Thank you, Dr. Pramila, for a beautiful, lovely, and very thought-provoking and societal, differences we have to make. And this is a real challenge, and you have spoken so well about all the challenges which we are facing for our young and new generation, for the adulthood to become the healthy and wealthy adults. That is very good. Thank you so much, Pramila, for such a
Thank you.
wonderful lecture. Very nice of you.
Thank you.
Thank you. Now we
Yeah.
call upon the next speaker, or would we have some questions here?
No time. We are
Okay.
running. Yeah.
Okay, then we call upon the next speaker for adulthood, Dr. Bhavna Sosal from Bangalore. She is MD, MRCP, FRCP, diabetologist at the
Slideshow, ma'am.
Daikon
Slideshow.
Hospital, Bangalore. An opportunity for prevention in adult women. Dr. Bhavna.
Yeah, thank you so much for the introduction. Thank you, Dr. Lily, for inviting me to your wonderful event. I think my job today is going to be fairly simple because I'm going to mostly be giving a short summary of all the different things we need to do in the hospital when we actually see a lady walking in. It could be someone treating diabetes, someone treating hypertension, someone coming in for a cardiac problem, or just an annual health checkup, or someone going to gynecologist. So what are the different things that we could do as doctors to prevent NCDs in adult women? My job's also been made easier because a lot of things have been covered across several talks yesterday and today. We've had talks on cancer, we've had talks on thyroid, pre-pregnancy counseling, and adolescence. So now what I'm going to talk about women will also, and adult women will have a lot of overlapping features that have already been discussed in several talks. I'm not going to be looking in detail on numbers and statistics because I believe that is something all of you are already familiar with and you could go through in your free time when you wish to. So let's say a lady comes into you. What are all the different basket of things? As Dr. Pramila said earlier, WHO may say NCD has some 3 things or 4 things. But you know, as doctors, we have to really look beyond that. So if a lady is walking in, there are some specific things to women here up on the slide, but there are also a number of things. So even if you have a male patient walking in, there could be several things that you actually need to look into. So of course, we need to look into their overall health. We need to think about diabetes. You need to think about thyroid, other endocrine disorders like PCOS, maybe relevant, osteoporosis in the older population with overweight, obesity going up. We need to think about diseases associated with that, which are diseases other than diabetes, like joint problems, cancers, cardiovascular disease, heart failure. More and more of sleep apnea is being observed and practiced across NAFLD, dyslipidemia, atherosclerosis. And in addition to all of this, we also need to look for other respiratory disorders, like people may have seasonal bronchitis. They may also have a lot of psychological issues. I've only mentioned depression here, but mental health is a big subject. And of course, there could be substance abuse. So when we're seeing any patient as any particular specialist, irrespective of what field we are in, it becomes sort of necessary for us to remember that there's a huge basket of things for us to look into. What are our aims really? Our aim is primordial prevention, and that's what Dr. Pramila Kalra was talking about. Looking at individuals when they're young, when they're healthy, when they even have no risk factors at all for anything, and initiating a healthy diet, lifestyle, advocacy, awareness right there. And this has to start at the level of the school, because for most cases, by the time these kids actually come to us as adults and women adults coming to us in the clinic, they already have risk factors. But even then, we can make a difference and we can control these risk factors and ensure that some of them are so well controlled that they don't increase and actually cause a problem. So if someone has a risk factor for diabetes, strong family history, putting on weight, well, at least you could ensure that they lose weight, they adopt the right lifestyle, so the pre-diabetes or even the normal glucose tolerance doesn't progress to diabetes. But let's say you're seeing someone at a much later stage, they already have diabetes and they're coming to you, there's still a small window of opportunity there for reversal right at the start in some cases. And then in other cases, you have a big window of opportunity there for early aggressive treatment because you want to ensure that you prevent complications. So you start screening for all macrovascular complications right from day one, and then you treat it and you aim for good aggressive HbA1c control, reduce the glycemic variability, at the same time ensure you reduce hypoglycemia and prevent long-term complications. So initiate multifactorial risk reduction because in the end, you want to avoid complications. So you have a lot of windows here, and irrespective of where you are, you have a good window of opportunity to ensure that the problem does not increase. But ideally, where do you want to start? You want to ensure that there's primordial prevention. So you don't want anyone to have risk factors at all. So we need to initiate measures to prevent NCDs at every opportunity given to us. So it's important for us more and more to recognize that we have specific opportunities to look at specific problems based on the age of the individual. So in children, it may be slightly different. Adolescence to adulthood, we've already looked at the different things that we need to monitor. So to ensure there's a healthy transition, irrespective of whether someone has diabetes or not. I'm talking about general health here. And then once someone is an adult, we have a window of opportunity before conception, because more and more women, at least in cities today, they do come and see the doctor to get everything checked before they get married, or if they're married, then before they conceive, they want to make sure they're healthy. So that's a window there. And then after delivery, throughout pregnancy, of course, and then after delivery with the obstetrician, that's again a window of opportunity to initiate a healthy lifestyle during follow-up. Menopause, again, is a specific transition, and this talk will be followed by menopause. And of course, in addition to all of this, it would be right, especially for high-risk ethnic populations, and Indians, we belong to that, especially in terms of metabolic diseases. It is important for everyone to get an annual health checkup to ensure that their health is all in the green area. So what are our goals here? Our goals are to reduce risks of chronic diseases through education, counseling, and appropriate intervention. Face-to-face with an individual patient, this needs to be done for every patient, so everyone's the target population. But I think on a broader level, public awareness messages, media, schools, television, and policies, of course, can initiate a healthy lifestyle at a larger level, at the population level. So we see a patient in our clinic. What is it that we would have to tell them in order to ensure that they're healthy? So everyone needs to be in touch with a nutritionist. So we often think that, a diabetologist or an endocrinologist has to have a dietitian with them. But I think today, every physician and even an obstetrician has to have a nutritionist and an educator sitting with them in practice, because we need to ensure that all our patients have a healthy lifestyle and diet. Exercise is important, 150 minutes of aerobic exercise. If that's a little lower, I think that's okay. It depends on overall the amount, the kind of exercise you also do. So if you're doing something like high intensity interval training, you may not need that much. And you could also incorporate a lot of resistance training to that, reduce the aerobic exercise, improve muscle mass, because that again is important as we age, to prevent osteoporosis, to improve balance, and to reduce frailty and fractures. In addition, everyone who comes in should get a full physical exam. Need to try and make sure that we encourage people to keep their BMI under 23. So that's why I've said 22. So keep it under 23, so it's normal, so they don't go overweight or obese. Check the blood pressure for everyone at regular intervals, so ensure the blood pressure is normal. Salt restricted diet, a healthy diet with sufficient vegetables, fiber, reduce carbohydrate, make it a more balanced diet with 50% carbs, 30% fat, 20% protein. You could switch up that ratio based on how much weight you want your patients to reduce. and also try to tell people to measure their waist circumference, and for women to keep it under 80. If you're thinking of labs, what would be the things we generally look at? HbA1c, well, normal is below 5.7, so we want everyone's below that. So to keep it in the healthy range. If someone has pre-diabetes, you want to get it into the normal range. If someone has diabetes, you want to get it below 7 ideally. But if it's a young, healthy person, you could try to get it below 6.5, minimize hypoglycemia. Check the lipid profile. Someone with diabetes, get it below 70. Someone with cardiovascular disease, maybe even under 50. Check the renal function, keep the UACR under 30, initiate ACE inhibitors, angiotensin receptor blockers, and also today we have SGLT2 inhibitors in individuals where you can improve renal outcomes and reduce albuminuria. Get a basic ECG done for everyone, hemogram to check their hemoglobin levels, because anemia is a problem, especially if someone needs to plan pregnancy in the future. So you need to ensure that all micronutrient deficiencies, low hemoglobin, low iron, all of that is corrected. Get the thyroid function assessed, get the LFT done, especially if people take alcohol or if they're overweight or obese, because you want to look at non-alcoholic fatty liver disease, which is actually quite common. And therefore the ultrasound, and if you do suspect it, then refer to gastroenterologist for a fibro scan. Sleep study, again, if there's obesity, symptoms suggestive of sleep apnea, then a pulmonology referral, a sleep study comes in. Of course, if someone has diabetes, in addition, you do a foot exam, assess vascularity, do the ABI, get a retinal exam every year. If someone's older, and I won't go into details because menopause comes next, also screen for osteoporosis. But even if someone is younger, if there's history of risk factors like long-term glucocorticoid use, the body weight, smoking, family history of osteoporosis, fractures, a lot of alcohol intake, previous fractures, then osteoporosis is something to screen for. Of course, as physicians, we sometimes forget to screen for cancers, and we usually, especially gynecological cancers, we forget to tell our patients to get a pap smear in time. So that's something important to remember, that we have to tell all our patients coming to us to do a regular self breast exam, and anyone over 50 is advised to get a mammogram done every 2 years or so. But of course, if there's early menarche, late menopause, previous history of cancer, family history of cancer, first degree relatives, then screening may be warranted much earlier. It's also important for us as doctors, even treating diabetes endocrinology, to ask patients and to do a breast exam at least once a year, and then ask them to check and examine themselves at least once a month or twice a month. So fix a date and do this every month, so they actually come back to you if they notice any signs, any lumps or any signs that are suggestive of early malignancy. Similar to that, I think a pap smear is something that's important. So anyone over 21 years needs to get it done every 3 years, or every 5 years if they're getting the co-testing done with HPV as well. This is recommended until someone's about 65, and more than 65, it can be stopped. Or some gynecologists and cancer guidelines also say at 65, you still continue to do it, or you can stop it if you have a sufficient number of consecutive tests which are negative in the last decade. So I think here I would refer the patient to a gynecologist to get this done based on the guidelines that are followed in India. Mental health is a big issue, and especially patients coming with diabetes, hypertension, chronic diseases like cardiac and heart failure, depression is a big associated comorbid condition. So simple things that we could ask is, how is the patient feeling? Do they have chronic pain, feeling low, recent stressors, a lot of insomnia, fatigue, unexplained physical symptoms? Because you see a lot of patients coming to us with really just aches and pains, and nothing goes away irrespective of whatever treatment they take, and all their labs are fine. So this is a clinical red flag that there's an underlying psychological problem. So simple questionnaires you could administer, or even just these clinical red flags, you could refer them to a counselor, a psychologist, or psychiatrist for a formal assessment and treatment. Substance abuse is again an issue, so that's something we need to remember. And everyone needs to be told that smoking is harmful and smoking cessation is recommended. Alcohol intake, of course, needs to be avoided preferably or limited if someone does take alcohol. Well, this doesn't come under NCDs, but since we're talking about holistic health, you already had a talk on vaccinations. I think a few vaccinations that would be good for everyone to take is hepatitis B, the annual flu vaccine, and the pneumococcal vaccine. Of course, if someone is immunocompromised, then a few other vaccines like the meningococcal vaccine, herpes zoster, etc., might be recommended. But overall, why are we doing all of this? Of course, we want the society to be healthier. But imagine if someone's healthy, the amount of money you're going to spend just to treat that problem. And the problem is not going to go away, especially for chronic diseases, and the quality of life comes down. So nothing is really more expensive than a missed opportunity. And this holds good for all non-communicable diseases. And an ounce of prevention is really worth a pound of cure, whether it's diabetes or hypertension progressing to heart failure, or overweight going into obesity and being a leading cause for cancer. Either way, prevention is really the key. So thank you very much.
Thank you so much, Dr. Bhavna, for such a splendid explanation of proactive prevention and primordial to primary preventive aspects, as well as detailing about how to approach the modus operandi and where we have to be very proactive. Excellent talk. Thank you so much, Dr. Bhavna. If we have any questions, I would like to just say one word, because being an interventional cardiologist and a preventive cardiologist in my forefront, I would suggest that most of us, we are talking about HbA1c, TSH, but I think so far I have been listening since yesterday, nobody spoke about really seriously about the lipid profiles, which I would be very, very proactively and, primordial preventive, and because that is the main thing for coronary events and the, acute seismic problems, vascular problems. We have never spoken about lipid profiles, and we would suggest it to get it done from 10 years onwards. That is what is our recommendation. Okay, I would talk to about this next. Any questions here with Dr. Bhavna? Anybody? Okay, then we move on to next talk. Very thank you so much, Dr. Bhavna. Good, excellent. Next talk would be about menopause, the primary prevention, and Dr. Meeta Singh, Hyderabad. She's there with us. Dr. Meeta Singh.
Hello, hello, Dr. Tripti.
Hi, Dr. Meeta. So nice to see you after so many years. We are such good friends, but we never meet. So nice to see you. Should I introduce Dr. Meeta Singh?
Yes. Yes.
We have the first slide for her introduction.
Oh, I'm sorry, I have not put up the first slide. I think I put it up on the, I put it up actually on the thing, but it's okay. I mean, we can.
I think Dr. Meeta is so famous gynecologist that we need not give her extra this thing. I think she has many publications and she has so much of intense research work, and she has been looking after this menopause. I think I heard her menopause once, one very great lecture, actually, I remember about a year back or so. So it's kind of...
Just to add, she's the current president of Menopause Society of India.
Oh, great. That's great. Yeah. She is the president. So we would love to hear from Meeta all the detailing about menopause window of opportunity. Great. Thank you so much, Meeta.
Yeah, Thank you. Thank you, Dr. Lily. Thank you, Dr. Tripti. Thank you actually for having me in the core committee, as well as, you know, a big congratulations to this wonderful sessions which have been going on since yesterday. A little correction, I was the president in 2012, Lily, but I'm a very active member, but I also will take this opportunity. In fact, I was thinking I will not disturb the flow of your conversation in WhatsApp, but so I will take an opportunity for all those who are listening in that I am the editor-in-chief for the Journal of Midlife Health, which is an index journal. And I'm really looking forward to have a great team. So I would want, you know, reviewers. So I would put it in the WhatsApp. You can, you know, if somebody is interested and have the time, please volunteer. We need good people, a good team. And I would also request, you know, all of you, if you have any good topic for a review or a mini commentary or anything that you feel really passionate about for midlife health, do send in your articles. So having said that, we'll talk about, it's been a great session, and having Dr. Sarita Bajaj here, it's a big honor and an opportunity to speak with her as a chairperson, and of course Tripti, who's done wonderful work and is still doing. And and you know, talking about prevention right from the entire lifespan is a wonderful idea. And so now the woman comes to menopause. Whether she has really taken care or not been taken care is what generally happens now in our scenario. But what do we do? What is the window of opportunity at menopause? And I have some disclosures, that is no financial, but then the evidence that I'm putting in, you know, like Bhavna said, I'm not putting in any hardcore evidences, because though I know it's a very elite audience, but I thought, you know, I'll keep it very simple so that it's propagated to the other people through you. And it's this multidisciplinary interaction, which I feel is very, very important. And rightly said, NICDs start right from here. That is in utero, and even before that, a womb is the most important thing that is there, more than actually a home, I think. Because if you have the proper womb, a proper well-nourished woman, then that is where the problems can be actually nipped in the bud. But anyway, my field is menopause. I'm going to talk about that. And everybody has done such great justice to this topic in this entire session. So menopause is like a radiant Indian summer, not like some cold country. Okay, so we are happy to be here. And it is, of course, a normal development experience. And why are we talking about these different phases of life, you know, right from your prepubertal, your pregnancy, reproductive, and then you come to menopause. These are the important milestones where they come to us for some issues. And that is where, as a professional, we can really take care, guide them, not only for the problems that they come in, but take every opportunity to instill this preventive care, which we are really talking about. So nature guides best when it is guided. And these are all from the Indian Menopause Society. 1998, we just had about, say, 20-page booklet on menopause and hormone therapy 25 years ago. And today, this is the latest guideline, clinical practice guidelines on menopause, and it runs into, hold your breath, 500 pages. So that is the entire development that has happened over a period of years. And we strongly believe at the Menopause Society that working with what you have wherever you are, and not with what you wish for. So whether you're working in a small setup or in a corporate with everything, everybody can pitch in, everybody can do with very simple measures. And that's the basis of my talk today. And we know that in relation to menopause, a lot of changes happen over a period of years, right from the menopause transition. But we are going to pay attention to this chronic disorders, NICD. So any disorder, whether it is labeled under the WHO or not, anything which is not communicable, I mean, comes into the preview. But today, I think I'm going to restrict more on a few issues. So body composition, I feel finally, everything ends. Your entire preventive measures end with the body composition. Look after the muscle, look after your bone, look after your fat. And fat is emerging as one of the major issues, not just for obesity, not just for metabolic syndrome, but you see fat anywhere in the body is going to lead to problems. whether it is in the liver, whether it is in the pericardium, whether it is in the ovaries. So each ectopic fat or dystrophic fat leads to problems, even to cancers. And of course, the cartilage also plays a very, very important role, because osteoarthritis is one of the very important things that happen in this menopause transition and beyond, which affects the quality of life. So there are so many, and osteoarthritis cannot totally be prevented, but the quality of life can be definitely be improved, and you could prevent a lot of people from going to the stage of knee transplant just by simple, persistent, discipline measures. So menopause has an effect, and these are a number of cross-sectional studies which show that menopause associated increase in visceral adiposity is related to the change in estrogen and not just aging alone. So aging also adds on, but the visceral adiposity, especially in menopause transition, is definitely related to menopause. It's not just about that. So the couple of slides, I'm going to have more on what really happens at transition, and then what we are going to do clinically. So this is the So we, all of us are also aware that from premenopause, which is featured in blue, to postmenopause, the bone mass, whether it is at the spine or the total hip, gradually reduces. And as you see, the menopause, the metabolic syndrome is much worse when it is presented in women. And we know that there is a drastic change in the lipid profile. We have enough of data from the SWAN and so many longitudinal studies, RCTs, the change that happens in the lipid profile during this menopause transition, as and very rightly pointed out by Dr. Tripti. I think lipid profile and the triglyceride levels give you a host of information even before drastic changes happen in the body, and which is such a simple test and something that needs to be done like wherever possible, right from the age of 10 years. So like I said, these fat redistribution or the presence of this ectopic fat can cause so many diseases. So fat becomes as important as your bone, as your muscle, and as your cartilage. This was a study that we had done from the Indian Menopause Society way back in 2010 and 12. Even at that time, the percentages related to the hypertension, IHD, multicentric, all India. So the prevalence of these NICDs is quite a bit, and it's very important that we need to take care. And we also know that the calcium intake, average intake, is not more than 300 milligrams, where earlier the ICMR and NIN guidelines were saying 600 to 800 milligrams, and now they have hiked it up to 1000 milligrams for an adult and almost up to 1500 for a postmenopausal women. So we have a lot to do in that area. And the IMS data suggests that the average age of menopause is 46 years. But why are we bothered about the average age of menopause? It's very, very important to know the average age of menopause, because the age factor has a great influence on so many of these chronic disorders. We are lacking behind by 5 years. And we have got good studies to say that actually it starts off right from in utero. We grow, we mature early right from the beginning. And I mean, that's a huge area that needs a lot of research. So, but what happens, and why is this, why are we different? Why this ethnicity and country specific ages matter when it comes to longevity and also lead to a lot of disability. The mean age of menopause is 46 years, and it is reported that osteoporotic fractures occur 10 to 20 years earlier. Excellent study done by Dr. Marwa. 20% of most menopausal women have lean muscle mass, and it is almost to the tune of 30% lesser than the lower mean mass compared to the white counterparts. Indians have a higher percentage of fat, and the visceral fat, the phenotype that we have is the lean fat, visceral fat that we have, and it is definitely much more than the Caucasians. That's why we are the diabetic capital. And type 2 diabetes occurs a decade earlier than the Caucasians. Prevalence of hypertension, diabetes, of course, is also earlier, and metabolic syndrome transits from 22 to almost 32, doubles by the time you're in the postmenopause. Breast cancer today is the most common cause in Indian women versus the cervical cancer, which was there earlier. And it's surprising that we have a lot of endometrial hyperplasias, a lot of endometrial in situ, atypical hyperplasias, and endometrial cancers also rising in the younger generation, mainly because of the increase in the obesity. And we know that increasing obesity apart from so many other problems, the cancers in the postmenopause is also on the rise because of these. So these are all correctable, modifiable factors. So most of these chronic diseases, almost all of them have two major issues. One is the modifiable, one are the non-modifiable. Non-modifiable, you just cannot do anything about. But as clinicians, we can start working on those modifier factors right from the beginning. So in India, what are the medical challenges? One is the early median age of menopause, high prevalence of the NICDs, and we need to redefine then our POIs, early decline of the fecundity. We have both the ends, like it was debating since, I mean, yesterday there was an interesting debate on this dietary excess and deficiencies and type of fasting, which would help. And once they may look absolutely normal, but then they may be deficient in calcium, vitamin D, and the micronutrients. So we have all these issues to look into. So as a professional, these are the simple slides which I'm going to talk about now as to what we really should be doing as a clinician sitting in your clinic. So one is assessment of symptoms when a woman comes to you at menopause. Why has she come to you? And then a thorough physical examination, investigations. There are a host of investigations we can do, but what are the ones which are cost effective? What are the ones which would be useful in a whole group of population and not only in a set of population is the main question. And then once we come to a conclusion, then you classify these women basically at menopause. I classify them into two groups: women with menopausal symptoms, women without menopausal symptoms. So, but for both of them, you need to do all the preventive measures. So a breast exam, your anthropometry becomes very important. Breast examination becomes important. Your blood pressure. So blood test, I think the simple basic blood test which you should be doing is a complete blood picture, your blood sugar, your TSH, because thyroid is also very much prevalent. And of course, never forget your lipid profile. These are important. Pap smears, yes. HPV, if a woman can afford it. And we'll talk about and waist circumference. Never forget to do the waist circumference after the BMI. I think these are the things that need to be done. I mean, you cannot do away with this when you see a woman at menopause. Ultrasound and BMD, we will talk about it later, which are done only on an indication. But the rest, what is there in the figures, have to be done. And this is how you actually run a menopause clinic. You know, this figure shows you what the woman goes through. These are the basic requirements that you need when you run a menopause clinic. Very simple gadgets: a tape, a weighing machine, an apparatus, a speculum, a pap smear, a small lab collection center to do your basic test, and little stationery. And these are the tool kits that we need to have. One is a BMI chart and the WHO risk assessment chart and the OSTA. So I'm going to talk a little more about that. So you just need a simple tools to check and to pick up the problems of NICDs in a whole group of population without spending too much of time. So first you understand whether the woman herself is in menopause. Once you know that, and that's only by the history, then we have a proforma, which is a document which needs to be filled up, because just like antenatal, you cannot just have a one-time contact with this woman. You need to see her repeatedly once a year. If she's absolutely normal, you don't need to see her many times. You just need to see her once a year. But you're going to document her progress every year with simple things, with simple tests, and you really don't have to make it very, very expensive and very difficult for the general population to follow. And once you've decided, this was a beautiful staging of menopause done by an Indian researcher, and he classified this much before the WHO had come in, that the stage 1 is the early menopause transition, where you prevent and treat. In the stage 1, when they're going through a problem, you treat, and later on in postmenopause, it's all about palliation. And so a menopause role is not just symptoms, vasomotor symptoms, but it is risk assessment of disease. And this applies for both the women. And these tools, I think, are very, very important for a menopause specialist to talk about. The breast is the risk assessment tool, is the Gale index that we have picked, because unfortunately we don't have a validated tool. But when Bhavna was showing, all those risk factors for breast, tell me, when you're sitting in a clinic, how difficult it is to decide which woman you're going to, screening for mammogram. You offer to everybody, of course. I mean, if everybody can get done, it's fine. But then you have different classes of patient where you may not be able to, that may not be a priority compared to the other things as an investigation. Then what do? You just have to scratch your head, because it's very subjective. You don't have an objective markers to say, okay, this lady definitely needs to go for your mammogram. So I think that's where it's okay to adapt the Gale model, even though we don't have a validated model in India. And then, of course, there is no two ways about this, because this is a validated model by the WHO and ISH. So rather than going into a lengthy other models which are available, I think the CVD risk assessment tool, which uses the sex, the smoking, the blood pressure, the diabetes, yeah, I will. Yeah, so you have all these tools, and then you can do a 5-year risk or a lifetime risk, and indications for DEXA are much more expanding. And these are some way that you can actually do. So the good mantra for good health is a therapeutic lifestyle management. And indications, this is one place where I would like to concentrate, just take 1 minute of your time, because I think indications are for bone health as well. It's not just for vasomotor symptoms. It can be the first choice, not only for prevention, but treatment of osteoporosis based on so much of data. And so this is the final slide, which you have to work for the woman through the lifespan. And this is the slogan from the Indian Menopause Society: fit at 40, strong at 60, and independent at 80. Thank you so much for the patience.
Thank you, Meeta, for such a nice and sweet and very clear demonstration of what is menopause and how the woman goes through it, and what is the pre-menopause and the menopause clinic, how you could do that, and that would help a lot of women. In fact, in India, I think more than above menopause age, more than 50% of population of women would be coming under that group, because we are increasing in age. The woman age is going up. And what you have suggested, I would say we should have more menopause, pre-menopause clinics for women health and to get them through. Thank you so much for excellent and a very nice talk.
Thank you.
Thank you.
Okay, thank you so much.
What I liked best was what you said, it starts in the womb. So I think we cannot emphasize that enough. And if we can do something in the womb, then we can delay and, have a nice way on the way to the tomb, so that we are comfortable right through life. That I agree with that 100%.
Exactly.
Thank you, ma'am.
Lovely. It was very nice. Thank you so much. So over to the organizers now. Thank you, Dr. Tripti Dev.
Thank you. Thank you,
We had
Dr.
a nice,
Sarita.
very nice session. Thank you so much.
Yeah. Now we have the next scientific agenda is on diabetic complications. And I would like to call upon the moderator, Dr. Benny Nedur, again to take over the session and take the proceedings further.
Thank you so much, Dr. Lily. We've heard some wonderful talks today with all the stalwarts in their fields. We now go to the penultimate session, and it has to be on complications because we have not dealt with that. And there are disparities also in the complications between men and women. And we have 3 talks today by seasoned speakers. May I invite my chairpersons, Dr. Ismail Kiranmayi from Hyderabad and Dr. Ramya P. from Hyderabad, to join me in this session. And we have the first talk by Dr. Tripti Dev. I think we heard her in the last session. She's an interventional cardiologist, and she will be speaking on cardiovascular disease in women. May I request the chairperson to formally introduce her?
Good afternoon, everyone. I'm Dr. Ramya, and I'm honored to introduce Dr. Tripti Dev. She is a senior intervention cardiologist and presently working in Apollo Hospital, Jubilee Hills. She has more than 35 years experience, and she specializes in coronary interventions. She has done fellowship in intervention cardiology from France, and she is a fellow of American Cardiology Society and European Society of Cardiology. She is She has a lot of research papers to her credit, and she is an excellent human being and very patient-friendly doctor. And over to her. Madam, please give your talk on cardiovascular diseases in women.
Thank you, Dr. Ramya, for such a nice words and such a beautiful. Thank you so much. Then I would tell the organizers to share my slides. I think my slides are with the organizers and they have to share my slides.
Just give me a minute, ma'am.
Okay. By the time he is organizing the slides, I would like to say that women most affected by vascular complications of diabetes far more than men. And now we have been talking all about prevention, primary and primordial. Now it sets us that diabetes sets to the skyrocket of 629 million patients globally by 2040. And out of that, more than 50%, almost 60% would be women for the cardiovascular risk. And this escalates leaps and bounds, and a situation likely to escalate in the continuing decade, and it's not going to stop. The CVD occurs 15 years earlier in women, and the link between the diabetes and the cardiovascular disease are particularly very potent, and nobody can deny this real fact that all the good effects of estrogen and premenopausal women protection from the cardiovascular disease, which we say that atherosclerosis is late presentation in women after menopause because of protection of the estrogen, would be taken away by this diabetes. And this is the factor which we have to understand. Then globally, there are more deaths due to the diabetes in women than in men. That is more than 2:1 versus 1.8 million annually. And that is extremely mind boggling. And this excess risk is mostly due to the higher risk of CV death in the woman, which we have to understand that put together all the cancers and all the depression, all the psychiatric illnesses, everything put together, the woman dies most commonly with the CV death rather than any other condition. Coming to not only the cardiovascular CV deaths and the atherosclerotic deaths, the heart failure is the second most common, and the initial manifestation of the CV disease would be only heart failure in the woman with type 2 diabetes mellitus. Women with diabetes are 5 times more likely to get the heart failure than any woman without the diabetes. And this puts a woman into an extremely high risk of heart failure and CV deaths. When they with diabetes are 2 times, they are more likely for the heart failure as compared to comparative in the men population. The research in ongoing to explain that these differences between the women and the men, one possible reason why we should think that why women has more risk as compared to men could be because of the specific form is more common in the woman generally and is the type most likely to affect the patients with the diabetes. And this form is called the heart failure with preserved ejection fraction. When we talk about heart failure in women and men, we have two kinds of heart failure. Okay, I'm thankful to this organizers to get my slides on. Can we have the full screen?
Ma'am, from the first slide?
Yes. Yeah, can we go to the first slides? First slides onwards. This is the last one, I think so. Yes. Then go to the next one. Yeah. Now, once we talk about this extreme burden of vascular diseases, cardiovascular diseases in women, 38.2 million women, that is 34%, are living with the cardiovascular disease. A much higher population is at large at risk. The heart disease and the stroke are the number 1 and the number 3 killer for women over the age of only 25. 1 in 30 die of the breast cancer, but it's extremely high. 1 in 2.5 die of the cardiovascular disease or the stroke. Now you can see how much is the burden of the stroke and the cardiovascular disease amongst women. 66,000 more women than men die per year of the cardiovascular disease, represents 54% of the deaths in women compared to 46% in men. Next, please. Can we go to the next slide, please? Yes, now this gives us a real mind-blowing statistics for CVD runs is a very high different courses women. Women develop 10 to 20 years later than men before menopause. But if it is present at the younger age, that is less than 40 years of age, which we see nowadays very frequently, and we see women suffering with the coronary artery disease and the stroke before the age of 30, 35. And if they are present at the younger age, they are very malignant course and they have very malignant clinical course. Mostly young women we see with SCAD, that is, there is a spontaneous coronary dissection, which we call, that is other than the atherosclerotic cardiovascular disease. Diabetes and hypertension have relatively more role in the women as compared to men, and clinical manifestations of heart failure as well as the responses are totally different as compared to men. Next, please. Now coming to the risk factors which we include for the female specific and the female predominant in course of the events, when we see non-modifiable risk factors, as all other speakers have also explained very well, that is age, sex and family history of the premature cardiovascular disease. And here I would like to say that family history of premature cardiovascular disease has to be scrutinized in a much more detailed manner, because in Asian studies and especially in India, UNOS and UNOS have done the very classical socio-economic studies where they have shown that once a woman has got a cardiovascular disease much earlier, that is before the age of 65 years, any person in the family getting a heart attack, their first propensity, kith and kins, that is parents as well as the sisters and the siblings, would get the cardiovascular disease much earlier, much less, more than more than double the risk. Hence, the family history of premature cardiovascular disease is the foremost objective of us to scrutinize from every woman at the age of 20, 25 to understand. And there we can start implementing primordial and primary prevention, so that the first attack for the family, for the woman family, their kith and kin should be prevented before the age of 40 years. And that is the most important factor where we can have a primary or secondary prevention statistics put into a clear clinical perspective. Now coming to the modifiable risk factors: hypertension, diabetes, obesity, cigarette smoking, physical inactivity, dyslipidemia. All these risk factors we talk about because we can implement the primary and secondary prevention activities and bring them down so that every woman cannot get a heart attack or a CV death much earlier than 80 plus years of age. Female specific or predominant risk factors like pregnancy induced hypertension, preeclampsia, eclampsia, gestational diabetes, polycystic ovarian disease, menopause, and peri uh, during pregnancy they have even peripartum cardiomyopathies. All these things could be taken care of if earlier detection and the as early as possible the manifestation should be prevented and should be treated as early as possible. Systemic inflammatory disorders, rheumatoid diseases, and the mental stress and the depressions, they all finally point and get into the cardiovascular risk for the woman. Next, please. Next slide, please. Then coming to the post-menopause risk factors, like already spoken to with my esteemed colleagues already. And of course, nowadays, even women is getting up with the smoking and the consumption of oral contraceptives would bring down their, bring up their risk of getting CV deaths much earlier than the premenopausal age also. And worldwide, 8.6 million die from the heart disease every year. And that brings to the woman into a much higher risk as compared to men. Next, please. And these are the possible causes where why the men gets more risk factor as compared to women. When we talk about age, hypertension, total cholesterol, low density lipoprotein cholesterols as compared to women. But women do have high triglycerides and low HDL. And this combination in Indian scenario, especially in our Indian women at the age of 20-25, when we do the routine checkups for the primary health checkups, we find our women having low HDL and high triglyceride levels because of lifestyle scenarios as well as the family history scenarios. Though our women, they hardly smoke and very few of them have got the smoking habits. But as compared to men, they have more polycystic and metabolic disorders, which can be the major risk factors and which can be prevented, which can be modified. And the woman specific risk factors, which we have already spoken to. Next slide, please. Next slide, please.
Into
Till he gets the next slide, when I was talking about the heart failure in the woman, we have a big chunk of heart failure in women with the preserved ejection fraction. Normally, when we talk about the heart failure, we talk about the reduced ejection fraction heart failure. That means the pumping capacity of the heart has gone down and the left ventricular ejection fraction is less than 40%. And this anomaly of the heart failure is mostly seen after the major heart attacks and after the major coronary vascular events. And most probably, the women who never got any heart related issues,
asking for the next slide.
even that they are suffering with the heart failure. There we have a heart failure with the preserved ejection fraction, where the heart pumping the LV ejection fraction is more than 50%. And these group of patients, they are more than the double in the clinical scenario. And heart failure with preserved ejection fraction is more important escalating morbidity and mortality for present day women when we see in our day-to-day clinical practice. When we talk about diabetes, and there also we have heart failure with the worst prognosis, more than 50% of women die of heart failure with preserved ejection fraction with diabetes. And when we talk about the effect of diabetes on the cardiovascular complications, it seems that to have a sex-specific interaction, female sex confirms spatial protection against the cardiovascular disease, but this protection is lost in the presence of diabetes. The diabetes is also associated with a significant increase in the heart failure incidence in men and women, but women have more heart failure with preserved ejection fraction, which is more detrimental. Next, Next slide, please. So these are the reasons what we come to. The women receive less intense glycemic control and treatment of type 2 diabetes as compared to their men counterparts. We may also speculate that diabetes and the heart failure are diagnosed at a later stage in the woman, because most of the time the minor symptoms which women they suffer can be ignored in most of the families. The women frequently have confounding factors such as obesity and lower natriuretic peptides. Hence, that gets eliminated, and then their detection of the heart failure, which is mostly done biochemically by natriuretic peptides, which can be missed in the early stages. Hence, the delay occurs in the diagnosis and the treatment. Next, please. Estrogen affects collagen synthesis and degradation, inhibits the renin-angiotensin system, and the loss of its protective mechanism may render the heart of the postmenopausal woman more vulnerable, and the loss of the estrogen protective effect in diabetic women makes them even further vulnerable. Other gender differences is in underlying mechanisms identifies as include the calcium handling and the nitric oxide system and natriuretic peptides, which are differently handled in the women as compared to men. Next, please. There was an original article which was published in the journal in differential prognostic impaction of the type 2 diabetes in women and men with the heart failure with preserved ejection fraction. And this category of, it's very challenging to treat the preserved ejection fraction heart failure, because there are very few number of newer modalities of treatment and the medical armamentarium to tell us a little bit more efficiently that we have now presently available type SGLT2 inhibitors, where they have shown a better action on the woman for the heart failure with preserved ejection fraction when we use them without even in diabetes also. And they have a better action on the preserved ejection fraction heart failure. Next slide, please. Hello. Now, women have estrogen protection, which has been, I have already spoken about it. Can we have the next slide, please? This is the formula which I was talking about, male and females, how they difference in the estrogen and testosterone, and that brings down the heart failure subsets and the cardiovascular mortality earlier in men, but in women it comes earlier with diabetes. Next. When we talk about the women have anatomically normally smaller coronary arteries, and when we talk about the histopathology and the pathological problems with the woman, the most important problem when we talk about the interventions in the coronary acute MI and the acute myocardial infarction and the heart attacks in women, when we do the interventions and we try to use more of radial arteries nowadays for our intervention, so that the groin related complications can be prevented. And the radial artery size in women we find is much smaller in the Asian and especially in Indian scenario. And we have to, though we use the radial artery routinely to prevent the further complications of bleeding, but still we find it more difficult in women as compared to men. And after correcting for the body surface area, women's arteries and the coronaries are also smaller. Hence, and they are more diffusely diseased as compared to men. And their pathophysiology of the atherosclerosis in women is much different from the men. As compared to men, they have more of a plaque rupture and the clot formation. The women have got more of a plaque erosion when we talk about the coronary events. And hence, the stenosis and the endothelial dysfunction, which we see in women, are pathophysiologically far different from the men. Next slide, please. This is how we describe the pathophysiology of the acute coronary syndrome and acute myocardial infarction with a big thrombus formation. In the first slide, in the upper slide, you can see a woman having atherosclerotic cross section of the coronary artery, where it shows that there is a plaque erosion, and this plaque erosion goes slowly and burdens the coronary slowly without the understanding of the coronary anatomy. And when we do the angiogram with the erosion, sometimes we may not even detect these conditions in the coronary angiogram as compared to the men, where there is an abrupt plaque rupture and the clot formation. Hence, the men present with the acute coronary syndromes much more earlier and with the more vigorous symptoms and more classical symptoms as compared to women, because histopathologically and anatomically, women suffer from the more plaque erosion, and that causes less explosive symptoms and more of a vague symptoms in the coronary events. And they are missed out as non-Q wave MI in women as compared to more commonly Q wave MI and the more ST elevation MI in the men. Next slide, please. This is how the women present with the plaque erosion, and then there is a remodeling and there is a reverse remodeling, and which causes the coronary to enlarge in the size. And we miss out these plaques inside the coronaries in spite of building up of the coronary atherosclerosis. During routine angiograms, we may not see always the coronary blockages, and this causes outward remodeling, which causes atherosclerotic lesions to protrude outward that rather than impinging onto the lumen of the coronary. And these are the basic histopathological and the mechanistic differences between a woman and a men coronary, which gives us a more normal coronaries in the woman with the acute coronary syndromes, with the chest pain and with the angina symptoms. But we call it MINOCA because they don't produce the coronary obstruction, but non-obstructive coronary artery disease and the microvascular coronary artery disease are more common in women as compared to men. And hence the treatment modalities and their approach to the treatment is also more challenging as compared to men. Next slide, please. Hence, these gender differences in the etiology and differences in the coronary events and the heart failure, there was a systematic review which was presented recently in the ESI. Next slide, please. Can I have the next slide, please? This is based upon this research and the new paper publications. This shows that in USA statistics, among the older women more than 75 years of age, 10.9% are more as compared to the men. That is 9.8% statistically, they have prevalent heart failure. Even in the elderly group also, where the effect of hormones are not that preserving for the woman, still they have a more higher heart failure rates. And the instance of myocardial infarction as an etiological factors for the heart failure is detrimental for both genders. But however, in the woman, within the next 6 years of the acute MI, 46% of women should get disabled as compared to only 22% disability in the men. Hence, women suffer more disability even at the age of 70, 75 years also, after the much longer period than the men. Next. Next slide, please. Then we talk about the prevalence of the woman in the studies of the left ventricular dysfunction, that is SALT trial registry, which has shown the higher 1 year mortality rate for the woman, that is 22% after the MI and after acute coronary events than men, that is 17%. The difference has been attributed to hypertension being the most common etiology of heart failure in women, whereas the myocardial infarction is the most common risk factor for heart failure in men. Next, please. Hence, the women with the heart failure tend to be older than men. and with the heart failure and may have a higher levels of comorbidities as the baseline. Hypertension and myocardial infarction go together and they account for the most important, more than 75% of the heart failure population among attributable risk factors. According to the FSH, the hazards of developing for the heart failure in the hypertensive compared to the normotensive subjects was about twofold in the man as compared to threefold in the woman. And there was a significant association between hypertension and the heart failure in both men and women. Next, please. So it's not only diabetes, but the hypertension is a major risk factor and which is not prevented properly, and blood pressure measurements are not taken very regularly amongst the general population. The risk doubled with the blood pressure of more than 160/90 as compared to 140/90. And the general belief is there that if blood pressure is 140/90, it is not high, but actually it is a misconception. The now latest studies have shown on the blood pressure that if the blood pressure is less than 120/80 for a longitudinal cross-sectional society, then the population gets less heart attack and less prone to the heart failure as compared to more than 130/80. Hence, for a diabetic woman, the blood pressure cutoff should be less than 130/80, not 140/90, which is a misconception, and that should be prevalent amongst the physician as well as the family physicians, and they should take care of this part very commonly in the general population. The hypertension has the highest population attributable risk, and this risk is more than 39% for the males. And if you see the women, then 59% for the females. That means lower the blood pressure, better it is. If we can keep the blood pressure of a longitudinal cross-sectional society in the woman less than 130/80, we can prevent 59% of heart failure in females. The bar for the MI was 34% for men and 13% for females, and diabetes for 6% for men and 12% for females. Hence, these two risk factors, diabetes and hypertension, earlier detected, it is better for the prevention in case of women as compared to men. Next. Hence, we have seen the common risk factors and the common problems in both the genders as well as the differences. Now coming to the most important factor is the influence of gender on the symptoms of the myocardial ischemia. As I was already explaining, that men has got more classical symptoms of pain, pressure, squeezing in the chest, radiation of the pain in the neck, shoulders, back, arm, jaw, palpitations, difficulty in breathing, heartburns, nausea, vomiting, abdominal pain, cold sweats, clamminess, and the weakness. But the woman has got more common symptoms of much milder symptoms. Hence, they'll have generalized body aches and pains, sudden onset of weakness, shortness of breath, fatigue, feeling of systemic illness like without any chest pain, as if they are going for a viral fever or some kind of a general symptom, and mild discomforts in the back and the chest, arms, and the neck and the jaw, but without any chest pain. Hence, most of the women, if you see with the coronary events and the acute cardiovascular events, are missed out initially. And by the time they reach to their primary physician or to the cardiologist, it's very late, and we see them much later as compared to the men in our. Next slide, please.
Ma'am, can you please wind up early because we are
Yes,
running
yes,
short
yes,
of time?
yes. I'm coming to the last slide only.
Yeah, thank
It's
you so
almost
much.
gone. Yeah, most of it is over. Can I have the next slide, please?
Hello? Hello? Yeah. I
Sorry
already
for the
told.
delay.
Yeah.
Go to the next slide, please. Obstructive, non-obstructive, already I have spoken. And these are the steps of the success to reduce the CVD risk in women. We have discussed almost all the steps in entire sessions from yesterday to today. Next, please. All the steps of prevention we have already explained, and all the types of exercises, stress management, lifestyle, dietary modifications. Next, please. Can you quickly go through the slides, please? And these are all we have already spoken, waist circumference and the waist hip ratios. Next, can we go further fast? Yeah, can we go further fast and go further fast? Yes. Come to the last slide, please. Yeah, lifestyle changes and all we have discussed already. A big thank you to everyone for medicine armamentarium primary prevention. Still, we are not going with the aspirin presently because the newer guidelines for the aspirin as a primary prevention has almost been taken away, except for the where woman is having diabetes, we have got statins as the first line of the treatment, even for the primary prevention also. For the primary and the primordial prevention, statins have come in the first line of the treatment now as compared to the aspirin to prevent the major bleeding risk in the woman. Thank you so much.
Thank you very much, Dr. Tripti. I think you have told us the major differences of increased incidence of heart failure and the mechanistic difference in coronary artery syndrome where there is plaque erosion. So we move on to our next topic where Dr. Manisha Sahai from Hyderabad will speak on gender disparity in kidney disease. And may I request our chairperson, Dr. Ismail Kiranmai, who is Associate Professor in the Department of Nephrology, to kindly introduce her.
Can you hear me and see my screen? Okay. Yes. Kiranmai, you have to unmute yourself. Unmute yourself.
Manisha is a very, very well-known name in the scientific circuit. She's our HOD. Apart from that, she's a great friend, great human being, an excellent teacher, and very passionate about the research. And to her credit, she has many gold medals, and she is a member of International Society of Nephrology, Southeast Asian member, and she's an editor-in-chief for the Indian Society of Transplantation Journal. And she would be speaking about the gender disparity of nephrology. Over to Manisha. Thank you, Manisha.
Thank you, Kiranmai, for the nice introduction. And thank you, Dr. Lily, for having me here. And it was a great session yesterday as well as today morning. So I'll be talking about gender disparity in kidney disease. Is it in our genes? Are the genes responsible? So CKD, I'm surprised that among the non-communicable diseases mentioned since morning, CKD was not a part of many of the speakers' lectures. So the awareness of CKD itself is less among the faculty, leave alone the general public. CKD is the 8th leading cause of death among women. And do you know that 30 million women in India have CKD? 30 million, it's almost as common as diabetes. Diabetes is 40 million.
Excuse me, Dr. Manisha.
Ma'am, your screen is not visible.
Yeah, now.
Then what do I do?
Could you try it again?
Okay. Can you see it now?
Yes.
Okay. So, yeah. So, as I said, that CKD is an important problem, and it's 30 million in India. 30 million women in India have CKD, and this problem is very common all across the globe, even in emerging economies as well as the developed world. Now, why are women different? Why I'm talking about women CKD? This is because, let us find out, has nature made us different from men? Does nature favor us or the men? The nature favors women because women bring life into the world. Women have a longer life expectancy than men. And there is a decreased prevalence of cardiovascular risk factors and events in women. This risk, however, the decreased risk, it becomes an increased risk post-menopausal. Now, kidney health in women. There are certain anatomic differences with men. Our kidneys are smaller and lighter, around 300 gram only. Men have 350 gram kidneys, and our GFRs are 15% lower. So we are already anatomically and physiologically compromised. However, the nature protects us because the estrogen hormone is very protective. Testosterone is less protective. This is because of the different actions of these hormones on transporters in the kidney, which controls the drug effects as well as the toxicities. So the anatomy is against us, the physiology protects us. As I said, estrogens are good hormones, anti-fibrotic, anti-apoptotic. They increase nitric oxide, anti-inflammatory, they inhibit the RAS. whereas testosterone, it promotes apoptosis, it decreases nitric oxide, and it causes more of EGF receptor activation, which is more in males, which causes fibrosis. So it's very clear estrogen is a good hormone as compared to testosterone. What about renal diseases? Proteinuria, is it less in males or females? You'll be happy to know that it's less in females. Even type 2 diabetic people, the females are less proteinuric. Those who receive HRT are less proteinuric and increased creatinine clearance. What about chronic kidney disease? Is it more in males and females? Most of the studies say that the CKD is more in males. Some studies say that CKD is more in females, but that is because they have a longer life expectancy, and probably it's because of the inaccurate GFR formulae for females, because most of the formulae are made for males. However, this point is controversial. We believe that CKD is almost equal in men and women. What about glomerular diseases? Most of the glomerular diseases are commoner in males. IgA, FSGS, minimal change, everything is common in males. Some are commoner in females. HUS is one of them. And this is our biopsy data from Osmania. You can see over 10-year data, we had more number of men undergoing biopsies. So though the CKD progression is, the CKD prevalence is controversial, male versus female, the progression is happily lesser in women. The CKD progression to ESRD occurs slower in women. So we are happy, happy, happy. As you can see, women, the cumulative incidence of ESRD seems to be lower. Most of the diseases, they appear to be less common in women, and the progression of CKD also seems less in women. Then why are we worried at all? Why are we talking about kidney health in women? What makes a woman different from a man? Pregnancy is the essence of womanhood. Pregnancy is a major, major stressor. Normal pregnancy does not harm the mother, but remember, if the pregnancy is complicated or pregnancy is complicated because of issues, PIH, late pregnancy, or a pregnancy in CKD, this is detrimental for renal function. So the pregnancy differentiates a male from a female as far as the progression of CKD is concerned. Pregnancy-related AKI is a major risk factor for CKD. And don't think pregnancy-related AKI is uncommon. 15% of your acute kidney injury in India, 15% is because of pregnancy AKI, huge number. It is 30 times more common in India as compared to the Western world. So this, remember ladies, that pregnancy, especially pregnancy-related AKI, is a common risk factor for CKD, which does not exist in males. And the most important cause of pregnancy AKI, as we discussed yesterday, is preeclampsia or hypertension. Others are antepartum hemorrhage, postpartum hemorrhage, sepsis. You can see that some of them are quite preventable if we manage them early. If we do booking of pregnancies, the screen pregnancies, you can bring down on the complications because of preeclampsia or antepartum hemorrhage, postpartum hemorrhage. So this is a beautiful slide from placenta to kidney. The placental dysfunction, the preeclampsia damages the kidney. The CKD causes placental dysfunction damages the kidneys. So what are the effects of preeclampsia in women? Immediately it may cause acute kidney injury and death, but the problem is later problem. As I said, CKD, end-stage kidney disease. So this is a major lacuna we have here. We treat pregnancy AKI, but we forget about the long-term follow-up of women. So those of us who see women, pregnancy, complicated pregnancies, we should always have a registry and follow them long-term for CKD. Not only CKD, even CVD and stroke increases 5 times after preeclampsia. There is a risk factor for cognitive decline after preeclampsia. And even the child born to such mothers, they have less nephrons, they are born preterm, and they are also at risk for CKD. So as I said, pregnancy-related complications are a major difference between men and women, and they heighten the progression to CKD. And this is our article, Renal Cortical Necrosis and Topics. Many women, pregnancy AKI, they end up with cortical necrosis, whole cortex, the kidney cortex goes off. So healthy young woman with a child straight goes to ESRD because of sometimes preeclampsia, sepsis, so on and so forth. So maternal health is a key determinant of kidney health, and we should be aware of this risk factor for progression of CKD. Apart from this, as I said, most of the diseases are common in men. Pregnancy is unique to women, but there are certain diseases which are common in women. One of them is SLE. We all know what SLE is. And remember, I put up this slide. because 10% of these cases of SLE progress to end-stage kidney disease despite proper treatment. It has a poor pregnancy outcome, preeclampsia is common. So SLE makes us different from men. The ratio from men to women is 1:9. Other diseases which are common in women, again, which affect the kidney, CKD, are rheumatoid arthritis, amyloidosis, NSAIDs. Women take a lot of painkillers for back pains, scleroderma, renal crisis. So these are some of the renal diseases where women have much more prevalence than men. The third important disease, diabetic kidney disease, it's more common in men. But the problem is that the prevention to CKD is much more common in females because risk factors are more: obesity, sedentary, hypertensive, and they don't look after themselves. The fourth is obesity. Central obesity is becoming very, very common in women. And you can see, in fact, more women in India are obese now, especially the visceral fat. Another fourth important thing is urinary infections. Recurrent urinary infections, especially post-menopausal, very common. Stress incontinence, very common. It's very essential to take care of these urinary tract infections, should not just neglect them. Proper bladder exercises play an important role. So we have understood that overall kidney diseases are less. Pregnancy is a major stressor. Some diseases are unique to females, the SLE, the diabetic rapid progression, the obesity, urinary tract infections. These are more common. So this we have understood. What about treatment in renal disease? What about dialysis and transplantation? Any difference in men and women? So you'll be surprised. This is our study from our state where we have seen, which was published in Kidney International. This was a multi-centric study where it was shown that 73% of patients on dialysis are men. Women, even with kidney failure, do not come for dialysis. And it's the story not in India, across all economies, rich or poor, developed, underdeveloped countries, Africa, Japan, US. Top study. Everywhere women on dialysis are much less than men. They don't come. Is it that ESRD is less common? No, it's not that. Because less females seek medical attention. Less females receive medical attention. Nobody wants to pay for them. Very sad story. This is our center. 3,000 dialysis per month and only 1,000 are for females. Okay, fine. Dialysis is less. What about outcomes on dialysis? Who has a better outcome? Obviously, men. Women have a poor outcome. They receive less EPO. They are EPO resistant because of iron deficiency, poor muscle mass. They have increased gout, increased CV risk. So bad. More women die on dialysis as compared to men. What about peritoneal dialysis? There also peritonitis is much more common in females as compared to males. What about transplantation in men and women? Universal truth is, across all emerging countries like India, women donate, men receive. Women is always a default donor for a kidney recipient. And this is not only in India, all across the world, be it US, France, China, India, Pakistan, Sri Lanka, transplant rates in women are lower. Less women are registered as on transplant as recipients, and mothers are more likely to be donors. And most of the donors in India, apart from mothers, can you guess, are spouses. And this is the same story everywhere, be it Italy or be it Spain or Europe. So it's not a question of money. It's a question of, you can guess yourself, the behavior, the societal behavior. This is our Usmania data, 700 living transplants and 85 donors females, 87 recipient males. And most of the females either mothers, sisters or spouses. Even girl child is at a disadvantage. And this is from European Society. Again, you can see that girls have lower access to renal transplantation. Why is this? Is the female kidney better? That's why more females donate? No, female kidneys are in fact worse. They have lower number of nephrons. They express more HLA antigens. They are antigenic. They are more susceptible to nephrotoxic effects of immunosuppressants. They have a worse 5-year survival. Then why we are going after female kidneys? You can see the bottom red line, the dark red line. Female to male transplant has the worst survival probability. But still, we are asking the females to donate to men. Then why? So this is an article which I had written in Indian Journal of Transplant. Men are from Mars, women are from Venus. You have all read the book, and same thing happens in transplant. Why does that happen? Because maybe women sacrifice. In general, women seem to have a more self-sacrifice and sense of responsibility than men. And I appreciate that. And I'm proud of that. That women, they give birth They have a duty towards their children or towards their husband, and generally they sacrifice. And if they do, it's fine. I mean, families help, they are also benefited. So I'm not against this, but the problem is many women, even if they don't want, are forced. The girl child is not educated, considered inferior, females are not earning members, something female is a mere housewife. So because of this we don't like. If the women wants to donate, fine, but many of the women are forced to donate. And many of the women, after donation, the renal functions go down, especially with aging, and they may develop CKD. So women as donors, I told you that they are not good donors. Kidneys are not that great. They may donate out of their wish, which is fine. But again, many are forced to donate. What about women as recipients? First of all, they don't get the kidneys. Nobody wants to donate to them. And even if they receive the kidneys, suppose husband or brother donates the kidneys, they are at a high immunological risk, because many of the women are sensitized during pregnancy from the child's antigen, from the husband's antigen. And even if they give the kidney, the women may reject those kidneys. So immunologically also, we are at a disadvantage. Thus, across entire spectrum of CKD, right from the incidence, prevalence, progression, right from accessibility to dialysis, as well as access to transplant, females seem to be at a disadvantage. So what is being done to change this picture? We have a World Kidney Day, where in some years we have celebrated women and kidneys health, where we had highlighted all across the world, did seminars, webinars, quizzes, press notes, and this happens almost every year. World Kidney Day we celebrate in Thursday every year, second Thursday of March. And this is what we are doing now, Eva Stride. The whole purpose of the program is to make women aware that they also need to be taken care of. So what is the purpose of giving this lecture to this elite audience? Ask yourself these questions. Take care of yourselves as well as far as your kidneys are concerned. Is your body weight okay? Are you walking regularly? Did you get your checkups, regular checkups? The blood pressure, have you measured it? When did you measure it last? What about your sugar? Did you do it this year? What about your micral? Did you ever look at your urine albumin? What about your lipids? And did you ever calculate your GFR? I'm very sure many of us don't even know what our GFR is. So this also is required. In Japan, they do a universal screening for all. In India, we do screening only for diabetics, hypertensives, those at risk, obese, sedentary, stress, family history. But still, it is worthwhile that please get yourself screened for CKD. Are you vaccinated? Proper postmenopausal care. And last of all, are you happy? So ask yourself these questions for prevention of chronic kidney disease, and learn to speak up. Another important thing, ask yourself. We know that nature is a definite thing. Girl is a girl, boy is a boy, but nurture is just as powerful, and it can really, really mess with you. Do you yourself, you ask yourself, do you differentiate between your son or daughter? Do you differentiate between your daughter-in-law, your son-in-law? Ask yourself that question. Do not differentiate. Nature is different, but nurture is much more powerful. So ladies and gentlemen, there are no gentlemen, I guess. So ladies and more ladies, I'll end by saying that what defines a woman is not whether she bears children, whether she has long hair, the perfect curves, society's ideals, how feminine she is, or if she likes to cook. What makes a woman is her essence, her strength, her resilience, her loving way. It's what is there in her mind, heart, and soul. She defines it. Ladies and gentlemen, women are unique. They multitask. They are beautiful. They bring color to life. They also suffer. Let us give them the respect they deserve. Let us first learn to respect ourselves. So thank you, ladies and gentlemen, for a very patient hearing.
Thank you so much, Dr. Manisha. I think your lecture was an eye-opener to all of us women. And we have seen that women are disadvantaged in many ways where kidney is concerned. And may I suggest that you spearhead a movement in India to make women safe in where kidney is concerned. And we can join you where heart and lipids and many other NCDs, so we can be together in this movement.
Sure.
So we'll move on to the next topic, which is optimal glycemic control in a hospital setting. managing hyperglycemia in critical and non-critical care. And we request Dr. Beatrice Ann to kindly share your slides so you can be introduced. Yes, so she's an endocrinologist, associate professor in the Department of Endocrinology at NIMS Hospital, Hyderabad. And wow, she's been a gold medal in the DMO and DM endo examinations. She's also got the API gold medal in medicine. She's on the editorial board of the Indian Journal of Cardiology, is it? Or in the Journal of Cardiovascular Disease in Women. She's also got 20 national and international publications, and she's author of many books. So she's got a lot of merit behind her. And may I request her to kindly start your talk?
Thank you, ma'am, for the kind introduction. A very good afternoon to all. So over the next few minutes, I'll just be talking about glycemic control in the hospital setting in both the critical as well as in the non-critical care settings. So the meeting objectives is basically to understand the burden of inpatient hyperglycemia and to understand what are the current management and recommendations of inpatient hyperglycemia management, and to understand the preferred choice of insulin in the management of inpatient hyperglycemia. So generally, anti-hyperglycemic therapy in the hospital setting, we prefer insulin. OADs are in fact cautiously used, not generally recommended. We would like to use insulin and either IV insulin in critically ill patients or subcutaneous insulin in non-critically ill patients. So what is the burden of hyperglycemia and critical care? So first I'll be talking about the critical care setting and then the non-critical care setting. So what is the burden in the critical care setting? So before that, we'll go on to a few definitions. So any blood sugar which is more than 140 milligram per deciliter will be taken as in-hospital hyperglycemia. And stress hyperglycemia is wherein the patient's hemoglobin A1C is less than 6.5%. So there's no diabetes as such, but whatever the stressful conditions, either infections or just admission in the ICU, that is going to cause an elevation in the blood glucose level. So that we will take it as stress hyperglycemia. And A1C level of more than 6.5% detected for the first time in the hospital, probably undiagnosed diabetes mellitus presenting to us with probably an infection. And hypoglycemia is any blood glucose which is less than 70 milligram per deciliter, and severe is when the blood sugar is less than 40. So this is a fact which has been shown in consistently in almost all of the studies, that hyperglycemia is associated with increased mortality in critically ill patients. And as we see here, as the blood glucose increases, there is going to be a parallel increase in the mortality. So this is something which is known. And how do we manage patients in the critical care setting with hyperglycemia? So we have had actually two important trials. Of course, there are many trials on this, but I'm going to focus on two important trials which have given us some perspective in the management of inpatient hyperglycemia in the critical care setting. So the first was the Leuven surgical trial and the medical trial, in which they have looked at or they have actually divided the patients into two groups, the intensive control arm and the conventional blood glucose control arm. So the intensive control arm, they have targeted a blood sugar of around 80 to 110, and the conventional arm was around 180 to 200. And in this study, which was done earlier actually, which then the nice sugar came much later after that. So the Leuven surgical and medical ICU trial, this showed that the mortality was in fact lesser in the intensive control arm. But the trial has its own concerns in that, in fact, in both the medical and in the surgical ICU, in both these group of patients, in both the intensive treatment arm as well as in conventional treatment arm, they have given around 200 to 300 grams of glucose in the first day of ICU admission. So in fact, the mortality rate as such, even in the control arm, was found to be much higher than in the other studies. So the findings of this study have to be taken with a pinch of salt. And then we have the nice sugar study, which gave a better perspective of the difference between intensive and conventional glucose control in the ICU setting. So this nice sugar study enrolled around 6,000 odd patients, medical as well as surgical, and they divided the patients into the intensive glycemic control arm and the conventional. So the intensive, they targeted a blood glucose of 81 to 108, and the conventional is around less than 180 milligram per deciliter. And they found that there was a significantly higher death rate and a higher incidence of severe hypoglycemia in the intensive glycemic control arm. So many of the guidelines now, and in fact even ADA consensus statement on inpatient glycemic control, they recommend a blood glucose target between 140 to 180 milligram per deciliter in the ICU settings. So this is the targets, in fact, and generally we do not want the blood sugar to fall to anywhere between less than 110, and at the same time we do not want to relax it either. So we do not want a blood sugar of more than 180. But of course, if you have an elderly patient or severe comorbidities, you can relax the upper limit a little bit. So we have many protocols for IV insulin infusion. So I'm sure all of the institutions are going to have their own protocol, and in fact every institute should have their own protocol because there will be uniformity across all the departments then. So what is the choice of insulin? So before that, we'll see how we transition from the IV insulin to the subcutaneous insulin. So how do we do that? So we look at the average of the average dose requirement over the last 6 hours, and then we take only 80% of that to be the total daily dose, and then we have divided that into 50% of basal and 50% again to be divided into prandial, divided into three prandial doses. And on top of that, you can also give the correctional doses. So this is how we usually transition a patient from IV insulin to subcutaneous insulin. So what could be the choice of insulin? Of course, we have always the debate whether the regular insulin is better or the analogs are better. So most of the studies have shown that efficacy wise, there's not much difference between the regular insulin and the analogs, but the analogs by their capacity to mimic the normal insulin physiology, or so they do have a lesser incidence of hypoglycemia, and the other advantage is that we can give the analogs 5 to 10 minutes before their meal rather than waiting for half an hour. The lag time required is more in case of a conventional or regular insulin. So this is a particular study which looked at IV aspart in critical care setting. This is the Indian evidence here. So most of the patients did reach their targets of 140 to 180, and not major hypoglycemia events were reported in most of the patients, and there was quick achievement of target blood glucose, and it was very safe to use in that the hypoglycemic events are lesser, and there's also ease of switch from IV to subcutaneous. So hyperglycemia in critical care, to summarize, the consensus recommendations, they suggest a target blood glucose of around 140 to 180. And of course, in these, we do prefer analogs compared to regular insulin. So because of the reasons I had mentioned earlier. So what about the non-critical care? So we do know that in general, patients with diabetes, they have a higher risk of hospitalizations. And when they do get hospitalized, they have a higher risk of mortality as well. So there's almost 2 times more in patients with diabetes as compared to somebody without diabetes. And this study has looked at the different causes of death in patients with diabetes. And the most common common cause of mortality here was a vascular disease followed by infection, then renal failure and malignancy. So this, just like in all the other studies, even in Indian studies, hyperglycemia in non-critical care is associated with adverse outcomes and increased mortality. So how do we manage, or what are the first? We'll look at the glycemic targets for non-critical care patients. So it's the preprandial, we want to target to less than 140, and any random blood sugar should be less than 180. So it's almost the same as critical care. 140 to 180 is what we target. And again, this can be relaxed in elderly and those with severe comorbidities. So again, this is a subject of much debate, the sliding scale versus the basal bolus regimen. Many people still use the sliding scale, but it is outdated and it is to be discouraged, because this is not physiological, and we have a roller coaster phenomenon of the glucose. So it's more like a knee-jerk reaction. So you have a high blood sugar and then you give a shot of insulin. You wait for the sugars to go up and then again give a shot of insulin. So this is not physiological, and it will not help us in predicting the insulin dosage requirements as compared to a basal bolus regimen, which has a superior efficacy, and wherein we have a basal dose and we also give a bolus to cover the prandial increase in sugars. And if the sugars are out of target for whatever reasons, patient could be on steroids, patient could be having underlying infection, so we could always add on a correctional insulin as well. So this brings down the sugars better, and we have better outcomes with this basal bolus regimen compared to the sliding scale regimen. So the pharmacokinetics of different insulin preparation is something which is well known to this audience. So just to highlight, the regular insulin, the onset will be around 30 minutes, and it has a peak, and the duration of action is around 6 to 10 hours, as compared to an analog which will start acting by 5 to 15 minutes, and which has a peak around 1 to 2 hours and the duration of 4 to 6 hours. This mimics the physiology better than the regular insulin. And we have the fast acting insulin aspart, which is approved now for use, and this starts acting 5 minutes earlier to aspart, and it has 11 minutes earlier peak than aspart, and it has a 10% smaller late glucose lowering effect compared to aspart. So basal insulin, we know the peakless insulin, the glargine and the degludec, out of which degludec has the longest half-life. So we look at the basal insulin analogs, a choice of basal insulin analogs in the inpatient setting. So we have had various studies which looked at the regular insulin combination along with the analogs. So this is a basal bolus regimen was compared, where glargine plus glulisine was compared with NPH with a regular insulin. And they found that the severe hypoglycemia was more common in the human insulin arm compared to the analogs. And there's also studies looking at the efficacy and safety of the different basal insulin. So they've looked at detamir versus glargine. There was no difference in the inpatient glycemic control and rates of hypoglycemia in both the arms. You have to give more nominations. And we look at degludec, where in inpatient settings, where most of the patients, around 78% of the patients, do achieve their mean blood glucose target of less than 180, and by virtue of its longer half-life, there is lesser risk of nocturnal hypoglycemia and a better blood glucose, fasting blood glucose reduction, and the degludec arm also showed lower glycemic variability. So how does insulin degludec address the challenges that we face in the management of inpatient hyperglycemia? Some of the challenges that we face, one could be a reduced uncertainty in food intake. Probably patient could be having nausea, vomiting. So this could lead to high glucose variability and higher risk of hypoglycemia, which could be taken care of by degludec, by the flexible dosing and the lower glycemic variability and the lower risk of hypoglycemia, especially nocturnal. And when we have patients with diabetes, it's just not only diabetes. We could be having comorbidities like CKD, hepatic impairment, where they could be prone for hypoglycemia. We can have the elderly and frail individuals, again, with an increased risk of hypoglycemia. So here, degludec is a good choice in that it has a lesser hypoglycemia risk, I would say. And in hospitals, especially in settings where there's going to be an increased load of patient to nurses, where the patient may not take, or the nurses may not be able to administer the insulin at that particular set time. So this again, it can be overcome by insulin degludec in that it has flexible dosing. So the rigid dosage regimen can be overcome by the degludec doses. And what about the bolus doses? Again, I had mentioned earlier that the efficacy is almost going to be the same between the regular as well as the analogs, but the analogs, they have lesser hypoglycemia and they mimic the physiology better. And in this particular study, it's been shown that the maximum blood glucose is lesser in the analog arm compared to the regular insulin. And the mortality rates also seem to be better in the analog arm as compared to the regular insulin arm. And now a look at the faster acting insulin aspart. So usually the regular insulin is administered 30 to 45 minutes before meals, and the analogs like aspart, glulisine and they have to be administered 0 to 15 minutes before the start of a meal. The advantage of the faster acting aspart is that it can be administered up to 2 minutes before the start of the meal, or in situations where the food intake may be erratic or you do not know how much the patient may take. So in those conditions, the faster acting aspart has the advantage that it can be administered even up to 20 minutes after a meal without compromising the glycemic control or the hypoglycemia risk. So this is the advantages of a post meal dosing. So this is more convenient for once, and the second is that it reduces the risk for hypoglycemia should a meal be delayed, and it is particularly useful for elderly patients who could be having irregular eating habits, or for those people whose eating behavior is known to vary considerably. And these are the challenges, the same challenges that we face with inpatient hyperglycemia. The same challenges can be addressed with regard to bolus. The challenges addressed by a faster acting insulin aspart is that there could be flexible dosing, in that the insulin can be administered even after a meal, and no dose adjustments are required in the elderly or renal or hepatic impairment, and it is approved in pregnancy, and like mentioned earlier, it has a flexible dosing. So to summarize, we do know that poor glycemic control is associated with higher risk of mortality and morbidity in critically and non-critically ill hospitalized patients. And like I mentioned earlier, we know the advantages and the disadvantages of using an analog versus a regular insulin. And of course, a combination of degludec with an analog, a faster acting aspart could be a very good regimen in hospitalized patient, barring the cause. So with that, I thank the organizers for giving me this opportunity, and all of you for the patient listening. Thank you.
Thank you so much, Dr. Beatrice. I think you have very elaborately told us the critical care management in the ICU. So I think we can just ask one question each of the speakers. So may I request Dr. Ramya or Dr. Ismail to please ask a question to any of the speakers, or yeah.
I thank you, the organizers, for giving me this opportunity. It was an excellent discussion, starting from primordial prevention till menopause. It's a long journey a woman has to go through, starting from womb to tomb, as was already described. And we had great sessions from yesterday. Just summing up from my cardiology point of view, just repeating the words of Dr. Mary Cruz, who described the 3 C's and the 5 steps for lifestyle management for prevention of achieving a healthy life, that is maintaining the a good diet, and then reducing the alcohol intake.
I think there's little noise in the background.
मल्टीग्रेन मैंने प्रोग्राम देखा इंडिया में चलेगा ये ब्राउन करने का थोड़ा सा उसके अंदर वो कैरेमल डाल तो ब्राउन हो जाता है इसमें डालते हैं
I think Dr. Lily, can you please request Mintu? Yeah. Yes, Dr. Ramya.
Yes, ma'am. So actually, this is a great opportunity for me to meet my old teachers. Dr. Kiran Mai and Dr. Manisha Sahai, ma'am, have been my teachers in Usmania. And it's great, ma'am, to see you after a long time. And Dr. Tripti, ma'am, is a regular teacher for me in Apollo. So it's a really great opportunity for me to meet everyone here. So we have seen the wide range of non-communicable diseases, starting from anemia to very dangerous life-threatening conditions like heart diseases, stroke, CKD. And as the logo goes for this Eva Stride, this is a safe journey to womanhood. So we have seen various talks how we can take every opportunity to encourage preventive measures, starting from early childhood to menopause, to reduce this pandemic of non-communicable diseases, especially ischemic heart disease, stroke, and CKD. So all these conditions are preventable. And so various speakers have explained in detail. And just we can conclude with the big 5, as was described by Dr. Mary ma'am yesterday, that how we can prevent these non-communicable diseases, that is maintain an ideal body weight, encourage a healthy diet, ensure we walk more and do exercise for at least more than 30 minutes per day, and encourage non-smoking and moderate alcohol intake, And finally, what Manisha ma'am said, let us all take care of our health and our family's health, including kids and parents, so that we can ensure a safe transition of women from childhood to later part of life. Thank you, ma'am, for this opportunity.
Thank you. Dr. Beatrice, I have a question for you. We know that with all the efforts of giving multiple doses of insulin or IV insulin in an ICU setting, we cannot reach optimal glycemic control most of the time. So would you suggest adding OHA like DPP-4, where work by Ampères has been done, where he has shown that the glycemic variability decreases in the ICU when with the addition of a DPP-4 along with insulin in critical patients?
Yes, ma'am. Thank you for that question. In fact, it's a very relevant question because, like you had mentioned, even with the multiple insulin dosing, the basal bolus, correctional doses, it's very difficult to, in fact, achieve those targets of 140 to 180. And even if you look through the ADA guidelines, they do mention that, studies are there that gliptins, when added, they do bring down the blood sugar and help us achieve the target. And this particularly I have noticed now during the pandemic times, because most of our patients are on very high dose of steroids. So we actually have an institutional protocol where we do give the basal bolus and we give the NPH insulin as well to cover the steroids. And in spite of more than 100 and 120 units of insulin per day, we have difficulty in reaching the targets. So we have added sitagliptin to our patients, and we have tried, and it really works. So we are able to reach targets with an addition of a gliptin.
Thank you. And a question to Dr. Dev. Ma'am, you said actually women have more heart failure and also they have plaque erosion. But when we do the echocardiograms, we see diastolic dysfunction in many of our patients.
Yes.
Since the women are disadvantaged, would you advocate adding an SGLT2 inhibitor at an early stage when you see diastolic dysfunction only so that they do not go into overt failure? What is your experience, ma'am?
Yes, Dr. Benny, it's a very good question you have asked. And diastolic dysfunction and the relaxation properties of the LV comes down in a woman who is obese, who is diabetic, and who has got metabolic syndrome in a very early age, actually. So it's a very good question about very early diastolic dysfunction, and they become, they can't walk because of the breathing difficulty they have, SOB and, dyspnea on exertion. So these women can be prevented to have early diastolic dysfunction by lifestyle modification, weight reduction, and metabolic syndrome, catching them early and bringing them, reversing their metabolic syndrome if possible. That is the first line of treatment. And of course, SGLT2 inhibitors are coming in a big way towards the diastolic dysfunction and not yet approved completely. Still the, the EMPA-REG, diastolic dysfunction, this research is going on. The studies are still going on. The multi-center trials are still going on in the prevention of diastolic dysfunction and treatment of diastolic dysfunction, yet not completely approved, but women has shown to some extent better response than men. And then coming to these MRAs, that is mineralocorticoid receptor antagonists, they also have shown to some extent a better response in Canton trials, and some of the trials, they have shown a better response for the diastolic dysfunction prevention and the reversal, but nothing like metabolic syndrome reversal if that can be taken care of by good lifestyle modification. And these are the challenges we face day to day for our not only elderly women or menopause women, even our young women also. They are becoming now metabolic syndrome very high in the early stages, even teenage also. And we see them having diastolic dysfunction in a very disadvantageous age when they should be playing around, and they are just sitting and they are sedentary. So it's a very good question, and it's a wide spectrum, and we have to take this challenge in our future armamentarium of treatment, along with medications plus lifestyle. Thank you so much.
Thank you so much. Dr. Ismail, do you have a question? Sorry?
Hi, Mary.
Hi, Dr. Dr. I'm very depressed.
I just want to know that the ladies post-COVID complaining of breathlessness, one kind being in one flight or two flight of stairs. And not diabetic. Maybe it's like any, but they have suffered from COVID. Doctor.
Your sound is not very clear. I couldn't get the complete question.
Okay. Just wanted to ask the ladies suffering from COVID.
Voice is getting
recovery.
Voice is
Can
breaking.
you hear me?
Breaking, Tika.
Yeah.
Can you hear me now?
Say again.
Okay,
No, I think there's a mobile phone next to your laptop because there's a disturbance.
No, I'm only on the mobile. No.
There's a disturbance somewhere, but we cannot follow your sentence.
Okay.
I think madam is asking about post-COVID complications, ma'am.
Right. A lot of post-COVID myocarditis, I think, related to this breathlessness. So, any specific you have noticed in terms of treatment?
Post-COVID myocarditis, madam? You want to know about that? Or you want to know about post-COVID relationship with the heart failure?
Yes.
Yes, there is a subset of, yes, definitely there is a subset of patients where there is a myocarditis, and post-COVID there are a lot of implications on the heart. In fact, we have a stress myocarditis during COVID, and that has been shown to 20 to 25% of patients who present with heart failure. They would have a stress myocarditis without any coronary anatomy, coronary blockages. That is one part of it. And during COVID, they have very high thrombogenicity. The thrombotic factors are very highly prevalent, and they, in spite of our giving them blanket treatment with the anticoagulants like low molecular weight heparins and heparins very frequently, still they develop coronary blockages, that means clottings, and the pulmonary blockages, that is clotting, and the pulmonary embolism, the D dimers are very frequently high, and we find them having major or the minor or the subsegmental pulmonary blockages also. So these are all the causes of the breathlessness. So stress myocarditis, coronary events, then myocarditis, muscle damage. So all kinds of prospective problems could be there in the COVID, and which is a wide spectrum of problems with the muscle damage to the heart muscle as well as to the lungs parenchyma. Because not only because of the SOB after the COVID, I have been seeing very clearly and very regularly. I have been getting calls, even online calls also, because the post-COVID recovered patients, they are not only getting the SOB in the initial stages, but during recovery phase also, and long COVID syndrome where they are getting it even after 3 to 6 months later also. So these are all very many factors, and they are not only one factor which is causing this. There are all the organ systems which are involved, and there is so many explanations have been given, and there are so many possibilities and so many outlooks into that. And not only that, lung fibrosis, there's so many things which are going on into this. So we have to understand this long COVID syndrome, and it is a challenge for the treating physicians and the caretakers. So we have to be very careful about understanding and investigating, and then getting into the real crux of the treatment and treating them. Thank you for a nice question.
Thank you.
Yeah, Dr. Ismail, do you have any question for?
Yes, ma'am, for Manisha. Yeah. Manisha, that was an excellent lecture and very inspiring one as well. But what do you recommend? What are the measures you recommend to dissipate this gender inequality in the nephrology diseases or the practices? Manisha.
Is Dr. Manisha here?
I
think she has to be unmuted.
No, she knows that, but she's not there.
Yeah, I'm there. Yeah, what is it? Yeah. Yeah.
Please repeat the question.
Manisha, it was an excellent lecture, very inspiring one as well. But as a council member and senior faculty, what are all the measures you want us to do or to dissipate the gender inequality in nephrology?
Yeah. So thank you, Kiran, for being there on a Sunday, and thank you for all the nice words, and thank you for being such a great friend. And we have been together for such a long time. Now, to answer your question, the question is very pertinent, and I think we should first look at ourselves. Both you and me should also look at ourselves, which we don't do. So charity begins at home, and I think we should start from our health, and then apart from that, I think that involving the community, engaging the community is very important, and that's the motto of the International Society as well as motto here. So I think it would be nice for us. The way we have been doing on World Kidney Days, going to school, promoting school health, promoting healthy lifestyles, and going to the colleges, the teenage girls, the adolescent girls. So I think that would be the time to catch them young. The other thing would be to this is my passion, that we should prepare modules for everyone. So I think we should now talk across specialities, which is the beauty of this conference. Otherwise, what happens is we just end talking to only our specialty. So I think we should talk across specialities, and nephro module for a physician, nephro module for a gynec. Similarly, gynec can have a gynec module for the nephrologist, or maybe for the physicians. So do's and don'ts, the myths and facts. So the module should not be very extensive or exhaustive, just practical tips. And these can be online modules. Anybody can pre-test, do a post-test, and get this thing that I have cleared this module. So because I would love to see that all patients with kidney disease, men or women, are screened for kidney disease. That's the whole point here. We receive the kidney patients in the last stage of CKD, last stage of ESRD. So if the message gets across, early screening, be it men or women, though the talk was on gender, early screening, and especially in high risk groups, especially if you are above the age of 40, I think even you should undergo a screening for ruling out CKD. That's just looking at the urine protein and the GFR, which both you and I know is very much neglected. So I think if we can achieve that, that would be a great thing, and that would be a beginning. Thank you.
Thank you so much, Dr. Manisha. Yeah, I agree with you completely. We have to start from ourselves. And just like Eva Stride, we must thank Dr. Lily Rodriguez for having this interdisciplinary talks, so that we know more and more about less and less. And with this note, I conclude the session today. Thank you, everybody, for all your wonderful inputs. And we have learned a lot in this section. So I won't mention all the names, but all of you here on this view, thank you so much. And Dr. Lily, a special thanks and a big clap for your excellent conference.
Thank you. I thank you, Dr. Benny, for that wonderful conclusion of your session. We are still to stay on. We have the last speaker on this entire forum, who is going to talk to us about her own life journey and probably enlighten us through all that we have talked from yesterday to today that she has experienced in her life. I would now like to call upon Dr. Sureka B. Shetty, who is a consultant diabetologist, who has done her MD in internal medicine and MSc endocrinology, and works at the Karnataka Institute of Endocrinology and Research in Bengaluru. I do not want to make you wait for a long time. So it is she who is going to take the screen now. Dr. Sureka. Dr. Sureka? Unmute. Unmute. Mintu? We cannot hear her.
Hello. Ma'am, are you able to hear me?
Yeah, we are able to hear you now. We are able to hear you now. I think don't use the earphones and all that. With the earphones, sometimes there's a problem and we were not able to hear you at all.
Yeah, now you're able to hear me, ma'am?
Yes, we are able to hear you now.
Let me begin again. I think it has been my privilege to be part of this seminar, and I've been lucky to hear to such wonderful talks. Especially, I was motivated by what Dr. Manisha Sahai said about being the woman of virtue and so many other virtues that she spoke about. And I think for me, it is a bittersweet moment to be talking today about my journey with type 1 diabetes as a professional who provides medical care for people with diabetes. Of course, it's a story of 24 hours a day, 7 days a week, and 365 days a year. And probably, if you're willing to listen to me, this 8 minutes would not be enough. But let me try to keep it as precise as possible. Uh, the day of my diagnosis, it is something that I remember even after 25 years. I was diagnosed on January 9th, 1994, at the age of 16. What I would like to highlight here is that I went through the symptoms of polyuria, polyphagia, and polydipsia for almost a year before being diagnosed. What exactly happened? Uh, Polyuria and polydipsia were something that I did not express myself, being an introvert, to my parents. Weight loss was something they noticed. They took me to three specialities: a physician, a gynecologist, and a ENT specialist. None of them thought of type 1 diagnosis, type 1 diabetes as a diagnosis for my acute illnesses. Finally, on January 9th, I was admitted to hospital with DKA with a blood sugar of 420 and urine ketones 4 plus. The person who took me to hospital was my elder brother, who was a third year medical student and probably who was the one who made the diagnosis. He had just finished his exams, and probably being a bookworm, he never noticed that I had lost weight. And the day he finished exams, he called me into my room and asked what was wrong. And I first time opened myself and said I was passing a lot of urine, I was drinking a lot of water, eating a lot of food. And the diagnosis was very obvious to him. I could see his expressions change. The next day, we went to a physician and the symptoms were discussed. The test was done, the blood sugar was high. I was admitted to hospital. And while climbing the stairs of the hospital, my brother told me, "Don't worry, right now we'll be admitted for stabilization. After that, everything is going to be okay." A brother who is 4 years older to me telling me that somehow reassured me. And I was there in the hospital for 7 days. And if you look back 26 years ago, the therapy for type 1 diabetes in a small place like Davangere may not have been very accurate. I was on NPH 40 units per day in the initial phase. Maybe because it was a honeymoon phase, my sugars were not very badly controlled. Then I moved to Bangalore, met specialists, took treatment from them. And since then on, I think I have been on the path as a uh, person with diabetes. I was able to control my blood sugars very well and maintain it throughout the journey. As I told you, the early days were not so easy. My parents were upset. My parents were heartbroken that their only daughter had to go through this diagnosis. And I could see my mother cry every day morning for at least 15 days. But then she picked it up and she thought it was her responsibility to guide me through this difficult journey. And since then, she has been there for me, helping me out with understanding and following the rules of diabetes management. So also my brothers, I have two elder brothers, both of them professionals. One is a cardiologist and the other one is a software engineer. And I can still remember after my diagnosis, they stopped eating chocolates or sweets. There were no sweets made at home because our diabetologist had told us that everybody in the home should eat the similar food to avoid the child being upset, and that was followed at my home. I could say that though it was my journey, though it was my fight, my family was fighting it for me. And I think that helped me cope up with this disease better than many other children of my own age. So I learned this art. What I tell my patients nowadays to how to live well with diabetes. So there were 10 processes involved to understand the disease process. I was in the hospital admitted with diabetic ketoacidosis, and my brother bought me a Harrison textbook and opened the chapter on diabetes and said, read this. And the first statement I read was diabetes is a group of diseases characterized by chronic hyperglycemia. I couldn't understand a single word of it, but it still remains in my mind. So, my first step was to understand the disease. My second step was to set a goal for myself. How did I want to see my health? My health became my first priority. My dietary management was very well guided by my mother. I was a physically active child, and honestly speaking, I never missed my medicine. I don't think in this 25 years, 26 years, I ever refused to take insulin. Even as a girl of 16 years, I never, because somehow I felt that that insulin kept me alive, and I was motivated. We moved on from once daily injection to twice daily, then thrice daily. Now I'm on basal bolus. I never felt bad about pricking myself, and monitoring. Even today it goes on 4 times to 6 times daily monitoring of blood glucose levels, and my target has always been preventing the chronic complications of diabetes and living well, adjusted psychologically to this disease or whatever you want to call it. But there have been challenging times. So hopefully, I have driven through them very well. Luckily, not many episodes of hyperglycemia I have been through. No hospitalization due to decay. But yes, as the time has been passing with 25 years and very strictly controlled diabetes, I go through several episodes of hypoglycemia, which I am able to manage well. I have had my own share of fun with my friends, my family, my colleagues. I've been able to do all the activities of daily life that all my peers have been able to do throughout my college and my profession. What made the difference? Everybody thinks diabetes is the leading cause of blindness, amputation, kidney disease, or heart disease. But for me, it is the leading cause of courage, self awareness, persistence, maturity, enlightenment, understanding, compassion, and so on and so forth. So, if you look at it, this approach towards my life is something that has made difference to me and my life. Uh, I've been able to focus on my health and also my life equally well because I've been focused. I always tell my patients that it is D for diabetes and it is also D for discipline. Any subject with diabetes, if he leads a disciplined life, I think he or she can achieve overall best health and also lead a normal life. Long ago, 26 years ago, I decided to look beyond the obvious. I reminded myself that I'm not just my diagnosis, I'm just like everyone else, just a few extra struggles. Yes, of course, the struggles are not very easy. Uh, I used to tell my friends that you study the whole night before the exams, but I'm not able to study the whole night. And I also fumble during my exams because of few issues, but that's okay. Those extra struggles, maybe it makes me a better human being and more empathetic towards my patient's diabetes status. That does not make me weak, it only makes me a fighter. And despite what I have to deal with, I'm still here. I have a purpose. I'm smart, I'm funny, loving, understanding. And probably this is something that my own patients also recognize. They say that you have an ear to our issues, and that ear I get from my own experience with diabetes. Many times I feel when patients talk to me about their own issues, I feel, yeah, I have also gone through this. So my goal in life is something that is motivated by a saying by R.D. Lawrence. He once said, the person with diabetes must be his own doctor, biochemist, dietitian, and nurse. And this was something that my brother told me when I was in my second PUC. Uh, After being diagnosed with diabetic ketoacidosis and going through my 10th exam, somewhere I lost my focus on my studies. Though I was studying, I did not have an aim. And I almost spent 1.5 years just reading. And when the second PUC exams came near, my brother again called me and asked me, "What are you planning?" I said, "I don't know." And he said, "If you fail today, there will be many people who will sympathize you, who will understand that because of your diabetic status you are not able to give your best, but 10 years down the line you will be left alone with your failure. Don't let that happen to you." And this was something that made me realize that I need to get out of that diabetes mode, and I need to work on my abilities, overcome my shortcomings, and give my best. And that's how I ended up doing well in my second PUC exam, achieving 96%. And uh, I got a state CET ranking of 171 and was able to join MBBS in Davangere Medical College. And from there on, I went on and did my MD medicine from Bangalore Medical College with a state ranking of 5th. So somehow I always needed a push to be reminded what I'm capable of. But I think despite of diabetes, I was able to achieve that with support from my family. Just like many of these people who, despite being type 1 diabetics, have achieved their base abilities, I always reminded myself that diabetes need not stop you. And diabetes only is just a part of my life. The rest of the things, I need to prove myself, I need to work up. That is what I kept telling myself. And so today here I am, having completed my MD medicine from Bangalore Medical College in 2006, and then worked as a senior resident in endocrinology in MS Ramaya Medical College for 3 years. Followed it up with MSc Endocrinology from Southwell University. Currently working as associate professor in Karnataka Institute of Endocrinology. And I've been very active in academic and conference field, giving multiple talks. And it's indeed a pleasure to be a part of this seminar as well. And I have Dr. Lily Rodrigues to thank so much for that. Last but not the least, if I'm here today, it is only because of my family. Sorry. And here they are, my parents, my brothers, and their extended family, and my husband. I must say, sorry. I must say it is with their support and daily encouragement that I'm able to do this. Thank you so much.
So that was Dr. Sureka. Thank you so much for taking us through your life journey. And I'm sure it was definitely a motivational talk. I'm sure everybody agrees with that. And
yeah, I just want to say that we need to salute her actually.
Yeah.
For really coming up so well in life, in spite of all problems, which goes to show that you have to live well with diabetes by understanding the disease. Really congratulate you, Dr. Sureka.
Thank you so much, ma'am. That is what I keep telling all my type 1 diabetic subjects, that don't let this stop you. You are what you are. Please go ahead and live your life.
You have a lovely daughter.
She's here. She's actually here waiting for me. But she's very naughty, so I did not let her inside.
Okay. Thank you so much.
Thank you so much, ma'am. I loved all the talks that I was able to listen to. It was wonderful. It was a wonderful arrangement, and I think very enlightening too.
Thank you.
Thank you so much, Dr. Lily, for such a beautiful arrangement and for everything went in spot. Everything was so great, and the entire sessions, in fact, the non-cardiology part of it and the entire gamut of, academic feast, I had a real enjoyment and a wonderful time listening to all the best speakers, I must say, from abroad and from India and from across the world. You can say you have done it so well, and so much of inputs, so much of your extra work, and so much of You have done so extra, means so much of. I remember first time we met about a year back, more than a year back.
Yes.
That since then you have been planning, and see you did so well in this webinar. It's extremely appreciating, absolutely. It's really real appreciation. Thank you so much, Dr. Lily.
Yeah, Dr. Lily, I also second that. You are very dynamic, enterprising, and you are a born leader because you took the step to make a huge conference like this, which is your second annual conference. And I really wish you well for future years. We would like to be a part of it in future as well.
Sure. Definitely.
Thank you so much.
Yeah, Dr. Lily, congratulations from my side as well. This was one of the most wonderful conferences. I'm in with so many different speakers, and I'm in all the women-related topics. So we are fed up of listening to kidney topics now. So it was so good. I mean, across specialities, and all topics were relevant to us, and we can do better justice to our patients as well, because pearls of wisdom, the diet and everything, I mean, are really great. Congrats for a wonderful, wonderful job, and hope you have similar conferences in future as well. All the best. Good job. Superb. Wow.
Thank you. Yeah, this year, even though it was planned to be, we had planned to have a physical conference. I was just hoping against hope that pandemic will stop and we would have it before December, but it did not look like it. So month ago, we decided, some of us sat together and we decided to have a virtual conference. So this, all that we have done from yesterday to today is an effort that was put together from last 30 days. Of course, we did decide on the topic about 10 to 12 months ago. Somehow it was kept in the cupboard, and then we suddenly woke up, and last 30 days we have put things together. And I can't thank enough Dr. Usha Sriram, Dr. Sarita Bajaj, and Dr. Benny, who is here, Dr. Beatrice, Mary De Cruz, Dr. Meeta, and Monica, who have been part of the scientific committee for putting things together, but particularly Dr. Benny, who I have been disturbing every night almost the last 1 week. And she has been a guiding force, just like Dr. Sarita. And Dr. Sarita was so particular, even the spell corrections and upkeeping of the timings was her main this thing. So she was so strict in the beginning. I almost nearly got scared in the beginning, but she was like a mother. She was like a guiding force and enlightening all of us. And you have seen how beautifully she has carried herself in this meeting. I am sorry that she is not here now. She had to go for another meeting, but I thank her from the bottom of my heart. And for Dr. Usha Sriram for making up to this meeting, despite her, she was supposed to be back in India, but unfortunately she's stuck in Chicago, and despite the time difference, she could make it, and I really thank her for the wonderful presence. And for we also, the entire goal of this meeting is to make a difference in us, our lives, as well as through us, bring a difference in our patients and community as a whole. So as Manisha so beautifully said, that we need to take action. We need to take action. We need to make some changes to the society. I hope in the future meetings, we would concentrate on some topics and bring about some modules and this different things, So we will plan, with your help. I can't do it. We can't do it alone. We as a group, we as women who are blessed, despite all our day-to-day activities, we are blessed to do something more. So next year, I'm sure we'll meet on a very different platform. And like last year, it was just a seed that was sown. And then we had very few participants. And that was conducted in October last year. And then this year, it has reached international. So you can see the interest that we as women have. And then we should do as women and bring about awareness in the community. So we hope that next year we will definitely reach another big milestone. And I thank Dr. Sarita for having roped in the international speakers particularly. Um, um, I also want to thank all the speakers who have put in their best in the last few days. We approached them, just 2 weeks back, and everybody was there ready to share their knowledge, share and put their best. You have seen what a class of presentation. Each one is better than the other, and so I really thank each and every speaker, without whom this conference cannot be a success. And coming to the delegates, this year we had more than 600 delegates. I don't know about exact number, Mintu knows that. So I know that there were more than 600 delegates as on day before yesterday who were registered for this. And yesterday there were about 300 who have presented themselves, who were present at the conference. So I think that's a big boost to all of us. And I also want to thank ExpoCon, Mintu, who is behind the screen, and without whose help this virtual conference could not have been held. And he has been a real silent force. He is a really wonderful human being. I could shout at him. He would just listen silently and not say anything but take action. So it was wonderful working with him. And in their team, I would especially regard, thank you, Mintu. In their team, I want to thank one Abdul Khalil, who was the designer of the entire brochure. It was his choice, of course, some corrections here, but he was there day in and day out. Even at 11 o'clock in the night, I could disturb him, and he has made the necessary changes. So I want particularly to thank him for this and wish him all the best for his work. So the last but not the least, as I thank each and everyone and wish all an amazing day ahead and year ahead, I also want to announce that we have certificates of participation for faculty as well as delegates, which will be present on the website, that is evastride.live. So you could visit the website. It will be made available from now after the conference is over. You can download your own certificates. And I thank you once again for having been here with me, with all of us who has been in the committee. Thank you very much.
Thank you. And we go back with a great feeling to come next year.
Yes. Thank you, baby.
Thanks, Manisha. It was so nice to see you. I really
She's
enjoyed your
firebrand.
talk.
She's a firebrand of Hyderabad.
Yeah. I know. That's why I told her she's a born leader. You're muted. Manisha, you're
muted.
Yeah. Muted.
Yeah.